And also I would like to welcome our e-poster committee team, Muskan ma'am and Ruksar ma'am. Without them, this scientific committee is very impossible. Welcome you all. Students also give flowers to our Akshata ma'am. Welcome them. Now I would like to call our judges, Dr. Ravi Shankar sir and Mr. Sendil Kumar sir. Please come on the dais, sir. The judging criteria will be given to you for the poster presentation. Yeah, sure. And I also would like to welcome the other faculties who have accompanied the students this far so that this event is possible. Please stand up, all the coordinators from other colleges. We would like to welcome you all. Thank you, ma'am. Thank you for bringing your students here and making this event happen. Thank you. Students, please. Before we start any event, we want the blessing of our God. So let us start this innovative program, and which is at the National CME, and we have to start with the God's blessing. So I would like to welcome Vaishnavi to sing a invocation song. Please welcome Vaishnavi.
शुक्लाम्बरधरं विष्णुं शशिवर्णं चतुर्भुजं प्रसन्नवदनं ध्याये सर्वविघ्नोपशान्तये श्रीविघ्नेश्वर विनायक वरप्रसादिसो गजानना श्रीविघ्नेश्वर वरप्रसादिसो गजानना श्रीविघ्नेश्वर विनायक 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 सुमुखने हेरंब एकदंतने सुरमणि वंदितने गजकर्णने सुमुखने हेरंब एकदंतने सुरमणि वंदितने गजकर्णने श्रीविघ्नेश्वर विनायक वरप्रसादो गजानना श्रीविघ्नेश्वर विनायक विनायक विनायक
Thank you, Vaishnavi. It was in such a pleasant and beautiful song. And I think we have got the God's blessings now. So please be seated. And I would like to call our Dr. Satish TJ sir on the dais to join the scientific e-committee panel to give the judgment criteria for the students. A small announcement for the e-poster students that the time limit for your presentation is 5 minutes. By 4 minutes, you will be hearing a bell. That bell will give you the instinct that 4 minutes are over. The last 1 minute is to wind up your session. Understood, right? So one by one, we will be calling your names so you can come and present your posters. But the time limit, you have to remember, it is for the 5 minutes, okay? The judges have got the criteria based on how you present, the presentation style, the content of your poster, and the scientific importance of your poster. Based on that, you will be judged, okay? So now I would like to start our e-poster presentation, which is from the scientific committee, And from the team of faculties, we have selected among 63 colleges. I repeat, the total number of colleges participated and the received number of posters received are 63. And among them, the scientific committee and the panel have selected 17 top students to present today here. So among these 17, the top 3 will be given cash prize. The remaining 14 students will also be felicitated with appreciation participation certificate. So you are all the winners. Participation is important than winning. So I wish that all the best for all the presenters today, and you can rock. This stage is all yours. Thank you. And before that, I would like to tell the details about our judges. Dr. Ravi Shankar sir, MBBS, MD, DM, he is a consultant interventional cardiologist at Apex Heart Hospital Private Limited, Tanjavur, currently working as consultant interventional cardiologist at Apex Heart Hospital Private Limited, Tanjavur. And our next judge, Mr. Sendil Kumaran Dhanakoti sir, MSc, PGDPT. He is a chief perfusionist and senior manager at Apollo Hospitals, Bangalore. He has presented numerous papers at both national and international conferences. He has won gold medal for the best paper presentation at ICCT 2015 at Hyderabad. So he have an experience to guide you all further for your future. Okay, thank you. I would like to start with the poster presentation. First, the presenter I'll call Mr. Adityan. Mr. Adityan G from Wales Institute of Science, Technology and Advanced Studies. His topic is on transcatheter paravalvular device closure. So let's begin. Time starts now.
So, hi, hello, good morning, everyone. So, first of all, I'm very thankful to the Sridev Institute for giving me this opportunity, and I'm welcoming all the judges, doctors, and my respected staffs and friends. So, first of all, let me introduce myself to you. I'm Adityan, studying BSc Cardiac Care at Wales University, Chennai. So, let's move on to the presentation. My topic is paravalvular device closure. So, what is paravalvular device closure? So, paravalvular device closure is a minimal invasive procedure to repair the leaks present beside the surgical valve replacement. So, simply, it's a leakage that occurs after the surgical valve replacement is due to the improper fixing of surgical valve. So, it has procedure like access retrograde. Retrograde procedure means it's access through the aorta, and anterograde procedure means it's access through the vein. And the techniques are aortic snare. And aortic snare means it's a type of wire. Yes, ma'am. So aortic snare means it's a type of wire that used to stabilize the pathway to reach the heart. So arteriovenous rail, it's also almost the same, and the basic methods are accessing the heart via blood vessel and typically in the groin. So advanced method using like specialized device like amplifier vascular plug 3, popularly known AVP3, and Acutec PLD. So the echocardiography of paravalvular device closure means transesophageal echocardiography, popularly known TEE, to guide the placement of a closure device to see leaks around prosthetic heart valves. So the risk factors are valve interference, stroke, endocarditis, cardiac tamponade, cardiac rupture, cardiac perfusion, device embolization. So the benefits of this paravalvular device closure, it's a minimal invasive procedure and it has fast recovery. So medications given to this paravalvular device closure, anticoagulants like warfarins. So anticoagulants means it's a clotting factor to stop the leakage, and direct oral anticoagulants will be given. So, and the medications, anticoagulants like warfarins to clot the leakage, and the direct oral anticoagulants will be given. So that's all. Thank you. Any questions will be asked.
A big round of applause. He has been selected among 63 presentations. So we'd like to thank you, Adityan.
Thank you once again. Thank you for giving this opportunity. Thank you all.
So good one. So which device you had used actually? Which device you have used?
Sir, AVP3, Amplet, sir.
Amplet 3. Is there any specially designed device for paravalvular leak?
Yes,
Are
sir.
you aware?
Yeah.
Are you aware? Did you read up? Is there any specific device for paravalvular leak?
I'm not detailed aware about that.
Okay, it's not available in India. Occlutech
Occlutech
PV.
PLC,
So Occlutech has a paravalvular leak device. So that leave that. So what is the main indication for closing paravalvular leak?
Sir, pardon?
Main indication. Do you close all paravalvular leaks? We do get some paravalvular leaks. Is there any reason why you should close them? Are you going to close every paravalvular leak or?
Sir, because already the surgical valve replacement will be there, but after the surgical.
So your perfusionist or your cardiac technology?
Cardiac.
Okay.
Yeah,
Okay.
BSc
Okay.
So that leakage occurs due to the improper fixing now, sir. So beside the side of the leakage will appear. So we have no benefits of that previous surgery. So we have to close that.
So you should be very careful with the choice of words. Don't say improper fixing. That's making an allegation on the surgeon. All right. So there are so many factors why paravalvular leaks can happen. But what is the indication? So there could be some leak. Is there any indication? So number one is failure. Number two is hemolysis. So when the leak happens, when there is a cardiac failure, it should be of a bigger size or it should be producing significant hemolysis. So only in those two conditions you close this one. Okay.
Thank you so much, sir. Thank you.
Thank you, Adityan. Now I would like to call our second presenter, Amgot Srikanth from Sridevi Institute of Allied Health Sciences, Tumkur, on the topic of endovascular aortic aneurysm repair, EVAR. Welcome, Amgot Srikanth.
A very bright good morning, one and all. Myself, Amgot Srikanth. I am from third year BSc Sridevi Medical College. So today my e-poster presentation topic is EVAR, endovascular aortic aneurysm repair. So why I selected this topic? Let's see the aim of it. As it is to investigation to surgical treatment for the abdominal aortic aneurysm. One is EVAR, endovascular aortic aneurysm repair, and OSR, open surgical repair. And let's go to the introduction of it. And EVAR was first described by the Charles Dubust in the year of 1950, and the EVAR was undertaken the Ukrainian surgeon in the year of 1987, and the EVAR was later publication by the John Carlos Parodi in the year of 1991. Before we are going to the procedure, let's see the indication and contraindication in the procedures. The indication, the patient with abdominal aortic aneurysm that are large, more than or equal to 5.5 centimeter in the men and the 5 centimeter in the woman. The rapid expansion in the aortic aneurysm is nothing but the affected segment which quickly growing. And the contraindications include the conical proximal aneurysm neck and the severe aortic angulation and tortuosity. And before we are going to see the procedure, some devices which we are going to use in the procedure, like Anuix, it's a type of Medtronic, and the zenith lobe profile, that is a type of Medtronic, and the excluder, the type of Gore, and the power bring AFX, the type is Lombard. Let's now discuss about the procedure. After the part preparation, the anesthesia will be given under the general anesthesia or local anesthesia, depends upon the patient conditions. And the puncture the both femoral artery and by right and left femoral artery by using the Seldinger technique, and the placement of arterial guidance and the sheath. The imaging to confirm aortoiliac anatomy. In the anatomy, the fluoroscopic guidance with the LAO aortic angulation image and the craniocaudal the view. Then the main body deployment. The main body deployment, the graft at the contralateral gate. The contralateral gate is nothing but there is a here there is a Y-shaped there. So one we can keep the right side. After that we can choose the left side of the iliac, abdominal aortic, the iliac presentation. Now the gate cannulation, the bifurcated. After that, everything done, the graft ballooning with the complaint and semi-complaint balloon, we can inflate that, and the completion imaging after it performed the aortogram to evaluate the endoleaks. Endoleaks is nothing but persistent flow of blood. And it is a very important part of the poster. Let's go to the conclusion. The conclusion is EVAR is a advancement technology and techniques is to continue the evolve expanding treatment option for the complex aortic aneurysm, and the EVAR providing benefit treatment such as reduce the morbidity and the foster recovery and the patient outcomes. Thank you so much to give a wonderful opportunity to showcase our talent and interest and e-poster presentation. Once again, thank you so much.
Thank you, Amgot Srikanth. It was an awesome presentation. I would like to felicitate Amgot Srikanth. Please. The question sessions can start now.
So that was really a brilliant presentation, actually. So you completed the topic mostly thoroughly. Most of the most valid things are given over here. So what is the most common long-term complication of AR?
Sir, endoleak, sir.
Endoleak is the most common.
The persistent
reason.
flow of blood, it will be endoleak. So there is a type
So that is the most common long-term complication of this one. So this was done by your cardiologist or vascular surgeon?
It's a vascular and cardiologist, but cardiologist we can like femoral artery.
No, this is this
was vascular, sir. Vascular.
No.
Sir.
So this is not a case presentation. Not a case presentation.
Sir. Case presentation, no, sir.
Okay. Right. Okay.
Thank you, sir.
Good.
Thank you, Amgut. Please come in between. Now I would like to call upon stage Mohammed Fasil S from Wales Institute of Science and Technology, Chennai, on the topic of mitral clip. A big round of applause for Mohammed Fasil. Please come.
Good morning, everyone. To present of all of you. Well, introducing myself, I am Mohammed Fasil from Wales University Institute of Chennai. Let's introduce my topic, mitral clip. Okay. Now, the mitral clip procedure is a less invasive, a catheter-based on therapies for patients with a severe MR who are not suitable candidates for the traditional surgery. The traditional surgery is the open heart surgery. Okay. What is mitral regurgitation? The mitral regurgitation is a condition where the mitral valve does not close properly, causing blood to leak backward into the heart. So let's see the methods. The mitral clip procedure is performed in a catheter lab with the patient under general anesthetics, guided by the real-time imaging fluoroscopy and transesophageal echocardiography. Okay. Next, see the methods of vascular access. A thin fibular catheters enter throughout the veins to grain or femoral vein, guided to the heart. Next, transpectal puncture. A small hole made in the wall separating the heart upper chamber access the left atrium where the mitral valve is located. Next, clip deliver. The mitral device is advanced through the catheter and positioned just above the mitral valve. Next one, grab the leaflets. The grab the leaflet is not
Yes, ma'am. Okay. The clip The clip grabs the leaflets mitral valve at the point of the great leak. Next one, assessment of development. The physician use TEE to confirm the correct position and to ensure significantly reduce the blood leakage. If the result is satisfactory, the clip is reels permanently faceted and leaflets together. Procedure completed. The catheter will be removed in the green. Next one, we see the risk factors. Risk factors is the vascular complications, bleedings, and cardiac complications. Next, cardiac tamponade, mitral valve stenosis, device-related issues, clip embolism, damage to leaflets, and stroke. Let's see the results. MR reduction. Clinical studies such as the COPT and expand trials have shows that mitral clip procedure can significantly reduce the severity of mitral regurgitations. In the expand studies, 99% of patients achieve MR reductions. Symptoms and improvements. Patients of the experience in immediate reduction in symptoms such as the shortness of breathness and fatigueness. Improvement functions status as measured by the New York Heart Association. Thank you.
Any idea what is the basis? Is there any surgical procedure that is very similar to mitral clip? For mitral regurgitation, what is the standard procedure? A patient comes with mitral regurgitation.
Okay, sir.
So what do? You subject, you know what is the cost of the procedure? You know what is the cost of this procedure?
Yes, sir. Shortness of breathness and fatigue. Okay.
Cost.
Cost.
25 to 30 lakhs.
Okay.
So you can understand what is the feasibility. So
Okay,
this
sir.
is not the most common procedure done for mitral regurgitation. What is the most common procedure done for mitral regurgitation? You're cardiac technologist, right?
Yes, sir.
Yeah. So what is the most common procedure for mitral regurgitation?
Open surgical.
What is it?
Uh,
MVR, mitral valve
Mitral valve
replacement or
replacement.
mitral valve repair.
Okay, sir.
You understand what I say? So only when the patient is inoperable or very difficult to do it, then where he is not fit for anesthesia or something, very old age or something, you consider mitral clip in those patients. The actual question is, this was actually developed from a surgical procedure that was called Alfieri repair. Alfieri repair, where they used to put a knot within the two leaflets. Is there any criteria to say this should not be done? This is not fit, echocardiographic criteria, where you cannot subject the patient to mitral clip. You understand my question? You cannot do mitral clip or you cannot do Alfieri. You have to do only a replacement. Is there any echocardiographic criteria? Contraindication. So what is the contra? So what are the contraindications you mentioned? See, mitral clip basically takes both the leaflets and put a clip inside.
Okay, sir.
So it keeps it in partially closed position all the time. For that, there has to be a coaptation. The gap, if it is more than 10 millimeter, or if the leaflets are really heavily calcified or something, then you cannot control this with mitral clip. You understand what I say?
Okay.
Are you able to follow what I say?
Okay, sir. Hold.
If the gap is really too much, you can't hold both of them with a clip. Between the two leaflets, if the gap is too much, they cannot be clipped. So the gap must be less than 10 millimeter.
Yes,
Only if the gap is less than 10 millimeter and an adequate length of the mitral leaflets. So all these things must be assessed by TE before subjecting them to mitral clip. Okay.
Thank you.
And a septal puncture, where do you get your septal puncture is extremely important. The area where you puncture, septal puncture for a paravalvular leak is very different from where you puncture for mitral clip. So if you are going to get too closer, you won't be able to get lower, you won't be able to do a PVL. You have to get a higher puncture. Here you can do a higher puncture.
Okay, sir. Thank you, sir. Thank you.
Please felicitate our Mohammed Fasil student. Please go there in between. Mr. Sendil Kumar and Dhanakoti, sir, do you have any inputs to talk to students based on these three presentations, sir? Yes, sir. Sure, sir. Sure, sir. Now I would like to tell and read out the list of colleges who have sent the posters. So the colleges are Frontline Lifeline Hospital International Center for Cardio, Thorax and Vascular Diseases, Chennai, Nehru Institute of Health Sciences, Coimbatore, Saptagiri Institute of Medical Sciences, Bangalore, Sri Venkateshwara College of Allied Health Sciences, Erode, SNS College of AHS, Coimbatore, Sri Balaji Vidyapita, Pondicherry. I want the round of applause for all the colleges. Wales Institute of Science and Technology, Chennai, Enapoya College of Allied Health Sciences, Bangalore, and our own Sri Devi Institute of Allied Health Sciences, Tumkur. Now the poster presentations, we are not ending, just we are putting a pause button to it so that we can continue later after our scientific sessions as our guests are waiting to give their valuable presentations. So I would like to call now Dr. Pavitra ma'am to hand over the stage and also to give a short intro about Dr. Pavitra G, Associate Professor, Department of Clinical Research in Sridevi Institute of Allied Health Sciences, Tumkur, and has presented 21 papers, national and internationally. Recently, she has been to international presentation trip on Thailand, Pattaya. So it was nice to have her today as a host. Welcome, Dr. Pavitra ma'am.
Thank you, Nishad. Good morning, everyone. Good morning, respected dignitaries, colleagues, and participants. Welcome you all to the National CME on Innovations and Recent Advances in Cardiac Care and Perfusion Technology. Today, the first session, we have with us Dr. Suresh S., Consultant Interventional Cardiologist, Sridevi Institute of Medical Sciences and Research Hospital. He will be sharing insights on recent advances in echocardiography, innovations, and clinical applications. To chair this session, I request Dr. Virupaksha sir, Professor and HOD, Department of General Medicine, SIMS and RH, to come on to the stage, and Dr. K.V. Ravindranath sir, Senior Consultant Physician, Department of General Medicine, SIMS and RH. Welcome you, sir. Now I request Dr. K.V. Ravindranath sir to introduce our speaker, Dr. Suresh sir.
Good morning, everybody. Welcome you all for the Cardio Shine 2025. And I thank the organizers and Sridevi Medical College for inviting me to become the chairperson for the first talk of the day. Dr. Suresh is going to speak on the echocardiogram, which is nothing but the ultrasound examination of the cardiovascular system. And ever since the echo was discovered, it has grown leaps and bounds. Today, it has become an inevitable tool in the examination of the cardiovascular system. It has evolved so much that today it has become an integral part of the clinical examination itself. Just like you use a BP apparatus and any other apparatus while doing the clinical examination, bedside echocardiogram is also a part of the clinical examination has become. And over the decades, what started as a single dimension echocardiography, that is M mode, then it traversed through 2D echogram, 3D echogram. I was told that even the 4D echogram also has come. With the advent of innovations, with the addition of Doppler, color Doppler, and TEE, now it has become possible to accurately and pinpoint a diagnosis of various disorders, cardiovascular disorders like congenital heart disease, valvular heart disease, ischemic heart disease, and even grading the several types of heart failures. And with this brief introduction, and even also in assessing the prognosis of a patient once the treatment is started. With these few words, I'll invite Dr. Suresh. As you can see, he's a product of Mysore Medical College for MBBS and MD, and he did MD, DM Neurology, DM Cardiology from Calicut Medical College. He has been a senior interventional cardiologist in our institution and is doing a great work, hardworking, and very good cardiologist. He is going to speak on the recent advances in echocardiography, innovations, and clinical applications. He has, to his credit, presented a lot of papers in the various journals, state-wise as well as national-wise, and a faculty in so many conferences. I invite Dr. Suresh to take over.
Thank you, sir, for the nice introduction. Good morning, all. I am Dr. Suresh. I am working as an interventional cardiologist in Department of Cardiology in this institute. It's an honor to present my talk on recent advances in echocardiography. I would like to thank the organizing committee of Sridhar Institute of Allied Health Sciences for this wonderful opportunity. So it will be a slightly bigger, long talk. I will have less theory, more of an images, because it is more of an echo conference. So my today's talk outline will be on history of echocardiography and contrast echocardiography, artificial intelligence in echocardiography, speckle tracking or strain imaging, also called as myocardial deformation imaging, 3D echocardiography, advanced valve and chamber assessment and interventions, echo integration in cath lab, that is also called as a fusion imaging, portable and wearable echocardiography, and what is the future of echocardiography, and with that I'll what is the transformative impact on cardiovascular care. So coming to the evolution of echocardiography, the echocardiography has evolved from simple M mode, which was used to be done in 1950s, from to a sophisticated multi-dimensional assessment. The key milestone was the transition from 2D to the 3D with a real-time capabilities. That is the key milestone in the echocardiography. And the digital revolution enabled the quantitative analysis and workflow integration very easily. And what are the recent major advances? The real-time volumetric imaging was introduced in early 2000s. Myocardial deformation analysis, that is called as strain imaging, is introduced in early 2010, and AI integration started now only. And miniature and wearable devices are started recently. So these are all our upcoming things. And today, echocardiography is the most frequently used cardiovascular diagnostic test after ECG. So can you see this? This was the first echo to be done in 1953 by Hertz and Edler. So we can't see anything. This is the echo they used to do it, and this is the classical M mode of mitral valve, which was recorded during that period. This is the only available during that period, and this was the two-dimensional B mode images. Can't see anything. That was the days when we started the echocardiography, and we have reached to this level. Okay. And early monoplane esophageal probes are something like this, and the images were also like this. And this was in early 1970s. And the landmark in development of echocardiography. So we have come all the way from 1940 to 2020, starting from just finding the reflected waves on the mitral valve. From there, we have gone to the Doppler echocardiography, intracardiac, phase array scanner, pulse Doppler, intravascular phase array probes, portable echocardiography, and now to the speckle tracking. So most of the things, whatever which was started in 1960s, they're still validated, and still we are using those things. And recently, the intracardiac echography and TE has advanced in last 2 decades. And what has made revolutionized is the artificial intelligence facilitated technologies, which has made these things very easier. So coming to the history, the timeline I've already told from 1954, and what has happened to the 2023, we have started using artificial intelligence in echocardiography very rampantly. And even the diagnosis of cardiac amyloidosis, how it was initially from 1976, and over a period of these years, we have started picking up cardiac amyloidosis in a normal patients also. That's how we started using this technology. So a few words on contrast echocardiography. What is contrast echocardiography? Is like just injecting some material into the intravenous line and then seeing the doing the echocardiography, that is contrast echocardiography. Most of us, we are doing the saline contrast. So it is for the enhanced border definition and perfusion assessment, and most of us, we are not doing the perfusion assessment. Most of the times we'll be doing the border assessment. The first generation we used to give only agitated saline, then we started giving encapsulated air bubble, and third generation we have started using perfluorocarbons. And what are the clinical applications to find out the left ventricular opacification for endocardial border delineation, especially to find out the thrombus and tumors, all those things, and myocardial perfusion assessment and quantification of the myocardial blood flow. These are the two technical things which we'll be doing very rarely in a dedicated echocardiographic labs. And technical advantages, we have an harmonic imaging and destruction replenishment imaging for perfusion technology. So this is the one echo image where you can start seeing, you can see the LV, apex of the LV, where you can see a homogeneous hyperechoic structure which is there. We don't know whether it is an thrombus or an intramural hematoma or a dissecting aneurysm or a tumor. So in contrast imaging, once you give the contrast to the left ventricle, you can start seeing the whole white thing is the contrast and the black thing is not getting perfused. So it is telling that it is either thrombus or an dissecting intramural aneurysm. So to delineate these things, we'll start using this technology. And what is the one slide on artificial intelligence integrations? So it's a transforming echocardiographic workflow and analysis. Basically, the image acquisition and measurements are most of the times manually done by a sonographer, which has started taking over by an automated analysis. That has made the strain to the echo technicians and to the cardiologist very means less things. So there are multiple softwares from different companies which auto measures all the Doppler signals, even the workflow, whatever we are doing in the echocardiography. Most of the things were done by Siemens, GE, and Tomtech, that is from the Philips. They have revolutionized these things. I'll keep showing the images so that you will understand what all things we are doing. So this is the simple M mode pulse wave Doppler across the mitral valve. And once you take that M mode across that one and you just click auto, and it will automatically calculate the E velocity, A velocity, and the deceleration time, and E to A ratio. Everything it will automatically give and give. You don't require to start searching everything. So it has revolutionized our workflow. And this is from the GE, and the same things. It will calculate all the Doppler formulas in the same workstation. It's a single one button. And for the calculation of the LVOT Dopplers, when we want to calculate the cardiac output or a continuity equation for the aortic valve sizing or and measurements, again, just record the pulse wave Doppler at the LVOT and just you click the auto and it will record. This is from the Philips. And again, this is from the aortic valve from a GE, which is again, which is already showing a beat-to-beat variations of all the velocities. And this is auto RV measurements. This is from the Philips, where you just select the right ventricle and just click the auto RV measurements. It will only calculate the basal, mid RV dimensions and the long axis, and it automatically it will give the all the RV parameters. And this is from the GE, where you just take the apical 4-chamber and apical 2-chamber view, and just you click auto EF, and it will calculate it will trace the endocardial border, and ultimately it will give you what is the end diastolic volume, end systolic volume, and the ejection fraction. So it's all done with a one single click. Only thing you need to do is acquire a better image with an ECG gated. That is the only thing, and no need to endocardial tracing the borders, everything no need to do. And this is from the Philips. Again, it will do the same things. And with that, we'll go to a new concept that is called as a speckle tracking, also called as a myocardial deformation imaging. It quantifies the myocardial deformation. What is this technique? Basically, it analyzes the natural acoustic markers within the myocardium throughout the cardiac cycle. So every cardiac cell will give you a reflected images as some small dot, and that is called as a speckle. And it will move in all the 3-dimensional structure. Our machine will start follow that small speckle and it will tell you what is happening to the myocardium. That is the simple thing, but we cannot manually do. It has to be done by in artificial intelligence softwares only. Usually, initially, we used to do with the Dopplers, tissue Dopplers, but that we have come all the way from tissue Doppler into the speckle tracking, and it doesn't have an angle. It's an angle independent parameter. So there are multiple strain imaging. The global longitudinal strain imaging of the LV is most validated, most reproducible, and most useful for the clinical applications. And there are other strain parameters like circumferential strain, radial strain, torsion, twist, all those things, but still they are in the early era of development. But presently we are using GLS and it is available in most of the echo machines, and it has made our revolutionized our things. What are the clinical applications? It will start detecting the cardiotoxicity from in a cancer patient, like any cancer patients who started on a chemotherapeutic agents, and the most of the drugs are cardiotoxic, and they start reducing the LV function. So before you start getting the significant LV dysfunction, it will start detecting as early as possible. That is the one greatest innovation in the last 10 years. And subclinical LV dysfunction also, LV dysfunction can be detected whenever you want to subject the patient for mitral valve repair or mitral valve replacement or aortic valve replacement. And these are the things which will be detected early. And the prognostic value in various cardiac conditions, it is there. And it is a superior sensitive test over ejection fraction, which is done in most of the laboratories. So this one we want to know in detail. So what it exactly does is we will take the three images, one the apical 4-chamber, apical 2-chamber, and apical 3-chamber view, and automatically it will select the endocardial borders, and it will keep tracing the endocardial borders, what is happening in the entire cardiac cycle. So initial days when we were trainings, we used to draw all the endocardial borders manually, and then you have to select it and then you have to process it. Now in my hospital or my setup, we started doing the auto strain imaging, where you don't need to endocardial trace spotting. You just record the image, just go to the auto strain, and it will start doing these things, and it will trace the endocardial borders nicely. Same thing again, it is tracing the endocardial borders, and ultimately what it does is it will give what is the amount of shortening of the myocardium which is given, and this is the bullseye pattern where the global longitudinal strain is always a negative value. Anything more than 18 is a good global longitudinal strain. And if you see red in the graph, the bullseye plot, it is every segment is contracting very well. Every segment is contracting very well. And again, the same thing, which we will give it by the segmental order, and all the segments will be given a different numbers according to that one. Which is a segment which is lengthening, which is a segment which is shortening, which is a segment which is dysynchronous. The cardiac dyssynchrony, all those assessment can be done with a global longitudinal strain. Again, the same thing from the, this is from the GE. Again, another global longitudinal strain imaging. And see, this is the image which was done where you can see the concentric left ventricular hypertrophy. It's not a simple concentric left ventricular hypertrophy. If you see the this bullseye plot, the center of the bullseye plot is red, and rest all things are somewhat white or bluish. This is also called as cherry on top of ice cream, that pattern. So it's classically seen in cardiac amyloidosis. So these things will be able to pick up only by doing a speckle tracking imaging. And this is how we do. You take the three images, 2-chamber, 3-chamber, and a 4-chamber. Ultimately, you need to select the region of interest, and by clicking, and give the strain imaging. And now this used to be done by olden times, but now it doesn't require anything. You just one click, it will automatically calculate the strain. Again, this is from the Philips, where we calculate the GLS auto strain. So the LV auto strain is already validated. What about the RV strain? Can we do same thing to the RV? Just take the endocardial border of the right ventricle, and automatically it will give you the RV strain. It is most useful in some of the pulmonary hypertension patients where you need to prognosticate. Especially in those cases, it is much beneficial. It's the same technology. And what about the left ventricle? sorry, left atria. Left atria is the one of the component in diastolic dysfunction which we keep on seeing. Only when the left ventricle, left atria is dilated, and when we see the E by A ratio, all those things are the olden methods of teaching of a diastolic dysfunction. Now just take an apical four-chamber view, select LA auto strain. It will give you all the three parameters. Okay, the conduit strain, reservoir strain, and the contractile strain. All the three things will be given, and ultimately it will tell you whether the patient is having an LV diastolic dysfunction or not. So this is not very much into the clinical practice, but it is an advancement. And if I think now the validated softwares are coming, and most of the equipments are coming with this LS strain also. So with that, what is the new era? So once you get an 4-dimensional echocardiography, you record one image of an 4-dimension echocardiography. The whole volume will be recorded like this, and it will give you the longitudinal strain, radial strain, twist, and everything. So only thing you need is a 4-dimensional echo recording. Only one beat recording is required, which will give you all the possible strains which are available. So it is giving the torsion, rotation, and even the longitudinal strain and the radial strain. Everything will be given by one click only. So it has revolutionized. You don't require much time. Just 2 minutes or 3 minutes of one recording, and one click, it will give you everything. So with that, we'll move on to the 3D echography. It is the most fascinating things, and I think this has revolutionized the intervention cardiology and the structural heart disease enormously, and it has made everything possible. From static reconstruction to a live volumetric imaging. What is static reconstruction? Initially, we used to take multiple 2-dimensional images. We used to construct it and to make a 3-dimensional image, and now a real-time 3-dimensional images keep coming. So that's the advantage of this new technology. So here, what we are doing is a matrix array transducers are used with 3,000 to 4,000 elements which can able to produce real-time images. And the current systems acquire full volume data sets in a single beat. Means in a one beat, entire cardiac activity will be recorded, and whatever measurements you want to do, you can measure with that one only. It doesn't require much time. So what are the clinical advantages? It eliminates the geometrical assumption of volume quantification. So whatever we are doing, the Simpson's method or Tickel's methods of ejection fraction, all those things are too many assumptions. The LV is bullet shaped, LV is cylinder, and the formulas, everything is an assumption. So, but the real LV is not like that. So it doesn't have any assumption. It will calculate every possible things, and it will measure. It's a more accurate assessment of a cardiac chambers, especially in a complex structure, and superior reproducibility compared to the 2D echocardiography. What are the applications? Valve morphology assessment, especially when you want to do valve interventions, and volume, ventricular volume and function quantification, and guidance to the structural heart interventions. These are the main applications at present. So I'll keep showing the images. You will be fascinated how the 3D images has revolutionized the cardiology. So this is the one of the 3D image. You can see the left ventricle here, and what we can see is a dissecting intramural aneurysm. So that is what we can see. This is the apex of the LV, where there is an anterior wall with a dissecting a wall. So that you can clearly see how it is there, whether the thrombus is there inside, how the LV, everything you can clearly see in a 2-dimensional. And coming to multiple modes, there is something called an explain image, where the image will be captured in 2 dimensions, perpendicular to each other. And this is from the Philips, where you can start seeing the mitral regurgitation in the 2 planes. One is 80 degree and one in 360 degree. So ultimately you can find out what is the mitral regurgitation quantification, whether it's a mild or a moderate. So there is something called as a 3D RV, where you need to just take the apical 4-chamber view, and automatically it will endocardial borders will be calculated for the RV, and it will give you the volume. So RV volume assessment and RV ejection fraction can be easily done with 3D RV strain. So this is the image which we see most commonly in a structural interventions. And this is a 3D image of a mitral valve, tricuspid valve, aortic valve, pulmonary valve with the left atrial appendages. And this is the surgically how it looks, and the echocardiography how it looks. It's something like an virtually dissecting the heart. You no need to open the chest, nothing. You just take a TE probe, go to the 3D enable, and you are almost seeing like virtual anatomy, like a dissection hall. So this will enable where exactly is the pathology, which valve is the problem, which leaflet is the problem, whether to fix it or not. All those things, structural analysis can be done easily with a 3D imaging. So we'll see a lot of fascinating things here. And this is the 3D image of a tricuspid valve. You can clearly see all the three leaflets of the tricuspid valve. And this is a trans-illuminating image where you can clearly see the borders, whether the vegetation is there or not, leaflet perforation. All those things can be easily seen. And this is the new technology from the Philips, where that is called as a true glass image, where you can see the left atrial appendage very much nicely in this image. Okay, this is the left atrial appendage, which is clearly seen here. And this is the, again, 3D image where you can see the LV thrombus inside the left ventricle. This is the LV thrombus. These are the still images. And again, if you have a 3D image where you can, this is the left atrial appendage, and you can see the multiple sections of the left atrial appendage, and you can construct the left atrial size, what is the length of the left atrium, all those things, including the area for the device closure, especially in the atrial fibrillation patients. And this is the mitral valve. You can see this whole thing is the mitral valve, and some of the scallops are prolapsing during the systole. That's also we can clearly see whether the patient is having a mitral valve prolapse or not. These are the still images. I'll still show some of the videos. This is the, again, 3D. You can quantify how much amount of blood is regurgitating from the mitral valve. This is the mitral valve where the blood is regurgitating back. And this is again the auto left atrial appendage. This is the whole thing is the left atrial appendage, and how to quantify all those things can be done easily with 3D. So yeah. So this is the one image where you can see this whole thing is the left mitral valve annulus, and this is the anterior mitral leaflet, and this is the posterior mitral leaflet. You can start seeing the scallops A1, A2, P2. A2, A3, P1, P2, P3. All the scallops can be seen. Is there any problem in any scallops where there is an infective endocarditis or cleft is there? Where is there any prolapse? Everything can be seen, and whether to, as the previous student has spoken about the mitra clip, whether mitra clip is indicated, all those things can be seen with this one. This is something like how the surgeon looks when they open the heart to look for the mitral valve, whether to replace or not. This is a surgeon's view of a mitral valve, which we can do simply by transesophageal echocardiography and a 3D integration. Again, same thing. It is a trans-illuminating 3D image of a mitral valve. You can see this is the anterior mitral leaflet. This is a posterior mitral leaflet. You can see there is a small gap here. This is called as a cleft mitral valve. This is the reason why the patient is having a mitral regurgitation. The cleft is not very easily picked up by a 2D imaging, and it is only detected from a 3D imaging. And this has revolutionized in identifying this cleft, whether this patient requires surgical intervention or not. And again, this is a flexi light image where you can change the light source of a light source so that we can keep seeing which part is prolapsing. It's something like you are going into the left ventricle and looking the left ventricle from different angle. Where is the prolapse? All those things. It's something like how the surgeons look at the valve. But when the surgeon is looking, it is a non-beating heart. But when we are looking, it is something like a beating heart. It is a realistic imaging what we get from a flexi-light imaging of a mitral valve. Again, it is showing the prolapse of the anterior mitral leaflet. Again, what is the, can we quantify the mitral regurgitation in 3D? Yes. Again, once we get a data set, we can see where is the regurgitation volume. And once we get, this is how we see the mitral valve leaflets are moving. That is the AML, and this is the PML, and which is a prolapsing leaflet which is happening, and whether the patient is having a significant mitral regurgitation, whether this patient requires a surgery. And this is the explain imaging. Again, the mitral you can see the non-coopting leaflets which can be seen in two different angles. So this is the assessment for the mitral follow-up case of a mitral clip. Once you put a clip, you can still see some regurgitation which is happening. This is the clip. That's why it is holding. Even the regurgitation jets, we can still see from the mitral valve. So you can follow up these cases again with the 3D enabling. So again, this is a simple TE images where after the mitra clip, you can see the mitra clip is placed in the mitral valve, and the transeptal puncture was done, and through the transeptal puncture, the ASD is happening, and whether this ASD to be closed or not, this assessment all can be done easily with a transesophageal echo with a 3D enabling. Again, this is a beautiful image of a aortic valve, how the 3D looks. You can see all the three leaflets are moving, which are all the three leaflets, whether they are coopting or not. Is there any central gap? Is there any prolapse? Everything can be seen with a 3D imaging. This is how the 3D aortic valve looks like. And this is a bioprosthetic valve. You can clearly see from the two sides. This is from the surgeon side. This is from the left ventricular side. You can see all the three leaflets, how it is moving. All the sutures are there or not. Is there any paravalvular leak? Whether the gap, any dehiscence of the valve. All those assessment can be done even in post-operative cases also. And this is the post mitral valve replacement, where this is the mitral valve and this is the central leaflet. You can see in and around the mitral leaflet, there is too much of tissues which are grown. This is called as a pannus, which can be able to identify. That's the reason the leaflet is not working. And those assessment can be done easily by analyzing the 3-dimension. 2D will not able to differentiate whether there is a thrombus or a pannus, but 3D can able to at least identify whether there is a thrombus, where is the pannus, whether this requires a surgical resection or not. Again, this is another case of a mitral cleft, mitral valve cleft. You can see the PML is having a small cleft here, and that is the reason why the patient is having a mitral regurgitation. You can see in this image, the regurgitation jet is coming from the cleft. So do we have this application in rheumatic heart disease, which is the most common disease, but nowadays we are not seeing too many rheumatic heart disease patients. But again, you can see how the 2D sees, the dooming AML, thickened APML, and the thickened aortic valve with all the commissural fusion. How the 3D images, how the quantification of the area can be easily assessed by 3D imaging. You can see how the 3D image of an aortic valve looks like, where all the thickening, whether the leaflet is thickened, all those things, assessment can be done with 3D. And again, this is the one case of an aortic regurgitation, and we want to know what is the cause for the aortic regurgitation. If you carefully see, one of the leaflet is flailing, and that we can see even by the 3D imaging. And again, coming to the myxoma, LA myxoma, so you can see something like this. What is the size of the tumor, where all it is attached, whether the thrombus is attached with the tumor. Every analysis can be done by 3D imaging. This is the 2D image, and these are the 3D images, and this is the post-surgical excision sample. So this is a case of an amyloidosis with a pericardial effusion, and there is a lot of pericardial effusion, and the art is like something like an wobbling. So you can see this whole thing is a pericardial sac, and the colorless fluid is the pericardial, and you can see the art is something like wobbling inside the pericardial space. These are the beautiful, fascinating images you can see from 3D analysis. And the RV analysis, you do TAPSI, the RV analysis. That is not the way. That was the once, and it was a long time. And nowadays we have to analyze the RV incomplete, like RV volumes, RV ejection fractions, TAPSI, even the tissue RV, this one, and the volume quantification. Even the volume quantification can also be done easily with 3D analysis. And I'll give you some of the things. This is a 4D data sets. How we analyze the LV function? It will just trace the endocardial borders in short axis, long axis, everything. This is a 4D image, and ultimately what we give is entire LV volumes will be in this one: ejection fraction, stroke volume, cardiac output, everything will be given with one click. And this is about the LA assessment. You need to take only one single image, and it will quantify the LA volume induced in all the strain patterns of the LA will be given. For the mitral valve assessment, again, you need to take only one apical 4-chamber, this one, and it will calculate all the inch points from the mitral annulus, and it will give you the entire mitral valvular perimeter, all the leaflet length, everything can be iotomitral angle. What all the parameters you require for mitral valve replacement, or for the TAVI, or for the mitral valve interventions, those things can be easily acquired from these 3D images only. This is how the 4D ejection fraction of an LV can be given from all the things. It will not leave any small gap in the LV also left unaccountable. Okay, so this is about the fascinating things in the 3D and 4D analysis. And we'll go to the advanced valve assessment. So why we need advanced valve assessment is basically because nowadays we started doing lot of valve interventions like TAVR. We are doing the mitral valve replacement, mitral clips, even the left atrial appendage closure, all those things. So for that we need a pre-procedural planning, and for that, so for the same reason, the echo has been integral part of these things. So in structural heart interventions, it has ramified into too many dimensions. For a pulmonary vein interventions, left atrial appendage closure intervention, tricuspid valve interventions, paravalvular leak closure, transcatheter mitral valve replacement, and when you want to do a mitral clip for a mitral regurgitation, and a transeptal puncture for multiple reasons. These are the indications for this one. I'll keep showing some of the images so that you will understand. And this is the slide which is showing tricuspid valve annulus assessment, just an auto analysis. You need to take the inch points and you give you the value. It will give you the tricuspid annular plane, perimeter, everything, which will be given by this one. And this is the images which we'll record for the mitral clip assessment. These are the still images. I will show you some of the things. And this is how you paravalvular leaks will be closed by a device. So what the mitral clip is the most fascinating things. What we do is just take a femoral vein puncture, go to the inferior vena cava, go to the right atria. From right atria, what we need to do is we need to puncture the interatrial septum and go to the left atria. So this is called as a transeptal puncture. And once you do the transeptal puncture, this all things will be done by fluoroscopy, transesophageal, and the fusion imaging only. Once you go to the left atria, and then you deflect your the catheter into the mitral valve. Once you go there, this is the mitral valve, how it looks like. All the cardiotendina and the leaflet scallops will be there. You catch hold of the scallop and release the device. Once it catches the leaflet, whatever the leaflet which was prolapsing or which is not co-opting will co-opt like something like this. This is the simple technique of how the mitral clip works. But we are not cut opening the chest. We are doing everything assuming and looking at the fluoroscopy and the echocardiography. So for the same reason, we need to assess the mitral valve very much clear. And this is how this is the interventricular septum, and this is the needle. We are just piercing the interatrial septum. This is how the transeptal puncture. Whether you have to take anteriorly, posteriorly, whether to take lower or higher border of the fossa ovalis, all those things assessment can be done only with a TE and a 3D analysis only. And once you go there, this is the catheter which is going in the left atria and going into the mitral valve into the left ventricle and catching hold of this clip and just just releasing the clip. Once you leave the clip, it will close this one. So what we do see only this one. The catheter is going from inferior vena cava to the right atria through interatrial septum to the left atria through the mitral valve. This is what we see, nothing else. And another slide we see is the transesophageal echo with a 3D enabled. So the catheter tip is going like this. This is from the surgeon's view, and this is from the left ventricular view. So this is how the image looks like. Once the leaflet is old, it will catch hold of something like this, and it will make two orifices. Instead of one big orifice, it will make one single orifice. And this is the true view image where the leaflet is holding, and because of that the regurgitation has reduced. I'll show one of the slide. This is the image where you can see because of the non-cooption and leaflet prolapse, the regurgitation is too much. This is a secondary mitral regurgitation due to the LV dilatation, and this is how the mitral clip goes there, stays there, and once it is fixed, the mitral regurgitation has reduced. This is pre and post mitral clip regurgitation, especially when there is a secondary MR. Secondary MR is the MR due to LV dilatation or some other cause. And is there any other interventions? Yes. When you want to close the PFO, that is the patent foramen ovale, when the patient is having an cryptogenic stroke or something like that, when you want to close the interatrial septum, because it is a small gap only, so you need to analyze. And this is the right atria and this is the left atria. and you can see the left atrial plate and the right atrial plate, and there is a small narrow neck will be there in the PFO device. So whether the PFO device is occluded properly or not, this assessment can be done easily with the 3D enabled imaging. And this is balloon mitral valvotomy. You can see the balloon which is coming from the left atria into the left ventricle. This is the left ventricular part, and once it balloons comes from through the a small gap, and we will inflate the balloon so that the mitral valvotomy can be done. These are all initially done with fluoro guided only. All are assumptions only, and lot of things used to go wrong. And now because of the TE and the 4D, three-dimensional image formation, you can clearly see whether everything is there or not. So with that, we'll conclude most of our fascinating things. And what is the future? Portable and wearable echocardiography. We used to see the echocardiography is there in one lab, you have to go there. And now portable machines are there. We can take the machines from one ward to the another ward, ICU to the special ward, all those things we can do. And from there, we have gone to a wearable echocardiography. It's something like you putting a patch on the chest and you walk, and it will keep recording the echocardiography and it will give you things. What are the indications? We will go there. One of the things is the handheld ultrasound device. Handheld ultrasound device was not available in India only because of the PCP&AD licensing, but now the licensing has been released and for the handheld device for the institutions. That's the reason why we are start seeing the handheld device in the most of the institutions. Okay, and second one is a wearable echocardiography. It's still in the research where it's something like a patch or a Holter monitoring like a patch, and connect to the patient, and it will keep recording the things. And clinical implications, why it is required, especially it is there in the sports medicine, where you need to see the cardiac activity, what is happening, not only the ECG, even the movements of the heart needs to be analyzed day to day and every time. For those things, it is still in the research field. I think it will come in future, another 5 to 10 years. So these are the available handheld echocardiographic devices which are there from the Mindray, TEAR, Philips Lumify, which is already available in India. Butterfly is there, GE Vscan, which is an older version, now it has become wireless. And the Cosmos, again, it comes with a small iPad with a small probe, but it is a connected wire system. They've just given a trolley, which was recently there in our hospital also, the Cosmos. But the Lumify and the Vscan has revolutionized. Now it doesn't have wire. It's just like a small device like this. Just put it over the chest and you can see with your mobile only. So this, why it is important? Because it is a point of care ultrasound when you want to assess the patient emergency or a critical care in a casualty. So these are the most fascinating devices which will change our clinical practice. And this is about the wearable things. Basically, it has an acoustic sensors which are kept over the chest, even in the carotid artery, which will calculate the Doppler signals and even the cardiac activity also. Little bit complicated, but still in the research field, not yet into the clinical practice. So what is the future? We have something called as multidimensional imaging, where we fuse CT, MRI with echocardiography. That is what we do. The CT will be done in CT room, echo will be done in echo room. But how it looks when we integrate both the things, that is called as the multimodality imaging. Then ultra fast imaging, where we see more than 1000 frames per second. It's an extremely high frame rate. Now the 2D echo recordings will be done with 60 or 70 frame rate. 3D will be done with still lower rate. But if you start recording at the 1000 frames per second, you will get a very clear, beautiful images. These are all in the future. And there is something called as the molecular imaging, where you inject a injection, and that will go and sits on the inflammation or an infection or something like that, and you start detecting those things in the echocardiography. It's something like a PET CT, where in PET CT we give the injection and we'll see the disease in the CT scan. Like that, if you start seeing the same thing in the echocardiography, that is called as a molecular imaging. Again, it is in the early part of the research. And extended reality applications, it is still in the simulation and most of the surgical centers, but not in the interventions part. So this is called something called as the fusion imaging. This is the cath lab fluoroscopy. You can see the transesophageal probe is there, and the background image is from the CT scan. Cardiac CT was done, and the background image is there. And once you get these are the images which we generate from the transesophageal echocardiography. And once you integrate these two things, we will start seeing the beautiful images. So I'll show you a few things. This is how, this is for the transeptal puncture. This is the fluoroscopic images which is overlapped with this cardiac CT. And these are the images which are generated from the transesophageal echocardiography with a 3D, which will give you where exactly needs to be punctured and where exactly needs to go there and how to place the device, all those things. And this is how the cath lab works like. So when we see the cath lab, we see only the wires, balloons, all those things. But we start seeing the images. This is cath integration with the CT, and this is the integration with echo. Even the echo images will be integrated in the cath lab. In the cath lab monitors, you can start seeing the echo images also. So that's it. Welcome you, the management team, for the program, sir. I think I'm concluding this slide. This is the last slide. What is the clinical implication and conclusion? We are transforming the cardiovascular care with these new technologies. So diagnostic impact is the earlier detection of the subclinical disease will be easier, more accurate quantification of a cardiac function, and improved risk stratification and prognosis. And therapeutic implications, it enhances the guidance for structural heart interventions, better monitoring of therapy, and personalized treatment is readily available with these things. And future vision is echocardiography continue to evolve as a quantitative AI driven modality and increasing the integration with clinical workflow and electronic health record. And already there are so many research which are going, keep collecting the echo data from all the countries to a single worldwide data. So these are the things which are transforming. With that, I'll just conclude my talk. Thank you.
Thank you, sir. It was an excellent presentation from Dr. Suresh S. Sir has explained in detail regarding newer recent advances in echocardiography like AI, 3-dimensional echocardiography, 4-dimensional speculate tracking echocardiography. Like that, he has explained in detail. So, any doubts you can ask? Any doubts or query from audience? So I have one doubt. What is the role of echocardiography in strain imaging?
The strain imaging or a deformation is something new. It's not a new technology. It was older technology. We used to do with a tissue Doppler initially. It was there since long time, 1970s, 80s also it was there. But now we have changed to 2D strain, 3D strain, and a 4D strain also. In what is the indication is, once we see the ejection fraction is low, we say LV dysfunction. Sometimes the ejection fraction is 55 or 60%, but still the patient is having an LV dysfunction. How do we find out? It is not possible. The only way to find out a subclinical LV dysfunction is by strain imaging. And when we start treatment, whether the patient is responding to the treatment or not, the subclinical improvement can be start seeing only by the strain imaging. And when you are waiting patients for aortic valve replacement or a mitral replacement, the indication for surgery is most of the times onset of LV dysfunction. When already the LV dysfunction starts in, no surgeons will take up. Just before the onset of LV dysfunction, again, that is an indication. So how do we have to periodically screen it. You do the strain imaging, is there any subclinical LV dysfunction, but the clinically patient is stable, you subject the patient for the surgery. So cardio-oncology and valvular surgery and some of the chemotherapeutic agents, these are the advanced and it is a well-proven indications for the strain imaging. And day-to-day clinicians are doing only for these three things, but it will go for other things also.
So even that hidden
LV dysfunction can be detected because here
so that
the
small early diagnosis
small tissue will be, that is called a speckle. There are millions of speckles in the image, and those all millions of speckles will be traced which direction it is going, whether it is contracting, whether it is relaxing, what is the deformation, the change in the position which is happening to the small contractile proteins can be detected by this imaging. So it's not like a one small dot, it is millions of dots steps which will be followed in the system. So that's how we detect the subclinical LV dysfunction.
Thank you, Dr. Suresh, for the excellent talk and more informative. And what fascinated me was the wearable echocardiogram. Just like we have Holter monitoring, we have Holter echocardiography, where you can usually perform the stress echo also in this, I think. Thank you so much.
Thanks.
Thank you, sir, for enriching our understanding on recent advances in echocardiography, innovations, and clinical applications. Now, I request our chairpersons, Dr. Virupaksha sir and Dr. K.V. Ravindranath sir, to express our gratitude and present Suresh sir with a certificate and a token of appreciation. Thank you, sir. Now I request our chief guest, Dr. B.M. Chandrasekhar, sir, District Health and Family Welfare Officer, Tumkuru, to hand over token of appreciation and certificates to our chairpersons. Sir, please come on to the dais. Dr. Virupaksha, sir. Thank you, sir, for accepting our invitation and chairing the session. Dr. Ravindranath, sir. Sir, thank you very much for accepting our invitation and for chairing the session. Thank you, sir. A very warm good morning to all of you. Welcome to all dignitaries, faculty members, and adult students. We have gathered here today for the Cardio Shine 2025, a national CME on innovations and recent advances in cardiac care and perfusion technology at our Sridevi Institute of Allied Health Sciences, Tumkur. Before we begin the ceremony, let me remind you to please turn off the phones to silent mode and kindly avoid talking aloud. Today's chief guests are Dr. B.M. Chandrasekhar Sir, District Health and Family Welfare Officer, Tumkuru. Our Honorable Chairman Sir, Dr. M.R. Ulinaikar Sir, Shri Sridevi Charitable Trust, Dr. Raman M. Ulinaikar Sir, Medical Director, SIMS and RH, Dr. Lavanya Ma'am, Trustee Shri Sridevi Charitable Trust, Mr. M.S. Patil Sir, Director, HR and IT, Dr. Harendra Kumar Sir, Principal, SIMS and RH, Dr. Mohan Kumar Sir, MS, SIMS and RH. Sir, please come on the dais, sir. And Principal, Dr. Krishna MC Sir, and Vice Principal, Dr. Chandrapa CP Sir. As we start our event, it is rightly said, prayer is not asking, it is a longing of the soul. It is both an incredible expression of faith and a humble gesture of surrender towards the divine. To begin this auspicious occasion, may I invite Ms. Vaishnavi, lecturer, to plead with Almighty.
वारणास्यं हेमवर्णं मङ्गलाङ्गं मनोहरं गौरीपुत्रं गणश्रेष्ठं विघ्नराजं नमाम्यहम् श्रीगणनाथं श्रीगणनाथं सततं भजेऽहं श्रीगणनाथं सततं भजेऽहं श्री आदिकेशव सोदरी सल्पुत्रं मातृहितं परिपालनबालं शिवकरहन्यं पुनर्पुण्यजन्यं श्रीगणनाथं सततं भजेऽहं श्रीगणनाथम्
Thank you, Vaishnavi, for your devotional and soulful execution. I now take the pleasure of requesting our beloved principal, Dr. Krishna MC Sir, to welcome the gathering.
Good morning for all. Sridevi Institute of Allied Health Sciences, Tumkur, is the college affiliated to Rajiv Gandhi University of Health Sciences, approved by Government of Karnataka. We have 11 undergraduate courses, BScs, 8 MSc courses, and 7 diploma courses. Totally 26 courses are running in this college. As you all know, Government of India has launched National Commission for Allied Health Professionals, just like National Medical Commission for Medical Colleges. At present, we have National Commission for Allied Health Sciences Professionals separately. This is a new commission launched by Government of India. Likewise, all the states are formulating state healthcare, allied healthcare professionals council under the National Commission. So all states are framing their councils. Henceforth, all the undergraduate and postgraduate students of all allied health sciences colleges across the country has to be registered under these councils henceforth. So with this intention, Sridevi Institute of Allied Health Sciences, we have planned a national CME for the integration of India, because we are all professionals under India. So we have to work together. So we planned national CME on our two departments, cardiac care as well as perfusion technology in the beginning. So medical technology is the fastest growing branch in the health sector. Yesterday's technology is outdated today. Whatever we are talking today, the technology will be outdated tomorrow. That is the fastness of technology. In view of this, Sridevi Institute of Allied Health Sciences and all Sridevi Institute of Medical Sciences, we have established our own research wing. We are working on it to conduct CMEs at the state level as well as the national level. So I am very thankful to our management, Chairman Sir, Dr. M.R. Ulinaikar, the founder, Chairman of Sridevi Group of Institutions, renowned surgeon and educationalist, and ex-member of Legislative Council, Government of Karnataka. I welcome you, sir, for chairing this national CME on behalf of management, and my personal welcome to our Dr. M.R. Ulinaikar, sir. For today's CME, this is a national CME labeled as CardioShine 2025. For the today's CME, the chief guest is my beloved friend, Dr. B.M. Chandrasekhar, District Health and Welfare Officer, Tumkur. I welcome you, sir. So this CME, the backbone and direction by our medical director, Dr. Raman M. Ulinoikar, Professor of Medicine and Trustee, Sridevi Charitable Trust. I welcome you, sir. All the functions, all the coordination will be there with the Sridevi Institute of Medical Sciences and Research Hospital. I welcome Dr. M.L. Arendra Kumar, sir, a principal, Sridevi Institute of Medical Sciences and Research Hospital, who is encouraging us in all these events. Welcome you, sir. Another Director HR and IT, Sri M.S. Patil, sir, who is encouraging us in all these events. I welcome you, sir, on behalf of Sridevi Institute of Allied Health Sciences. See, our hospital medical superintendent, Dr. Mohan Kumar, sir, I welcome you, sir, on this occasion of CME. The brainchild of this CME is our beloved Professor, Dr. Lavanya Madam, who has guided us to conduct at the national level, and she encourages us. So I welcome you, Madam, on behalf of SIAHS. I also welcome Dr. Chandrappa, Vice Principal, and my colleague to this CME. I also welcome all the speakers of today's event and all the chairpersons of today's event for scientific sessions, and all the delegates across the state, across the country who have represented, all the faculty from various institutions, various allied health sciences colleges, principals, faculty, and student delegates from different areas. So I welcome you one and all for this national CME. And also I also welcome the students of our own college and my teaching faculty and non-teaching faculty who worked for this CME day in and out. With a short period, we have arranged this national CME. If there are any drawbacks in this CME, pardon me, please, because this is a national CME arranged in a short period. So I also express my sincere welcome to the press and media who cooperated us for the announcements of the national CME in the TV as well as newspapers. I welcome you one and all. Thank you.
Thank you, sir, for your heartfelt welcome. On behalf of the organizing committee, I extend a warm welcome to you too, sir. Ladies and gentlemen, dear students, we are about to commence our event by lighting the lamp of knowledge and wisdom. This is a symbolic moment that signifies the dispelling of darkness and igniting of thought and enlightenment. It's an honor to invite our dignitaries on the stage to light the lamp and formally inaugurate the ceremony.
शुभं कुरु त्वं कल्याणं आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय
I request all the speakers to please join the lighting of the lamp. I request chairpersons and speakers to please join the lighting the lamp.
ब्रह्मरूपस्थं ज्योतिषां प्रभुरव्ययः ब्रह्मरूपस्थं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश पतिं स्वच्छामि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणं
Thank you, dignitaries.
आरोग्यं
This academic national CME, one significance is we had e-poster presentation. We got 63 e-poster presentation and out of which 17 will be selected for the first round and the prizes will be given at the end in the valedictory function.
Thank you, sir. Now I request Dr. Lavanya Raman ma'am, trustee Sri Sridevi Charitable Trust, to say a few words to the gathering.
Good morning, everyone. Respected dignitaries on the dais, respected Chairman, sir, Dr. Manjunath, sir, District Health Officer, Tumkur, respected Medical Director, Raman M. Holinaikar, sir, Director HR and IT, MS Patil, sir, Harendra Kumar, sir, Mohan Kumar, sir, Krishna, sir, Chandrapa, sir. There is a saying in Kannada, Vidye Manushana Shresthavada Snehita, Vidyavantanu Ellodaru Maryade Sigate anta. So that means, I know all Tamil students here come from Tamil Nadu. That means education is the best friend of a human, and wherever the educated person go, he gets the most respect. So we all know knowledge is our power. So it gives me a very profound happiness when I see this 350 students coming from different institutions, colleges from all over the South India for the CME. So I feel very happy. when students are so motivated, they want to improvise themselves. The CMEs are very a vital part. That is, it always helps a healthcare professional to improvise, to get updated in the recent advances in the field of medical and technology. As we all know, there is a significant rise in the cardiovascular diseases now. So when we see the statistics, I think uh, this year it is around 30% of all the deaths in India are contributed by cardiovascular diseases. When we see previous years, it was around 10 to 12%. So there is a significant rise in the cardiovascular diseases. So there is a significant risk for the health of the public now. So we all know what are the risk factors which are causing this cardiovascular diseases. It can be obesity, especially abdominal obesity, hypertension, stress is also one of the factor, and these are all happening at a very young age of a person. And even urbanization, as we know, this cardiovascular events are happening much more, incidents are happening in the urban. So all these factors all contributing to the rise in the cardiovascular events. So this all says that there is a need for a very significant prevention, a significant prevention of the cardiovascular risks. A significant treatment is required, a significant management strategies to be made by the doctors. And also, I feel there is a significant and there is a need for updating our healthcare workers who are directly coming in contact with the patient. So if you, I feel by updating about the recent advances to the our healthcare workers, there is improvement in the patient care. So in turn, we can all join hands to reduce whatever the surge or the increase of the cardiovascular events we can reduce. That's what I feel. And uh, I would like to throw a little bit light on the place you have come. You have come to Sridevi Allied Health Sciences, which is in Tumkur, which is under Sridevi Charitable Trust. I'm very proud to tell that this is one of the college in Karnataka where it has the highest allied and paramedical seats. That is around 320 allied health sciences seats and 260 diploma paramedical seats. We have around 40 MSc courses. The courses are like, we even have MSc Echocardiography, we have dialysis, MSc dialysis, MSc MLT, we have so we have MSc optometry. So we have masters in all the specialities, and we are very happy that our allied health sciences is attached to Sridevi Medical College Hospital. So you all know, so any college is attached to the medical college, they are being taught by the doctors who teach MBBS students and postgraduates. So it's a very proud thing that our students are being benefited by the best of the best teachers, doctors, and I'm very thankful to our management, the chairman sir, for providing them very good facility for all varieties of training which is happening here. We have a very advanced skill lab where the students are first trained in the skill lab, where they get trained many times repeatedly. Only once they're confident, they're let them to face a patient. So in that way, a very quality teaching is happening here. At the same time, we have as you have seen, we have a lush green campus, very good libraries, facilities, and our laboratory is one. It has all the advanced automated. The machines are there, very well versed radiology department. With all this facility, I'm very proud to say that our students have been trained under best of the best and in the good environment. And in this occasion, I appreciate from the side of management, I appreciate our principal Krishna sir and Chandrapa sir, who is conducting this one of this kind national level CME. So first of his kind, I would like to say, sir has conducted this national level, taking it in a very smooth and in a very successful way. I really appreciate them, and I really thank Dr. Suresh sir for his all the cooperation for conducting this national level CME. And I also appreciate all the staff of our Sri Devi Allied Health Sciences who are day and night working for successful program to come up. Thank you, one and all.
Thank you, ma'am, for enlightening us about the need of updating ourselves and also briefing us about our institute. Now I request Dr. Raman M. Ulinaikar, sir, Medical Director, SIMS and RH, to address the gathering.
Honorable Chairman, sir, former MLC Tumkur, Dr. M.R. Naik, sir, today's chief guest, Dr. Chandrasekhar, sir, District Health and Family Officer, Tumkur, Shri M.S. Patil ji, Dr. Mohan, sir, Dr. Harindra Kumar, sir, Dr. Chandrapa ji, Dr. Lavanya ji, and our Principal of Sri Devi Institute of Allied Health Sciences, Dr. Krishna, sir, all the faculty members of Allied Health Science College, all the today's guest speakers, renowned guest speakers who have come for this program, dear students of Sri Devi and all the other colleges all over India who have come to attend this program. Hearty good morning to you all. First of all, I would like to tell you it's a very well organized CME, national level CME, which has been organized in Sri Devi College. I just want to enlighten about working of the hospital. If you consider the hospital as a building, you can say the foundation can be the doctors, but the pillars and the walls you can consider as the nursing and our allied health professionals. So a hospital is not just run by doctors. It's not just prescribing a drug or giving a medicine. It has a holistic approach wherein a lot of professionals are involved. Right now, there is a diversity in treating a patient. It's a holistic approach wherein each and every professional are contributory towards the treating and curing of the patient. So the burden on nursing time immemorial has been increasing because the condition and the expectation of the patient is more. Can you give me another mic? Thank you. The approach or treatment for the patient is very diverse nowadays. So it's not only just the doctor treating the patient and the nursing taking care of the patient, but it also nowadays has got a lot of role by the allied health professionals who are called as technologists right now. It's not just restricted to lab or radiology. Now technologists are there for dialysis, they're there for optometry, they're there for EMD, paramedics, they're there for cardiology, whether it's perfusionist or the cardiac care technicians. So a lot of developments are happening in the field of allied health sciences. So this career has got a lot of future, but you need to keep a good focus in your career and progress, develop in your career, find ways and means to gain more knowledge in your field. So this is one of the ways which you can get into more advanced or future trends knowledge in your field. So this was actually why we thought it's national level CME is needed for allied health sciences. And we have called very renowned speakers, super specialists in their fields, who are going to guide you for the rest of the day, talking about, right now we chose a topic for cardiology. So Cardio Shine 2025 has been organized. These speakers will be enlightening you, giving you more knowledge and the future trends which are happening right now. So I would suggest and advise you these kind of CMEs try to attend more and more. And if soon the Sridevi has taken up this kind of CME, maybe we'll be starting up some crash courses or fellowship courses also for you people to gain more knowledge, more hands-on training. And if you find these kind of workshops or skills or CMEs, try to attend more so that you progress in your field, which will be your career. And all the hospitals are looking for more advanced and educated and knowledgeable professionals. So all the very best. Take full advantage of this kind of CMEs, and heartily welcome again who have come from all over the country, especially the southern part of the India. I welcome you all and have fun, gain more knowledge. Thank you. God bless.
Thank you, sir, for enlightening us about the need of allied health science professionals and advancement in this field. Thank you very much, sir. May I now call Dr. Palia Mohammadin, sir, Assistant Professor, Department of Community Medicine, to introduce our chief guest, Dr. B.M. Chandrasekhar, sir.
So good morning to all. Dr. Chandrasekhar BM sir, District Health Officer, Tumkur. Date of birth 6/4/1970. Sir has graduated from MBBS from SSMC Tumkur and PGDHM from Government of India, NIHFW. Then has got DPH from Chidambar University and worked as General Duty Medical Officer in different primary health centers and community health centers in Tumkur district, and worked as District Malaria Officer from 2023 to 24 in Tumkur district, and now working as District Health Officer in Tumkur since 2024. He is a very dynamic, efficient, able officer, carrying out all national programs efficiently, and has made his name people friendly, helping the needy and poor people regarding the health issues. Thank you, sir, for accepting the invitation and attending the function. Thank you.
Thank you, sir. Now I request our Honorable Chairman, sir, Dr. M.R. Ulinaikar, sir. May I request our Honorable Chairman, Dr. M.R. Ulinaikar, sir, to felicitate our chief guest, Dr. B.M. Chandrasekhar, sir. I request all the dignitaries to please join. Thank you, dignitaries. Now I request our chairman, sir, Dr. M.R. Ulinaikar, sir, to felicitate our speaker, Dr. Suresh, sir, who is a senior interventional cardiologist at SIMS and RH. Sir, please. I request the audience to please applaud. Thank you, dignitaries. Now I request our dignitaries to felicitate another speaker, Dr. Ravi Shankar sir. Sir, welcome on the stage, sir. Dr. Ravi Shankar sir is a respected senior interventional cardiologist. He has his own hospital, Apex Hospital in Tanjavur, Tamil Nadu. Thank you, sir, for accepting our invitation and gracing this occasion. Thank you, dignitaries. Thank you, sir. Now I request our dignitaries to felicitate our one more speaker, Mr. Senthil Kumaran Dhanakoti, Chief Perfusionist at Apollo Hospitals, Bangalore. Thank you, sir, for accepting our invitation and gracing this occasion. Thank you, dignitaries. Please kindly be seated. If your actions inspire others to dream more, learn more, do more, and become more, you are a leader. I request our Honorable Chairman, Dr. M.R. Ulinaikar, sir, to kindly deliver the presidential address.
Good morning to everybody. Respected Chief Guest of the today's function, Dr. B.M. Chandrasekhar, our District Medical Officer. All the dignitaries on the dais, Dr. Harendra Kumar, Principal, Sridevi Medical College, Dr. Mohan Kumar, our Medical Superintendent, Dr. Raman, Director Medical Hospital, Dr. Lavanya, the Professor Ophthalmology, Dr. Krishna, Dr. Chandrapa, all the dignitaries, the guest speakers, students who have attended the today's events from all over India, all the faculty members and friends. Really, I'm very happy to be here in such a good occasion where our allied health science institution people have organized a very good National CME on Cardio Sign 2025. They have done very systematically. It is well organized event where students are taking part. They are presenting their papers. Experts are discussing with you and giving guidance to you. It is really wonderful. I wish all the success. As we know, in all the medical discipline, overall healthcare people, nearly 60% of them are now allied health science people. They are not supporting staff. They are the partners of the health system now. Now, the allied health science is very growing science. In every field of medicine, we need people who are experts to support, to help the mainstream doctors in the specialization. Probably we have to get closer from different disciplines. If we work together with the different disciplines, even amongst the allied health science people, the outcome will be more than 40%. The patient comfort will be more than 30%. That's what studies tells us. That means not only we are growing in a particular field of science, we have to have some better understanding between the interdisciplinary also. Because one particular problem needs many people. Maybe a cardiologist or a neurologist treat the patient. To get the better outcome, we need a lot of technologists also. For example, one person has got vascular accident, he got a stroke, we have to find out from where this start has come. A cardiologist works on that, neurologist treat for that, a physiotherapist will work on him, a therapist, occupational therapist will help him to get the job, the radiographer or a radiologist will support him to understand better, a diagnostic person will follow up his other parameters. Like that today, a single person or single department will not be getting that much of results for the patient. So it is a interdisciplinary understanding each other, discussing each other, helping all together definitely will help the patient. It will be going to help to the entire health system. Not only it is a necessity. We have to understand better in our own discipline. These kind of seminars, experts' opinion, experts' talks, discussing each other, definitely it will improve ourselves. Our understanding in the science will develop better. Our confidence level will be increased. We understand what are the developments taking place all over the world. It is always better to have such kind of seminars, discussions, experts' opinions, keynotes, addresses. Everything is fine. At the same time, in a cumulative, we all together should work so that we get better understanding ourselves, we get better confidence level to treat the patient, and it will also help the patient and public in large. With these things, today our experts are going to talk on many subjects which will be useful for your career, your understanding. even students are going to present their papers. It's very nice. You study on that. The other people will understand your understanding and your projects and your thoughts. These kind of repeated seminars, repeated talks definitely will take us in a higher level. I hope our people, they have organized very well. They have taken lot of strain to organize these things. I thank them. I congratulate them. I wish you all the success. Let this seminar, I mean, national level CME will take us in a higher level. Thank you, Anda.
Thank you, sir, for those wonderful words and stressing on interdisciplinary coordination and understanding. Now I request Rajkumar sir to say a few words.
So good morning, all present here. So I would like to It's my immense pleasure welcome you to all to the national level Cardiosine 2K25. First of all, I will good morning all the dignitaries and all the students and faculty members from various colleges. So it's my immense pleasure welcome to you all to this national CME Cardiosine 2K25. First of all, I would like to thanks and sponsored by Shimatsu India Private Limited and Purple Microport Cardiovascular Private Limited, Breed Stent, Falcon Healthcare from Bangalore, Maclights Pharmaceuticals Broker CVD and Mumbai. Now I would like to share to now I would like to welcome Sudhir sir on the dais, who is company person for Shimatsu India Cardiovascular Private Limited. Chairman sir to do felicitation of him. Next. Next, I would like to welcome Maclights Pharmaceuticals company person. Anyone come on dais? Now I would like to welcome Maclights Pharmaceutical company person. Anyone come to dais? Thank you for all the sponsors. Thank you, sir.
Thank you, sir. Gratitude is not only the greatest of virtues, but the parent of all the others. Let us now welcome our respected Vice Principal, Dr. Chandrappa CP, sir, to extend the vote of thanks.
A very good morning to one and all. Thank you, Dr. Pavitra Madam. It's a great privilege and pleasure to stand here to deliver vote of thanks. I would also like to extend my thanks to everyone for coming and for making this event a significant and memorable. This occasion is special in many ways. It is special because many professional delegates, participants have participated today. First of all, allow me to begin my thanking our Honorable Chairman, Dr. M.R. Hulnayakar sir, Sri Sridevi Charitable Trust for accepting and grace this CME, National CME. We are very happy to extend our vote of thanks to our today's chief guest, Dr. B.M. Chandrasekhar, District Health and Family Welfare Officer, Tumkur District, Tumkur, for accepting our invitation and grace the occasion. Thank you, sir. I'm very happy to thank our medical director, Dr. Raman M. Hulinayakar, to grace the occasion and continuous motivation and support to become this program a grand success. Thank you, sir. I am delighted to thank Sri M.S. Patil ji, Director, Human Resource and Information Technology, Sri Sridevi Charitable Trust, to evident this program and kind support. Thank you, sir. I'm very happy to thank Dr. Lavanya Raman Madam, Trustee Sri Sridevi Charitable Trust, for her continuous care and monitoring the arrangements for this considerable event to become grand success. Thank you very much, Madam. We are happy to extend our vote of thanks to Srimati Ambika Madam, Trustee, Sri Sridevi Charitable Trust. Thank you, Madam. An exceptional dhanyavad to Dr. Ravi Shankar, Senior Interventional Cardiologist, Affects Heart Hospital, Tanjavur, Tamil Nadu, who is going to deliver lecture on hemodynamics in cardiac catheterization laboratory. Thank you, sir. An extreme special thanks to expert academician Dr. Suresh S, Consultant Interventional Cardiologist, SIMS RH, for excellent lecture on recent advances in echocardiography, innovation and clinical application. Thank you, sir. A distinctive thanks to Dr. Nilesh Kumar S. Shah, Interventional Cardiologist, Siddhaganga Hospital and Medical College, Tumkur, who is going to deliver an excellent lecture on recent advances in interventional cardiology. Thank you. Thank you, sir. I am delighted to thank Dr. Bharat Kumar Mohandas, cardiovascular thoracic surgeon, minimally invasive and robotic cardiac surgeon, Apollo Hospitals, Bengaluru, who will be delivering lecture on transforming cardiac surgery from sternotomy to robotic and minimally invasive approaches. Thank you, sir. Happy to thank to Mr. Senthil Kumaran Danakoti, Chief Perfusionist and Senior Manager, Apollo Hospitals, Bengaluru, who is going to speak on redefining the beat, innovations and insights in modern cardiac surgery, mix and robotic assisted interventions. Thank you, sir. Our heartfelt thanks to scientific committee members, Dr. Harendra Kumar sir, ML, Principal, SIMS RH, Dr. Suresh, Consultant Interventional Cardiologist, Dr. Virupaksha KL, Professor and Head Department of General Medicine, Dr. Naveen K, Professor Department of General Medicine, Dr. Yaswant G, Nephrologist, and Dr. Sridhar, Neurologist, SIMS RH, for their suggestions for the conduction of this wonderful CMA. Thank you all, sir. We are happy to thank today's chairpersons of each session, Dr. Sharat Kumar Shah, Professor and Head Department of General Medicine, Sri Siddhartha Medical College, Tumkuru, Dr. Virupaksha, Dr. Naveen, Dr. KV Ravindranath, Senior Consultant Physician, Department of General Medicine, Dr. Suresh, Cardiologist, Dr. Muralidhar, Professor, Department of General Medicine, Dr. Ravi Shankar, Dr. Amit Kem, Dr. Bharat Kumar Mohandas, Cardiovascular and Thoracic Surgeon, Apollo Hospitals, and Dr. Ravi Shankar Vaiyar, Gastroenterologist, Department of Surgery, for SIMS RH, for conduction of sessions successfully. Thank you all, sir. It is my privilege to thank Dr. Mohan Kumar sir, MS Medical Superintendent, for their support. Thank you, sir. It's my privilege to thank Dr. Krishna MC, our beloved principal, for wonderful involvement and guidance. Thank you, sir. And sponsors of today's function, on behalf of organizing committee, I thank you all. Really, it is the right time to appreciate Mr. Rajkumar, lecturer, Department of CCT, Sridevi Institute of Allied Health Sciences, for his commitment to plan and conduct such wonderful CME. I thank Mr. Rajkumar on behalf of management, principal, staff and students. Thank you, Rajkumar, for your great contribution towards this excellent CME. I thank all the coordinators and members of various committees for your marvelous support to become this program a grand success. Thank you all. I'm really fortunate to thank participants without whom the CM would not become grand success. Thank you all. Finally, I'm glad to thank all the media persons, event manager, photo and videographers, technical persons, and who are involved directly and indirectly. Thank you all once again. Thank you very much for this marvelous opportunity.
Thank you, sir. Now I welcome Dr. Nilesh Kumar, sir. I request our chairman, sir, honorable chairman, sir, Dr. M.R. Ulinayakar, sir, to felicitate Nilesh Kumar, sir. Sir is a cardiologist at Sri Siddhganga Medical College. Welcome, sir, and thank you for accepting our invitation and gracing this occasion. Thank you, dignitaries. Kindly be seated.
Thank you, one and all.
Thank you, dignitaries. Thank you all. As we conclude this enlightening session, now I hand over the dais to Nishad, Mrs. Nishad.
Hello, everyone. I know now it's time for you to take a small break. But before you take a break, I would like to show you a small clip, just a 30-second clip, where we are projecting our MSc Echocardiography course. So you all know already the syllabus and course duration is of 2 years. So you have all the facilities in our Sridevi Institute of Allied Health Sciences. So a glimpse is here. After watching this video, you can take a short tea break. A high tea is provided for you outside. So we can go for that. So kindly watch this video and you can go from here. Thank you so much.
Darshan sir.
The tea is arranged at the beside room. You can go and come back quickly as soon as possible so that we can begin with the next scientific session. Thank you so much. Please go back. Take the break and come back. Because again, you will not get a break. Continuous scientific session is there. Go for the break. Hello, check, check.
I didn't got flower.
Which flower, ma'am? Rose. Oh my God, we will give you a special flower.
Yeah.
Again, I'll list it
Okay.
after the break. Ma'am, I don't know your full name.
My name is Veerpal Kaur.
Vilpar Kaur. आप
Punjab
से
से हूँ.
पंजाब से हो? Everyone, please come back and occupy your seats as we are going to start with a scientific session. Please come back to the dais. Those who have finished their tea breaks, please come back. Those who have finished their tea breaks, please come back. The scientific committee is yet to begin. Please come back. The scientific committee will begin. Please go back. Come back from the tea session as we are going to begin with our scientific sessions. Please come back, all the delegates. All the delegates, all the delegates are requested to come back to the dais. All the delegates, come fast and occupy your seats. We are commencing with our scientific session. Please come back. We are going to commence our scientific session. I would like to welcome all the delegates once again. Please come back and occupy your seats. Kindly occupy your seats faster as we are going to start with our scientific session. I would like to invite once again everyone for the scientific session, and I'm handing over the mic to Dr. Pavitra.
Thank you, Nishad. Welcome back after the tea break. Our next speaker is Dr. Nilesh Kumar S. Shah, Interventional Cardiologist, Siddhganga Hospital and Medical College, Tumkur. So to chair this session, I request Dr. Naveen K. Sir, Professor, Department of General Medicine, SIMS and RH, and Dr. Murlidhar Sir, Professor, Department of General Medicine, SIMS and RH, to chair the session. I request Dr. Murlidhar Sir to introduce our speaker, Dr. Nilesh Kumar S. Shah, to the audience.
Good afternoon, everyone. It gives me a great pleasure to introduce Dr. Nilesh Kumar S. Shah, who is an interventional cardiologist in Sri Siddhganga Institute of Medical Sciences, Tumkur. He is graduated from Siddhartha Medical College, and he was a topper in the MBBS. He has received 18 gold medals in MBBS. And one more, he was a university topper in MD, RGUHS. He did MD from WIMS Ballari. And he has done his DM from KLE Belgaum. And he has presented many papers in World Cardiology Conference in Barcelona. Now at present, as I already told you, is in Siddhganga Medical College. And I'm also very happy to tell you that he is a proud son of my teacher, Dr. Sharat Kumar Shah, Siddhartha Medical College. He has got expertise in recent advances in intervention cardiology. I hope he will enlighten us regarding this subject. Over to you, sir.
Thank you, sir. Hello. Thank you, sir, for such a nice introduction. Always grateful to all the teachers and my colleagues who work in Tumkur. This day, whatever I am is because of them. I owe them to you. Today, we have a small talk on advances in interventional cardiology. It is a very vast topic. ever growing and ever enlightening to us, because every day in cath lab for us, every patient is a new patient and every case is an advancement from what we have done from the last case. So basically, the internet in basic language, I will say interventional cardiology involves catheter-based heart procedures. So our scope of interventions includes coronary, structural heart diseases, peripheral interventions, and also devices. So before knowing the advances, we should know what is the history behind it. Initially, it started with cardiac catheterization. Dr. Ravi Shankar sir will be dealing about catheterization later in the sessions. Initially, it started with catheterization of a horse. From there, a person injected himself with dye, and then here the catheter, Judkins catheter, what we use day in, day out, came in. So later from there, we went into balloon angioplasties, bare metal stents, drug-eluting stents, now into bioabsorbable scaffolds. So the early foundation came in 1953. The first angiography was done in 1958 by Dr. Mason Stones. Later, the first percutaneous coronary intervention was done by Daughter and Judkins. It was a peripheral angioplasty. But the first coronary angioplasty was done by Andreas Grunzig. He is called the father of interventional cardiology, where he did the first balloon angioplasty. Later in the 1980s, there came POBA, where we called as plain old balloon angioplasty. The risk of restenosis was more and abrupt vessel closure was high, almost 50%. So then came the era of stents, what we use day in, day out now. That was invented by Ulrich Sigvart and Pickwell, which was earlier bare metal stent. Then later came usage of drug-eluting stents in 2002, which reduced the incidence of instant restenosis and further improvement of lifestyle. Now the recent advances are in imaging, atherectomy devices, and distal protection devices. The key areas of advance I want to discuss is coronary interventions, structural heart interventions, imaging and guiding technologies, pharmacological adjuncts, and device innovation. So I will try to touch upon as much topic as possible. It is a very vast topic. We cannot cover everything. Basically, coronary interventions, as I told, initially started with catheterization, then using the catheters, then came drug-eluting stents. So basically, to understand in layman's language, stents are nothing but pipes which are inserted into the heart. This is the blood flow is stopped. We put a pipe which opens the blood flow and the circulation is started. That's how we treat acute heart attacks. So initially came bare metal stents. That means a steel stent. It was a stainless steel. Now later came the advancements with drug-eluting stents. That is, there is a nitinol or a chromium pipe. On that there is a polymer chemical. On that there is a drug coated. Now initially there were first generation stents what I put, which was made up of sirolimus, paclitaxel. The platform initially was stainless steel or a slotted tube design. Now the second generation drugs came or zotrolimus, everolimus, but the platform I told to change, there was advancement in the platform, that cobalt chromium or the thin stud stents. Now the third newer generation stents have come where there are something called dedicated bifurcation stents. There are polymer free drug-eluting stents. There are bioabsorbable stents, which makes life easy. If the patient has a restenosis, new blockages, he can go for a bypass surgery post stenting also. Then came, now we are using drug-coated balloons. I'll be just discussing in the future slides. Now, the newer advancements or the new limelight is on these atherectomy devices. Earlier, in the era of 1960s to 2000s, any patient who has a triple vessel disease, calcific disease, was referred to a surgeon for bypass surgery. Now, many of the lesions or many of the blocks can be cleared with so many devices which are available at our forefront. That is called rotablation, what I have shown here. This is a rotablation. Earlier there was a rotaglide, now it's a rotapro. So it basically drills through the calcium, whatever is there. The tip here, what we are saying is a diamond coated tip. It will be breaking the calcium and going in balloon uncrossable lesions. Next, the newer advancement, what we have now is a rotational orbital atherectomy, where the crown will drill in 360 degree, which drills away the calcium in 360 degree. And the new one more IVL. The small pictorial depiction I've shown. Earlier, this was a balloon, just plain old balloon angioplasty. This is rotational atherectomy. I told it's a driller. In a common world, it is a driller. Once again, orbital atherectomy, it works in 360 degree. 360 degree. Next comes intravascular lithotripsy. That is, we break the calcium, extraluminal calcium, using ultrasonographic waves or high intensity waves, which breaks the calcium 360 degree and helps in equal stent expansion. Next comes drug-coated balloons. These are the new news in interventional cardiology. I mean to say, whenever the small Caesar, we have stent size up till 2.25 mm. What next? Less than that. Sometimes the vessels will be very small, or there are instant restenosis. We have put a stent, there is blockage inside within it, can be early, late, or subacute. There are bifurcation lesions. Sometimes we do only something called provisional bifurcation. Only the main vessel is stunted, the side branch is left, but it's lesion. There are diffuse coronary disease. There are high bleeding risk in which we cannot give high dose of antiplatelet for long time. And in long-term diabetic, the vessels will be very thin. In these cases, we use something called drug-coated balloons. Earlier, there was a drug-eluting balloon. Now they're called drug-coated balloons. The balloon is coated with medication. We inflate the balloon. The medication is deposited on the blocks. The blocks are cleared, and it will prevent future block development. So key consideration is important here to something called lesion preparation. These are very technical terms, but we need to know something called as drug-coated balloons, which can be used in day-out procedure for side branches, instant restenosis, bifurcation lesions for the side branch, and in high bleeding risk patients. Then something I spoke about bioabsorbable scaffolds. So these came into the market with a very big boom, but it lost its limelight because of so many other aspects which cannot be used in every case, but something called as simple lesions called type A, type B lesions that is large vessel size. So what is the advantage I will tell you out of this is the polymer or the metal will get dissolved by the end of at least 6 months to 1 year. The vessel is ready for, if the patient has one more block at the same place, distally, proximally, he can be planned for a bypass surgery. He can be planned for which was earlier not possible with stainless steel stents or the early generation stents. So this is an added advantage. Next comes the structural heart interventions. Earlier, interventional cardiology was just associated with involvement only with coronaries, something called as PTMC for balloon mitral commissurotomy. Now, the newer interventions have come for valvular heart diseases in patients in whom surgery cannot be done, in whom patient surgeries have been deferred, but still they are symptomatic and they need treatment. Mainly something called TAVR, that is transcutaneous aortic valve replacement. Mitra clip in cases with primary MR where we use mitra clips. Tricuspid valve interventions in which there are severe TR, there is right heart failure, they need treatment with something called as trick valve and so many other valves which are in usage. Then something called left atrial appendage closure in patients who have left atrium dilated, left atrial appendage clot. We need to prevent future strokes. So, and patient cannot take anticoagulation for a long time, or there are some contraindications, something called left atrial appendage device closure devices, which Watchman device is one of the recently used regularly used devices. And other structural heart disease interventions like ESD closure, PFO closure, PSD closures are all being done. So mitra clip usually in functional MR. What I told, the mitral valve, there will be difference. The closure will not be coaptation of the mitral valves won't be optimal. So we use a mitra clip device. We go percutaneously and put a clip there, which reduces the MR, hence reduces the incidence of heart failure, pulmonary edema, and increase in morbidity. There is reduction in morbidity and at last mortality also. As I told, left atrial appendage closure devices, there are many devices available, which mainly used for stroke prevention in AF patients who are unsuitable for long-term oral anticoagulation. Next came what I told is TAVR, that is transaortic aortic valve replacement. It is going to growing in a bigger way, in which now earlier they used to put a valve, now they put valve in valve, now they put valve in valve in valve. So the advancement is very high. That means to say, whenever there is a blockage at the aortic valve, it is mainly degenerative. That I mean to say is people in 60s, 70s, 80s. Earlier it started in the US, in which Dr. Krebier invented this procedure. Now, with a lot of studies and trials in patients with low risk also, we can use. Earlier it was started for patients in whom there is severe aortic stenosis, what we find out echocardiography. Patient is not suitable for surgery. In them, TAVR was advised. Now, with the advent of newer valves and advancement in the valve mechanism, it can be used in low risk patients also. Next came, this is the most important what we use in our cath lab day in, day out is imaging guidance. That is IVUS, where we use ultrasonography, and OCT, where we use laser for high resolution imaging. This makes life simple for us. When we have a picture, the lesions or whatever stenting has been done, cath lab wise, cinegraphy wise, the lesions are good, there is no complication. But when we do an OCT and see, we may find lot of dissections, under expansion, which are important in long-term prognosis, early or acute prognosis also. So we have OCT on the left side and the IVUS on the other side. So this helps in a lot of decision making on table, pre and post procedures. Then comes FFR or IFFR. That is mainly in layman language, they ask, sir, whether stent is required, stent is not required. This is a method where we can use in the cath lab and decide scientifically whether the blockage is significant, or we can leave it on medical management. Then comes CT or MRI. Now the new buzz around the city is CT coronary angiography. So any patient comes to us with intermediate risk for coronary artery disease, or we want to, the TMT is inconclusive, we subject them to CT coronary angiography for further and calcium scoring to decide whether there is any treatable disease or not. Next comes LV support devices. Mainly, this will be dealt in one of the sessions by our perfusionist, but I just want to put a light on few things, something called Impella. It is one of the boon for interventional cardiologists and also people who are in cardiogenic shock. It can be done without the help of a perfusionist in the cath lab, and high risk procedures can be dealt under the guidance or under the background of Impella. It improves the hemodynamics, and hence we can reduce the mortality and morbidity. Something I told about ventricular septal defect and AS, these are old procedures, but yes, there are newer devices for something called perimembranous VSD. Earlier, there was surgical treatment was the only option for perimembranous VSD. Now we can do a percutaneous closure of the VSD. And earlier there were, if there is a large ASD, we could have sent for surgery. Now there's something called fenestrated devices, which can be used for ASD device closures. Now the newer, one more device, something called penumbra device. It was used for thrombectomy. Whenever in cath lab or whenever we do interventions, there is a lot of thrombus, blood clot. We aspirate mechanically, manually. But there is a new system called penumbra device, which is being used day in, day out by interventional neurologists and radiologists for strokes, which can be used for peripheral thrombectomy, like in acute pulmonary embolism, acute limb ischemia, or venous thrombus. We can put, it will mechanically aspirate all the blood clots. And also in cardiac devices, but it's still not been approved for usage. Now the most important, for all the success of or advancements in cardiology, we need pharmacological support. That is antiplatelet therapy, oral anticoagulation, and high dose of statins, which is the talk of the town in all the conferences. So with the advent of newer drugs like ticagrelor, what we use in our post-procedure patients, IV cangrelor, these all reduce acute stent thrombosis and acute complications, and also the long-term complications. There are a lot of trials, because I told, now I'm talking here, there's already a new advancement happening somewhere else. So it's always an ever-growing branch, and every case is a new challenge for us. So we need to upgrade ourselves every day. So I will try to cover as much as possible in this session. But the future lies in something called robotics in PCI. It came with few machines in where we could do remote telemedicine, and we have done plasties. They have done robotic plasties, but the machine didn't fare well. The new something called AI guided interventions. Why the newer machines, whatever we are getting now into the cath lab, are all AI enabled. They will help in quantification, they'll help in assessing what is a significant lesion or not, and also helping in decision making. So the newer advances will be in gene therapy and regenerative medicine, and most important, personalized cardiology, because every patient is not the same. Every patient cannot be treated as per textbook. Every individual is unique in itself. So we need to practice that personalized cardiology. Thank you. Thank you. In concluding, I will say it has interventional cardiology has transformed healthcare. Ours is a tier 2, tier 3 city. We have 3 cath labs in our city. We are treating patients. Earlier, these patients used to go to the metros. Now we are treating at our center. So this is the first advancement, what I can say we have achieved. So day in, day out, we need to upgrade ourselves. Thank you.
Thank you, sir, for a wonderful talk. Now the session is open for any questions.
Just to initiate, I once again congratulate Dr. Nilesh sir for the extensive knowledge and the interventional cardiology. That is why, sir, I will be telling my liver patients who drink alcohol, say don't drink alcohol because there is nothing in the field of liver. So if something happened to heart, no, see, there are a lot of advances here. The cardiologist won't allow you to die. So, sir, one question for you, sir.
Yes, sir.
This is an era of very defensive practice. Nowadays, we come across patients come and tell, sir, we underwent stenting. Patient reached home, suddenly died. We have seen some of the incidences. After 5 days of stenting, patient dies. And there's usually lot of the attenders make lot of noise. So please guide me regarding this, sir.
Sir, what you told is right. We too have this fear. Once the patient is gone home, we also have that apprehension. He calls us he comes to the ER. The most important reason, one of the reasons, or I will try to put it into 3 reasons. One is acute stent thrombosis, in which there is a blood clot formation within the stent. One. Second is ventricular mechanical complications or electrical complications. That mean to say is he may have a VTVF because the LV dysfunction will be still persistent. We would have just revascularized. It takes at least minimum 3 to 6 weeks for the heart to recover, what we say in the follow-up. So maybe electrical complications, and one can be mechanical complications, in which there will be sometimes we used to read in early in medicine that there is third day there will be papillary muscle rupture, there is increase in MR, there is pulmonary edema, heart failure, or sometimes it can be just a asystole. So these are the most important things which can happen in first few weeks or months of post procedure, sir.
Thank you, sir.
Any question from the audience, sir?
Thank you.
Thank you, sir, for enlightening us about recent advances in interventional cardiology. Now, I request our chairpersons, Dr. Naveen sir and Dr. Murlidhar sir, to present Dr. Nilesh Kumar sir a token of gratitude. Thank you, sir. Now, the next session, I request Dr. Ravi Shankar sir, Senior Interventional Cardiologist, Apex Heart Hospital, Tanjavur, Tamil Nadu. His topic is Hemodynamics in Cardiac Catheterization Laboratory. I request Dr. Naveen sir to introduce our speaker.
It's a pleasure to introduce Dr. Ravi Shankar. Sir has dedicated his 2 decades of exemplary services in the field of cardiology and has been a forefront in the pioneering of interventional procedures. Sir has gained a vast experience in all kinds of complex coronary as well as the non-coronary interventions over the past these years. He is expert in complex interventions requiring assistant devices and imaging like OCT, IVUS guided PCI, as well as the bypass graft interventions, as well as the roto-ablation protective devices, as well as the IABP support and PT-SMA devices, as well as the BME. Sir routinely performs the primary angioplasty as well as the emergency procedures in the patients with the MI. Along with that, he performs all kinds of device implantations, including the pacemakers, ICD, as well as the CRTD. Sir performs the peripheral renal as well as the carotid interventions. Sir has done his MBBS from the Chennai, MD from the Tanjavur, and DM from the Jipmer Pondicherry. Sir has presented various presentations, national as well as the international conferences. Over to you, sir.
Thank you very much for the kind introduction, sir. So I understand the audiences are from cardiac technology, perfusion, as well as from the other courses are also there. So I understand. So initially it was cath lab hemodynamics. So instead I would talk about the basic of the pressure measurements, how to make the setup, what can go wrong, and how to sort about it. So hemodynamics by definition is a force which circulates the blood through the body, describe the intravascular pressure and the flow. So what is the purpose of monitoring? So the many purpose of monitoring inside the cath lab is that we are manipulating inside the heart and we need a continuous monitoring what is happening. So that's why we place a hemodynamic monitoring. In the ICU or in the theater, OT, not just cardiac OT, most of the other OT, see previously there were days when there were no monitors at all in the OT. People just used to space the pulse oximetry and used to monitor the patient. Those were the days. But nowadays it has changed because sir was talking about defensive practice. So unless and otherwise you are adequately trained in that, it is very, very difficult to handle. So as far as hemodynamic monitoring is concerned, you can monitor non-invasively as well as invasively. So non-invasively, the most common method is an inflatable automatic cuff. So that is the most common way in which the other departments monitor. ECG can be an indirect monitor, chest X-ray can be an indirect. Echo is a pretty useful, focus is pretty useful monitor for shock or volume assessment in the ICU. So based on your aortic signals, you can actually estimate the cardiac output. Up to cardiac output, you can actually calculate. So the as far as invasive is concerned, arterial BP monitoring, central venous pressure monitoring, pulmonary artery pressure monitoring, mixed venous oxygen monitoring, and cardiac output. So all these things rely on a basic setup that is flawless. If there is a flaw in that system, then whatever method you use, it will go wrong. So I understand most of you are from Tamil Nadu. So what we call satila irukkiradha aapila varum. What is in the vessel will come in your spoon. If your vessel is wrong, if vessel is empty, however big your spoon is, nothing is going to be there. So your basic setup has to be flawless because it is based on all your readings are based on the assumption that made correctly without anything. So the talk is going to be based on that. So continuous monitoring of systemic arterial blood pressure, frequent blood sampling and withdrawal of the during exchange transfusions are the ones. So as far as the heart is concerned, all of you are aware there are 4 chambers, 2 atria and 2 ventricles are there. So this is one way of looking at the heart, dividing the heart into atria and the ventricles. Other side are more seeing on the physiological point of view or hemodynamic point of view, it is the right sided heart and the left sided heart. Right sided heart doesn't mean there is a heart on the right side, but we divide the right atrium and right ventricle as a right heart and left ventricle as the left heart. So what is the difference? The left system is a high pressure system. On the other hand, the right system is a low pressure system. If you know the fluid, basic fluid physics, you know the fluid flows from a high pressure area to a low pressure area. So this is the natural tendency to flow. But here it is reverse. The blood has to flow from a low pressure area to a high pressure area. So the right sided, if you see the peak pressures over there, the peak pressure on the pulmonary artery is around 25. On the other hand, the peak pressure on the left system is 120. So how to make the blood flow? So this is called in series. It runs from this to this one. This circuit is called a series circuit. So how to make a fluid from a low pressure circuit to a high pressure circuit? You need a pump in between. So for example, if you are living in the hostel or something, if somebody is living on the top floor, they will put a pump in the pipe so that it goes. That pump is the heart. So the heart is the one which reverses this dynamics. It helps the fluid to flow from low high pressure area. So even without the right heart, the blood can still flow. For example, there is one procedure called Fontaine's circulation, Fontaine's operation, where you don't use the right ventricle at all. So it can still flow, but it happens at the cost of higher hydrostatic pressure on the right side. So to avoid that only, so this is the mechanism, what is the function of the right heart. So this, as all of you know, this is called the, so all of you are familiar with the diagram, I believe. So what is this one called? Cardiac cycle. So cardiac cycle or Vigor's cycle. So Vigor's is the one who first designed this cycle. This is a landmark in physiology, landmark in cardiology, landmark in medicine also. So he devised, because before it was, you know what is the actual meaning of the word artery? Artery, the literal meaning, vessel that contain air. So vessel that contain air. So that is what artery means. That's because during the early days when they did post-mortem, the arterial side was completely empty. After the death, all the blood will go to the venous side. It is also called capacitance vessels. The venous circulation is called the capacitance vessels. So when they did the post-mortem, they found only these vessels as empty, where blood is there in the vein. So they thought these vessels are taking the oxygen gas, while this vessel takes the blood. This was the initial understanding of circulation until one man called William Harvey proved that actually a circulation happens. So some of you might have known Harvey's test. It's a simple clinical test where you can do it on your own hand, where you can demonstrate actually circulation happens. Now this is a very, very important diagram to understand everything, whether you are a perfusionist or a cardiac technologist. Everything is based on. So as you can see, this is a high pressure system. See the pressures here, it's 120 and 0. So on the other hand, look at here, while there is a huge discrepancy in the systolic pressures, the diastolic pressures are almost similar, 4 to 8 millimeter mercury. While the systolic pressure, there is a difference of 100 millimeter mercury, while the diastolic pressure, there's hardly a difference of 4 millimeter mercury or 5 millimeter mercury between all the chambers, because it has to receive. It has to receive. So it has to, the pressure has to be lower than the previous chamber. So this is how the movement happens. In the GI system, it is called peristalsis. Here it is called pumping. So on the other hand, the right system is a low pressure system, the highest pressure being 25 millimeter mercury, the lowest being the 0 millimeter mercury. Usually the trigger, so it is very, very important to understand the electrocardiographic cycle of, when we say systole and diastole, it is always in reference to the ventricle only. We are not bothered about atrium as far as clinical setup is concerned. You understand what I say? When we see systole or diastole, it means the ventricular systole and ventricular diastole, not the atrial systole or atrial diastole. So normally the cardiac cycle is 0.8 seconds, out of which the diastole is 0.5 seconds and the systole is 0.3 seconds. So people think this is systole and this is diastole. No, it's not like that. The systole is starts from the QRS till the end of the T wave, and so this is the actual time interval. So this is extremely important, because for example, if you are putting an IABP, the timing is based on the ECG gating only. You will do it with the gating only. So when you want to really alter your gating, you have to check whether the timing is falling correctly or not. So as you can see here, from the peak of the R wave till the end of the T wave is ventricular systole. From the T wave till the peak of the R wave is ventricular diastole. So your balloon must be timed in such a fashion that it inflates during the ventricular systole and deflates during the inflates during the ventricular diastole and deflates during the systole. So that is a very, very key principle in understanding that. So that's the original Vigor's recording. So what is the advantage of putting up an IBP? Why should we do the invasive pressure monitoring? Providing a continuous monitoring, providing access for blood sampling, display of waveform in addition to the BP value, true heart rate in the presence of arrhythmias, and specific management strategies. but it is not without a problem. Complications can happen. There can be bleeding, there can be thrombosis, hematoma, infection, vascular compromise, nerve damage, air embolism can happen, digital necrosis, arteriovenous fistulae can happen if your access site is femoral. So unless, that's why focus has come now. Most of the large, for example, I do, instead of, they were talking about impella. Impella is a costly exercise. We do have impella, but I don't use them much. Instead, I use ECMO. I put them, I use the ECMO in the cath lab for high-risk primary PCI cases. So, because that's much cheaper. Much cheaper concern. Impella costs about 25 to 30 lakhs, while your ECMO initiation will cost you somewhere around 2 to 3 lakhs. So for high risk PCA, primary PCA, where there is a thrombosis at the proximal LAD or something, so I put them electively on ECMO. I do the cannulation. Those cannulas are very big cannulas. The perfusions will be knowing. So that's a large size cannulas. And if your puncture is wrong, you're going to get a hell of a headache. So most of the time, the femoral access is always obtained under the ultrasound guidance. Even though there are situations, even though you would have read VAN, the mnemonic VAN, vein, artery, nerve. The femoral artery arrangement is vein is in the medial most structure, artery is the middle structure, nerve is the lateral most structure. But this is not always true. Sometimes the artery and the nerve may be in an anteroposterior relationship or closely associated with them. You can easily get a puncture from the artery into the vein. And if you put a sheath inside that, you're going to have a hell of a problem. So it is always done with extreme care of getting it under, especially when you're using a large size cannulas like an ECMO cannula. So you have to get it under the ultrasound guidance. So what are the things that can increase the risk of arterial catheter thrombosis is a larger catheter to vessel ratio. For example, radial artery will comfortably accommodate 6 French. Now I have maybe for the last 10 to 12 years, I've been routinely using 7 French catheters. Previously, we used to use only the 6 French catheters. Larger the size of the catheter, please remember during their radial interventions, 25% of the radial artery gets permanently occluded. Permanently occluded. That is the Panjoli series. Based on the Panjoli series, since there is an palmar arch, it is not causing any problem in the upper limb. So otherwise, we'll be having a hell of a problem. So larger the catheter to vessel size ratio, there's a higher chances of the permanent occlusion and thrombosis of the vessel. Prolonged cannulation times, larger cannulation times, multiple cannulation attempts, presence of peripheral vascular disease, venous and arterial femoral catheterization in single extremity, younger age, especially when you do ECMO-like things, you put large cannulas most of the time. So some people, some senior people, for example, one of the oldest centers in the Bombay ECMO where they do contralateral technique. For me, this is practically simple in the cath lab. I cannot be handling cumbersome manner. So I do ipsilateral, arterial and venous, and that's the most standard practice most of the time. So when you take venous and arterial femoral catheterization, the single extremity with the large cannulas, again, there's an increased risk of thrombosis, younger age and thrombogenic conditions. Another important thing is you're applying very high pressure for occlusion. The occlusive bandage post-cath lab procedure, so people tend to use a very tight and completely circumferential bandage that can cause higher rate of permanent occlusions of the radial artery. So that's why there was something called, the Thermo company came with a band actually, the air inflated band, but it doesn't work that much. So how to set up a pressure transducer? So what to do? So what are the things you need? You need a normal saline bag, you need a pressure bag, you need a system and a mount. So these are the things you need. So monitor with an IBP port, a pressure transducer, saline bag or a bottle, cable, pressure bag, IV pole, transducer mount, IBP module. Depending upon inside the cath lab, you use high fidelity transducers like Axiom sensors, MacLab for your GE cath lab or Expert IM for Philips cath lab. These are high fidelity transducers aimed at systems, aimed at with a higher frame rate. They capture at a higher frame rate, so the fidelity is really very high to capture minute events. In the ICU, you will not be having, these monitors are really very expensive, anywhere between 6 lakhs to 12 lakhs these monitors are. On the other hand, in the ICU, you'll be having a routine monitor, contact CMS 8000 is a commonly used prototype. So that's reasonably good, fine also, not bad. So these are the components of the monitoring pressure system. So this is extremely important here. So as you can see there, the multiple transducer systems, for example, in cardiac catheter, in the OT, they need a central venous pressure monitoring. We don't use pulmonary artery pressure monitoring frequently anymore. That has been given up long time back because of increased complications. So commonly what they do is that they will get both a CVP as well as an arterial pressure line. So you can make an arrangement to the same pressure bag or two separate systems. So there is a transducer. There are two transducers. Need two transducers anyway. You can have connect the pressure bags, two pressure bags, or you can use one pressure bag. You use a Y line and do the counter shock with a single pressure bag. So these are the two methods by which you can actually connect the multiple pressure ones. So this is the pressure transducer. We'll talk about this, and this is a flush device. Those people who have not done internship or something who are not seen, the diagrams will explain you. IV fluid, three-way stopcock, pressure monitor, and a transducer cable. So this is the actual photograph of the, okay. Is it working? How is this?
Yes.
No, this is remote actually. So it's okay. Okay. Okay, right. So this is the, so as you can see, this is a three-way stopcock. That's a transducer cable, monitor, and IV fluid is there. So pressure bag. So what is the purpose of the pressure bag? The pressure bag inflates an inflatable cuff on a bag saline, which helps to maintain a consistent flow. So what is the purpose of maintaining this pressure bag? Many times I often come across these people don't keep it inflated, they just hang it without a purpose. There's a purpose for that pressure bag. The purpose is, one is there is a consistent rate of flow to the cannula tip. It prevents clotting, prevent backflow. So if you are not adequately using a counter pressure, see the systolic pressure can be anywhere between 80 to 200, 210, 220. So all these pressures are possible. In such a high pressure, if you are cannulating the artery, there will be a backflow, which will contaminate your transducer. To avoid this, you give a counter pressure that is above, well above physiological and even pathological range. There is a standardized level at which you have to inflate it. The standardized level is 300 millimeter mercury, because usually your highest systolic BP will be somewhere around 200 to, I am talking about the highest BP. 260 also can happen sometimes, 200, 220, or sometimes in hypertensive situations you can come across. So they have standardized, all these pressure tracings have been standardized at a pressure of the saline bag 300 millimeter mercury. So all the original studies were standardized at 300 millimeter mercury. So you have to inflate them to that. So prevent a backflow. Pressure prevents the flow from flowing back. Keep the artery open and ensure proper transducer function. So what do you mean by ensure proper transducer function? It gives a constant pressure of 300 millimeter mercury, prevents contamination of the blood from the opposite side. So pressure bag, so there is another important function. Normally at 300 millimeter mercury and with a normally functioning transducer, the flow is around 3 ml per hour. But if the patient is in shock, for example, the patient goes for a severe vasovagal shock or something in the cath lab or something, you can actually infuse through the arterial line itself. You can infuse at the rate of 30 to 60 ml per minute. So you can, in 1 hour, you can easily infuse about 3 liters through the pressure bag arterial line, because you are usually putting a 6 French cannula or a 7 French cannula. Even through Seclanti you can infuse. So the rate of infusion depends upon the pressure of the receiver, that is the patient. If the patient is in shock, so the pressure gradient between your pressure bag and the patient's pressure, the size of if there's something called the Poiseuille equation. So Poiseuille, in fact, I used to talk about all those things. Then I cut what is practically necessary for the perfusion and the catholic students, I'm keeping only that. Poisson equation is the law that governs the rate of flow of fluid. So the single most important factor that determines the rate of flow is the diameter of your cannula, because that's called fourth power of the radius. The flow is directly proportional to the fourth power of the radius. So when you are increasing the diameter of the inserted cannula, that can increase the flow to the fourth power of the radius. It's not 4 times, fourth power. So 15 to 30 minutes. So this is the actual system in the close-up view. There is a fluid-filled tubing is there. There is a 3-way stopcock. There's a flush system. There's a pressurized saline, and there is a cable signal to the processor. So the transducer is actually a strain gauge. So that's a strain gauge. When it stretches, it produces. The purpose of the transducer is to pressure signals into an electrical signal. So what you are getting is a pressure that has to be converted into an electrical signal and has to recorded in the monitor. So that is what we use. So there are various types of pressure gauges. Medically used pressure gauges or strain gauges. So it stretches. From the stretch, what is the pressure and record is attached to a Wheatson bridge. So based on the resistance, so this is how it assesses. So when known side of the, when one of the, all three other pressures are known, and when one pressure is not known, it can be calculated. That's how a Wheatson bridge strain gauge works actually. So the components of the measurement system and the characteristic are as follows. There's an intra-arterial catheter. The catheter must be kink resistant, biological, inert, and incompressible. The catheter, so these are all comes with the, so these were developed over many years, plastics, steels, if you look at those old things. So they have these things from the manufacturers. So a kink-resistant, biologically inert, incompressible intra-arterial catheter accesses the arterial circulation and provides interface between the arterial blood and the circuit fluid. A fluid-filled tubing. So what is the reason we want a fluid-filled tubing? Why don't we directly connect it? We want only the pressure to be transmitted. We don't want the blood to be transmitted. So this is placed as an interface between the blood and the actual transducer. So this is used for what we call as a hydrostatic coupling or a hydraulic coupling. So the fluid, we want a fluid to transmit the pressure, but we don't want the actual blood to contaminate our transducer. So once the blood contaminates the transducer, it will be clotted and the function will be affected. So we use an inert fluid like saline. Saline is commonly used. The flush valve is there. Fluid in the tubing should be incompressible, usually normal saline, under pressure from the pressure bag to prevent blood refluxing into the line. So the counter pressure fluid bag, as I told you, the standardized pressure is 300 millimeter mercury. You have to watch all the time. So every half an hour to 1 hour, there is, every hour with the 300 millimeter mercury, there will be 3 ml of fluid going inside. So maybe after in the ICU or something, 6 hours or 7 hours, you calculate. As the bag deflates, the pressure will drop. So you have to keep re-inflating again. So you have to make sure that the counter pressure fluid bag is properly monitored and it is properly kept under physiological pressure. The pressure transducer is a Wheatson bridge with a piezo-resistive transducer, signal conditioning and monitoring software. So these are the important thing. Steps of setting up the pressure transducer, the priming the line and calibration. So there are 2 steps here. So one is called priming the line. Priming the line is otherwise called a de-airing. You want to remove all the air from the circuit. So the air is not a good conductor of your pressure changes. You want that to be completely replaced by fluid. That is called priming, and then calibration of the system. So priming has 5 steps. Remove the kit from the pack, mount the transducer on the holder or the arm, de-air, microbubble remove by tapping and flushing by gravity, then under pressure, secure the cap. If previously was vented, make it non-vented. So I'll tell you each what is it. So remove the kit from the packaging, then mount the transducer. The transducer must be mounted. When you mount the transducer, always make sure that the wire is at the bottom. The wire is at the bottom while the patient line is at the top. So this is to this is because the counter pressure line is going to come from above. It is under very high pressure, 300 millimeter mercury. Supposing it gets disconnected, it will splash everywhere. To avoid that, so this is a standard thing where you keep the wire at the bottom and the counter pressure bag is collected out. The counter pressure bag comes along with that, while the patient side is on the top. You can mount the pressure transducer either at the arm or at the level of using a pole. We'll discuss this in calibration, what is the importance. So then de-air. So to de-air the bag, so what you do is you keep the bottle or the bag in an inward position where the air goes up. So as we know, air is of low density, it moves up. So keep the air above and then spike the bottle or your bag. And then open up the your drip chamber. So till the half of the drip chamber is this one. So you close the three-way to the patient side. You want to de-air this circuit, the atmospheric circuit you want to de-air. So the steps of de-airing or priming will be de-air the atmospheric circuit, close this, then de-air the patient side circuit. So this will be the procedure of de-airing. So then you pull the flush valve out. When you pull the flush valve out, the rate of flow is around 30 to 60 ml per minute. So you don't squeeze now. If you squeeze the bag now, what will happen is it will get agitated. You will produce more microbubbles. So initially don't squeeze the bag. So initially allow to get de-air by gravity. You just reverse it, hold it on the top, allow it to slowly flow so that all the air is done till the drip chamber is half filled. Then you confirm the IV hook is securely hung on the IV pole. If it is not, so there are different designs of your pressure bag where it contains a hook or it itself will contain a hook. Most of the pressure bags will contain a hook. You hang it on the hook inside the pressure bag or wrap it along the thread that is given over there. If it is not secure, as the bag deflates, the bottle will fall. So you have to hook it. Do not inflate the pressure bag now. Otherwise, it will inflate the air in the circuit, agitate it, inflate, and produce bubbles on its own. So you allow the line to be primed by gravity first. Once it is done, then later on you can inflate the pressure gravity. So first is to prime to gravity, then keep the completely, then turn the stopcock the other side. You have primed the atmospheric side, then you prime the patient side circuit. Then you can inflate and do a pressure flush and pressure priming. So step is, so remove the kit from the pack, mount the transducer on the holder of the arm, de-air by gravity, then under pressure. So initially do it by gravity or then under pressure. Otherwise, there will be micro bubbles all the time, and that will be, micro bubbles can cause damping. They can cause severe damping. So always make sure that it is not there. So once you are inflating to 300 millimeter mercury, then you can turn the three-way tap to close the inflator pressure so that the pressure remains inside the bag. Low pressure also will cause dampened pressure waveform and incorrect readings. So second step is to calibrate the transducer. So there are 8 steps. One is the connect to the monitor, connect the bedside monitor cable, then level to the phlebostatic axis. Phlebostatic axis is nothing but the level of right atrium. This has been practiced for several years. So this is the standard practice too. So it is the 4th intercostal space in the mid-axillary line. So that is how you have to, there are certain centers abroad which use a Carpenter level, the spirit scale. They use the spirit scale to level the heart. You need not be so meticulously do that. So Carpenter's level might be used. It is important to maintain the level of transducer with a phlebostatic axis at all the time while monitoring the patient to ensure the accurate pressure readings. This is the reason why, for example, in our cath lab, it will be attached to the pole, the transducer. In the ICU, we prefer, at least in our hospital, attaching to the arm, because the patient's position will vary. They will make the patients up or down. All the time, the transducer level will be at the heart of the right atrium. So in the ICU, it is always attached to the arm with us, our practice, or in the cath lab, it will be attached to the pole. This is what is called leveling. So this is the phlebostatic axis, as you can see here. So leveling and zeroing are two different things. They are done simultaneously. People often get confused. These two are two different things actually, but mostly happen simultaneously when you do it. So what is leveling? Leveling is to eliminate hydrostatic pressure. So you want to keep your transducer at the level of the heart. That is considered as a zero hydrostatic pressure. What will happen if you are keeping down? There is a column of blood or the water that is extra, that will exert additional pressure. For every 10 centimeter your transducer is below the patient, there will be a 7.5 millimeter mercury overestimation. So this is extremely important to understand this concept. So in Tamil we call this Yeldre Kutru. So, you know what is that? So some of you might be knowing. So 7.5 is considered trouble in Tamil. So for every 10 centimeter mercury, the transducer is below the body, there will be a 7.5 overestimation, and the reverse as well. For every 10 centimeter, the transducer is above the level of the body, there will be an underestimation by 7.5 millimeter mercuries. It is advisable to attach the transducer to the arm in the ICU, where the patients will be frequently changed in the position. Cath lab it is not possible because there is a gantry which will be moving here and there. We cannot be fuzzing around there, so we keep it in the pole. On the other hand, and cath lab table cannot be, you cannot achieve Fowler's position or whatever position you want. There's a fixed position, so there's no issue of leveling out there. So there the pole is acceptable. In the ICU, it is always preferable to use the arm positioning. So this is usually taken prior to the patient's heart at the fourth intercostal space in the mid-axillary line. Failure to do this results in an error due to hydrostatic pressure. There is an additional column of blood that is exerting pressure. So that will overestimate or underestimate depending upon the transducer position with respect to the position of the heart. Now come to the zeroing the transducer. So what is zeroing the transducer? So zeroing is done to eliminate the atmospheric pressure, while leveling is done to eliminate the hydrostatic pressure. These two are different things. They happen simultaneously. People think both are same. No, both are different actually. You can actually zero without leveling. You can actually level without zeroing. So since both of them are done simultaneously, people think this is how it has to be done. It's not like that. So zero the transducer. For a pressure transducer to read accurately, the atmospheric pressure must be discounted from the pressure measurement. So you have to, this is done by exposing the transducer to the atmospheric pressure and calibrating the pressure reading to zero. Note at this point, the level of the transducer is not important. That's what I'm saying. So leveling and zeroing, you can zero keeping at any level, because that is something done for hydrostatic pressure of the blood column. This is for the atmospheric pressure. So level of the transducer is not important here actually. So your zeroing must be done several times to make sure there is no atmospheric pressure interference. Zeroing and leveling of the artery line. Zeroing and leveling are occasionally used interchangeably, but they are not the same thing. They tend to occur together in the clinical setting, but the terms describe different processes. Zeroing exposes the transducer to atmospheric pressure via an open air fluid interface, and leveling assigns the zero reference point to a specific position on the symbolic fluid fill column, that is the patient's body. So this is the mnemonic I used to teach the people. ZALH. Zeroing nullifies atmospheric pressure. Level nullifies hydrostatic pressure. So that is a mnemonic. So after that, what you do is you close the open the cap and close the patient side. Now press 0 on the bedside monitor. So now only you are starting the zeroing of the transducer. So you are connected to the cable. Open the atmospheric pressure. Then you press 0 there. So make sure that the graph, both the graph and the number. I often see people see only the number. You should, your eyes and your mind must be trained towards this part of the monitor, not this part of the monitor. You should be able to. So many things happen here. Only few things are reflected here. So always focus on the graph side of the monitor. It requires a little bit of training. You see whether it has manually reached the 0 here. Both the graph as well as the number must be at the 0 level. Then you close the stopcock. Connect the catheter. So before insertion of the catheter, the site is prepared. So that's the most important part. So you make all the sterile preparations. Local injection is given, then you access by the Seldinger technique, and all these things will be taught to you. Now, after that, you confirm the waveform. So you have both leveled and zeroed. Atmospheric pressure is nullified. Your hydrostatic pressure is nullified. The pressure reflects the true pressure of the system as per the accepted standards in the literature. Okay, fine. So confirm the waveforms. Now, this is an important test which is not at all done by most centers, but this is extremely important. That's called a square wave test. The square wave test tests the dynamicity of your system. So what is the square wave test? So you pull the flush valve, and the square wave test is a 300 millimeter mercury shock from the opposite direction. When you squeeze the fast flush valve and let the transducer take some of the 300 millimeter mercury, this produces a waveform that rises sharply, plateaus, drops off sharply when the flush valve is released again. How many of you understood what I'm saying? So it's much easier if you see the diagram actually. So that's called a square wave test. So as you can see over here, once you pull the flush valve, it should rise sharply, attain a plateau, fall, and make 1 to 2 oscillations. So ideally 1.5 oscillations is the measurement. So this checks the resonance. So this is called a dynamic response of the system. Can be caused by air bubbles, clotting, excessive length of the tubing, excessive compliant pressure tubing, small bore tubing, loose connections, or leaks. So all these are tested in one shot. If there is a flat square wave and 1.5 oscillations, you know the system is perfect for interpretation. So that's the square wave testing. So you see here, so that's a dichrotic notch. There are many systems. If you look at the crude monitors, they won't be picking up the dichrotic notch. A system which picks up a dichrotic notch needs a high fidelity. So that depends upon its, I'll describe what happens is, so this is a square wave test where it rises quickly, then there is a plateau, reaches down, then there is a 1, 2, and each wave must be less than 1/3 of the previous wave. So this means this is an ideally resonating system. The damping, and after the fast flush has entered, transducer returns to the baseline. It does so as a harmonic oscillator, bouncing a couple of times before coming to rest. This bounce can be used to determine the resonance characteristics of the system. So ideally, for example, I'll tell you why these are all extremely important when you're doing IABP, not IBP, IABP, where your important timing point is the dichrotic notch. So when you're timing it, all these things. So even if the heart rate is 180 millimeter mercury, your system must be able to capture it. When the fast heart rates also must be captured. So the ideal resonance of the system should be 24 hertz, minimum 24 hertz. So this is what makes the difference between a high quality monitor, low quality monitor, high quality transducer, low quality transducer. So whether it is able to capture every event there. So damping, there are 3 terms. One is called the critical damping, over damping, and under damping. Critical damping is the optimally damped, otherwise called optimally damped. Over damping is where it is too much damped, and under damping is there where it is very loose stylus. So as you can see, this is an under-damped waveform. It just keeps on producing too many dichrotic notches, too many oscillations in the square wave test. So this is an under-damped system. So this is what. So low BP means, so over-damped system can underestimate your BP, while high BP, while an under-damped system can overestimate the BP. You understand what I say? It loosely goes up and down, so it should be critically damped. This is an important cause of error measurement of BP using IBP. So when you're when the system is under damped, it shoots very high, falls very low. So it overestimates your systolic BP and underestimates your diastolic BP. On the other hand, your over damped system, it's reverse. It underestimates the systolic BP and overestimates the diastolic BP. So normally we talk about only the systolic BP as far as the shock definitions are concerned. We are bothered about the systolic BP rather than the diastolic BP, as a result of which, so BP can be low in an overdamped system and BP can be falsely high in an underdamped system. So as you can see, this is a overdamped. The top one, the top tracing is a overdamped system, overdamped one. This is an underdamped one. This is an optimally or critically damped one, the lower tracing. So these are the three different tracings. So on seeing the tracing itself, you know there is something with the wrong with the system. So this is a trace from overdamped IBP system. Damping coefficient is more than 1. I have not delved into the details of the physics of the damping coefficient. So the second one is an underdamped system. The third one is an optimally damped system, also called a critically damped system, where the damping coefficient will be around 0.7. So how to calculate the damping coefficient is beyond the scope of this. Now, the arm versus pole, we have already discussed this. So this is a typical 3-port manifold cath connection setup. So this particular, it is nothing but a series of 3 ways connected and manufactured. So your manifold is nothing but 3-way systems merged. So this is one 3-way system, this is another 3-way system, this is another 3-way system. All three are put into a single, so all the 3 gangs are put into a single one. Usually the last one is connected to the contrast, the second one is connected to the pressure bag, and the third one is connected to the pressure line. There are many designs how can you connect it. So one thing is that don't put airway. If you put airway in the saline bag, then with a pressurized bag, it will it will splash everywhere inside your system and it will not be correct. So now, so what are the problems that can happen and how to do that? So power supply turned off. So if there is no waveform at all, then it can mean a power supply is turned off, monitor screen pressure range set too low. If you're keeping your pressure, for example, the line is in the artery and your range is, you're connected to the your preferred monitor is a venous side. So it will be seeing pressure changes at 0 to 25 while the actual event is happening around 120/80. So it will show a flat line. So when the range is set too low from the this one, it can still have a flat line, lose connection in the line, transducer not connected to the amplifier, stopcock off to the patient. You are not properly connected to the stopcock. You have turned the 3-way on the wrong side, or catheter occluded, or due to blood vessel. So what are the things you have to do? Check the power supply, raise the monitor screen pressure range. This is very important because questions are going to come from this now. I purposefully prepared this because this is very important. This can mean life or death in the ICU. Single most important event of using an invasive arterial BP monitoring is treating a shock in the ICU or a hypovolemic shock or whatever. Many times people wrongly interpret this, as a result of which lives are lost every day in every hospital. Particularly on the government side, it always happens. So you have to be very, very thorough with this. So check the power supply, raise the monitor screen's pressure range necessary, rebalance and recalibrate the equipment, tighten the loose connections, position the stopcock correctly, use the fast flush to flush the line. So drifting waveforms is usually due to taking off warm-up. It needs a warm-up. If it is not properly warmed up, there will be drifting of airlines. Line flight fails to flush. You are not able to flush the line. That means usually the stopcock is turned wrongly. Then inadequate pressure from the pressure bag. The artery pressure is around 180 millimeter mercury, or flush is around pressure bag is around 130 or 140. How the flush will go? So flush will not happen. So your inadequate pressure from the pressure bag, kink in the pressure tubing, or blood clot in the catheter. So artifact, patient movement, electrical interference, and catheter fling, particularly in a pulmonary artery catheter or a RV catheter, where there is a huge scope for a fling, and false high readings are because of transducer balancing port position below the right atrium, flush solution flowed too fast, air in the system, catheter tip. Now, we have some questions now. What is the common cause of no waveform in the pressure monitoring system? A, B, C, D. How many of you say it's A? How many of you say A? Any A? How many of you say B? How many say B? No waveform in the pressure monitoring system. A. So how many say A? Okay. A. So how many say it's B? Okay. So how many say C? How many say D? So the answer is actually power supply turned off only will give you a flat line. When the power supply is turned on, why you should give flat line? So that is the wrong answer. A is wrong answer. Answer is B actually. Loose connection in the line. Okay. So a loose connection in the line disrupts the signal transmission from the transducer to the monitor, resulting in no waveform. Ensure all connections are secure in the key troubleshooting step. Which nursing intervention is appropriate for drifting waveforms? The waveforms are drifting. Ignore the monitor. Allow the transducer to warm up for 10 minutes. Increase the flush solution flow rate. Remove the catheter. Let's go back to the actual one. You can see for 1 minute. Now tell me the answer. Okay, so he is quite confident. So allow the transducer to warm up for 10 minutes. So drifting waveforms occur already. It happens due to increased flow rate. If you increase the flow rate further, it won't settle the problem. So what should be checked if the line fails to flush? Power supply, stopcocks, monitor, transducer. Which is the correct answer? Stopcocks for correct positioning. Good. So which of the following can cause artifact waveform interference? Patient movement, proper catheter placement, stable electrical equipment, slow flush solution flow. Patient movement, very good. So no need for any explanation at all. What is the potential cause of false high readings? Transducer below right atrium, flush solution flow rate too slow, transducer balancing port position above the right atrium, above, below, loose connection, slow flow. Which one? Transducer? Which one? A or? High. So high means below the right atrium. It is positioned below the right atrium. Which intervention is not recommended for a hemodynamic line that fails to flush? Check the pressure tubing. It depends upon the size of the cannula. If the cannula is bigger, you don't flush the cannula. If it is a seclanti, a small size cannula, you can actually flush the cannula, because even if the clot is there, it's going to be only a small clot. But if you're going to put a 7 French cannula or a upsized cannulas, there are 9 French, 10 French, 11 French cannulas also. If you're using those cannulas, if you flush, if there is a clot, the clot will get dislodged and you can get thrombus. So you do not use a syringe to flush a cannula with a bigger sized cannulas in place. With smaller sized cannulas like seclanti or this one, you can actually, or a Venflon, you can actually flush the line. What should be done to address a damped waveform caused by air bubbles? Increase motor sensitivity, secure all connections, raise the transducer, ignore. Secure all connections means you de-air. So which factor can lead to false low reading? Which one? Very good. So transducer placed above the right atrium will produce a false low reading. So what is the nursing intervention for blood clot in the catheter causing a damped waveform? So ideally you should try to aspirate. So you always try to aspirate. For example, in my lab or where even the cannula removal should be always done under negative. Should be always done under negative pressure. I am very, very particular about this because I have lost a limb. I have lost a limb during removal. So always make sure you put the whenever you handle the cannula or occlusion deal, always have a negative and remove it, so that even if there is a system is clotted, the clot does not migrate and occlude the vessel. I used to do brachial artery angiograms at that time. So we had a very, very bitter experience before. So which action is appropriate if the transducer is pressed against the vessel wall, causing a damped waveform? So damping can happen because of, that's the most common reason. For example, if you are putting a Venflon, many times when we measure the pressure is not coming properly from the sheath. The most common reason is this one will be abutting a vessel wall and it won't be getting that pressure properly. So you have to change the position. You just flex the arm or extend the arm slightly, you will get a proper pressure reading. So I think those are advanced questions. We will stop here. Or maybe we'll quickly finish this. So what is the first step when IBP readings do not correlate with the patient's clinical presentation? Replace the catheter. Your clinical situation is different because there's one important question which I want to all of you know that. Replace the arterial catheter, verify the equipment catheter setup, administer vasopressors, ignore the IBP reading, rely on clinical signs. So whenever there is a discrepancy between your IBP and the clinical findings, always make sure your equipment is connected properly. So do what all we said, flush the line, zero, level, everything, make sure, then you begin to. So always check the equipment first. What can cause a damped arterial effluent? IBP monitoring, damped air bubbles in the system. So how should the transducer be positioned for accurate IBP measurement? At the level of right atrium, that's the plebostatic axis. What does the square wave assesses in an IBP system? Patient's cardiac output, system dynamics and damping, blood viscosity and catheter infection index. Which one? D. Yeah. B. Okay. So which clinical condition may cause discrepancy between radial IBP and central aortic pressure? One common problem with radial artery cannulation is, for example, when you're putting a seclanty, it's different. When you're using a sheath, there could be a severe spasm that can underestimate your pressure can be happening. So as far as radial artery is concerned, a low IBP can happen due to your radial artery spasm. So what should you do if the arterial waveform appears overdamped? Increase the flush rate, check for air bubbles or clots, lower the transducer, administer fluid bolus, check for air bubbles. The patient's IBP reading is low, but clinical signs suggest adequate perfusion. What is the likely cause? Arterial vasospasm, the radial artery spasm. So what does an underdamped radial waveform indicate? Underdamped. Excessive tubing length. So this is a simple one. So whenever, so you always make sure when the IBP is in doubt, always compare with your NIBP. But for that, the IABP, NIBP cuff size must be proper and its position must be proper. So can anybody attempt this question? What a clinical sign may confirm adequate perfusion despite low IBP? Low urine output. What do you think about A? I want only that. What do you think about A? Whenever the BP is low, for example, in my ICU, the instruction is whenever the IBP is low, your what is that? What do you call that? I forgot. Urometer. The urometer must be drained every 15 minutes. You understand what I say? So there are two types of urine collection bags. One is without an urometer. The other one is with an urometer. The urometer, you empty every 15 minutes. So you will know whether, say, urine output is the single most important clinical indicator of your hemodynamics. That's the only test that checks your volume status, that checks your cardiac function, that checks your pressures, and checks your renal function. All should be normal. If the renal output is normal, if the urine output is normal for the last 3 hours, I'm least bothered what is the number showing. I'm a little bit comfortable because I know for sure that the perfusion is being maintained. So, prolonged arterial catheter use increases risk of what complication? For a long time, if you keep the patient cannulated, thrombosis can happen. When should you consider placing a new arterial catheter in a different site if troubleshooting fails to resolve the problem? So your vasopressors can become discrepancy between IBP and clinical status. Your diuretics can become discrepant urine output when you between your volume status and the urine output. So this is what is the potential consequence of ignoring a damped IBP waveform? Overestimation, underestimation, no effect. So underestimation. Damped waveform can underestimate. Thank you.
I thank Dr. Ravi Shankar for the extensive talk which included anatomy, physiology, physics, everything. And the important nice thing was the interaction of the MCQs. Is it not? See, it is pressures in millimeters. You are asked to, if you are asked to blow a decorative balloons, you are going to blast 2-3 balloons. Is it not? Thank you, sir.
Thank you, sir, for enlightening us about hemodynamics in cardiac catheterization laboratory. Now I request our chairpersons, Dr. Naveen sir and Dr. Murlidhar sir, to present token of gratitude to Dr. Ravi Shankar sir. Thank you, sir. Now I request Dr. Suresh sir to hand over token of gratitude to Dr. Murlidhar sir and Dr. Naveen sir. I request the audience to please applaud. Thank you, sir. Thank you, everyone. Now I hand over the session to Mr. Rajkumar.
Now's the time. Now's the time. We sincere thank and heartful gratitude to our sponsors. One who is Mr. Rajesh, CEO, Bharat Medical System, authorized channel partner for Shimatsu India Private Limited. And another one is Mr. Sudhir Kumar Dupe, Assistant Sales Manager from Bangalore. Please come to the stage, sir. I would like to call our principal, vice principal, and Dr. Palia sir to felicitate them. Please come to the stage, sir.
That's it.
Next, sir.
This felicitation. After that. Next. You are calling me
Next, I would like to call McLeod's Pro Care CB division from. Please come to the stage, sir. With sincere and heartful and gratitude to our sponsors. Thank you for one and all. Thank you, sir. Now I would like to invite Mr. Sudhir sir to present Shimatsu company.
Hello, very good afternoon to all. First of all, I want to thanks to the CDV Medical College chairman sir, respected all the doctors here and all the cath lab technicians, and my special thanks to all the cardiologists who are giving their time to save our lives, sir, especially Ravi sir and Suresh sir is there, Nilesh sir is there. So thank you so much for all of you, sir. So I just want to give the huh? So just brief introduction about the Shimadzu Corporation. So this year we are celebrating 150 years of the Shimadzu. This company has been established in 1875 in the Japan, Kyoto. So currently, right now in the Shimadzu, there are more than 30,000 employees working all over the world. So here, Mr. Genjo Shimadzu Senior, who was the founder of the Shimadzu Corporation, and his son Genjo Shimadzu, who has taken forward for the company for the growth. So these are some of the achievements. Like Shimadzu is the first company in the world who has launched the remote controlled X-ray system in 1961, and first company in the Japan only to complete the medical X-ray system. So, and in 2021, Shimadzu is the only company who have launched the first in the world that the top PET system for head to breast diagnosis diagnosis, and also Shimadzu work in the many fields like medical healthcare system, pharmaceuticals, food safety, environment, energy, chemical, material, electrical, even in the transport. So we are Shimadzu manufacture the aircraft gear systems also. So coming to the analytical system, we manufacture so many types like chromatograph, HPLC systems, spectrometer for the analysis and for the quality management of the all the equipments which are used in the research and the development of the so many other companies. So this is the these are the So these are the like thermotubular pumps we are manufacturing, hydraulic gear pumps, hydraulic control valves. Also for the aircraft system, we manufacture the gear systems and the air control systems also. So now coming to the medical system equipments, we are having the angiography system, which is our Trinias cath lab, which is installed in your college, only CDV Medical College. We are having our Trinias C12 cath lab. We are also having the fluoroscopy equipment, which is Sonali Vision G4 and mobile C-arm system, mobile DR X-ray, and also the radiography system is out there. So Trinias Suroj with Score Opera, which is available in the 4 models. We are having the biplane system, C12 system, and the F12 system also is available. So yes, so in our system, like Score Opera, Trinias series Score Opera, we are having the stent view. So we can have the live stent view, Score RSM, NT-motion, RT-graph DSA imaging, 3D. So you can see the 3D image also of the all the organs like neurovascular, coronary, all the cases you can do. So we are having in the fluoroscopy, we are having the Sonali Vision G4, FlexaVision F4, FluoroSpeed, and FlexaVision series. So Sonali Vision G4 is basically for the tomosynthesis procedures. And we are having the mobile X-ray system like Opioscope Actino and Opioscope FD. So it is with the image intensifier system also and on the FD system also. Mobile dart evolution is our mobile DR. And this is our full room X-ray. So apart from all these things, these are all our centers of the research centers. Like we are having our research center in USA, China, Germany, Singapore, and head office is in Kyoto, Japan. So this is our research and development center in the Kyoto, where we develop our cath lab system and all the medical imaging systems. So these are some of the certificates we have got, like certificates in the Eco First Corporation, Acquired Habitat certification, and the Total Carbon Neutrality certifications. So these are all manufacturing and R&D organizations, and these are all the service stations. So on 8th of the October, we are going to do one webinar, which is with Asia. So in this, from all over Asia, so many cardiologists are going to participate. So anybody he want to join here, like any cath lab technician or any intervention cardiologist, they can join here. Registration is free of cost. And if any cardiologist is interested to participate or present their case, they can also present their case here. So this is the it will be the connecting heart all across the Asia. Discussion and exchange of techniques and knowledge with the Japanese cardiologist. Registration is free. So whosoever are interested, they can send their name, hospital name, and email ID on this WhatsApp number, or they can email me directly. I will get them registered. So this will be like in Indian time, it will be 4 o'clock on 8th of October. So thank you so much. Thank you.
Thank you, sir. It was a wonderful small session on brief of your Shimatsu company, and we are thanking on behalf for sponsoring us. Now it's time to go for a lunch, but before that, we have an announcement that there is culture is going to held in the evening, but we didn't receive the audio track, I mean BGM to be played background. So I want that BGM to be given right now. If you're giving only in the lunch break, your session will be considered for the culturals. And next, I want to know the absentees list. Divya Darshini is present from Balaji Vidyapeeth to present the poster. She has arrived. You have to take seat in your row after the lunch, because after lunch we have the e-poster presentations. Okay. Thank you one and all. And also I have an announcement about the lunch session. Mr. Darshan sir will take over.
Thank you, Nisha. You all can join for the lunch. The lunch is arranged in the lunch hall. Like what morning you had tea and snacks. One by one you can go. Girls and delegates, you can move that side. Boys, we have made a separate section because strength is less. Same menu, everywhere it is same menu. Just for crowd maintenance, you have done that. You want to go together, you can go together. You want to separate it out, you can separate it out. That is not a big task. Just I'm telling, to crowd maintenance, you have made a two venue. Please walk out. Straight opposite one, and this side, left side one.
Thank you so much, sir. Culturals team can meet Miss Muskan and Miss Ruksar ma'am. Please come here.
ஆருயிரே மன்னிப்பாய சொல்லுடி என் சகியே ஆருயிரே மன்னிப்பாய சொல்லுடி என் சகியே ஓ நீ இல்லாத ராத்திரியோ காற்றில்லாத இரவாயாதோ ஆருயிரே மன்னிப்பாய சொல்லுடி என் சகியே ஆருயிரே என்னை மன்னிப்பாய சொல் என் சகியே
Hello. Check, check. I request all the delegates to come back and occupy your seats as the scientific session gonna start. Please come inside. The scientific committee gonna start. Delegates, please occupy your seats back. As the scientific committee is beginning, I request all the delegates to come back and occupy your seats. Hello, delegates. Please come back and occupy your seats as the scientific session is beginning. Come back. Sir, unga family, sir. Yes, sir. Welcome. Welcome. All the delegates are requested to come back and occupy your seats as we are going to start with the scientific session. Open the door completely. Sorry. Yeah, open completely. All the delegates are requested to come back and occupy your seats as we are going to start our scientific session. Final announcement. We are going to begin our scientific session.
Good afternoon, everyone. I request everyone to settle down. Good afternoon, everyone. Had your lunch? So to start, yes. Who said no? Please go and have it. Welcome to the second session. So now in the second session, our speaker is Dr. Bharat Kumar Mohandas. He is a minimally invasive and robotic cardiac surgeon, Apollo Hospitals, Bengaluru. To chair this session, I request Dr. Ravi Shankar sir, Senior Interventional Cardiologist, Apex Heart Hospital, Tanjavur, Tamil Nadu, and Dr. Amit KM, Professor, Department of General Surgery, Sridevi Institute of Medical Sciences and Research Hospital, and Dr. Sharat Kumar Shah, sir, Professor and Head, Department of General Medicine, Sri Siddhartha Medical College, Tumkuru, to chair the session. I request Dr. Amit sir to introduce our speaker to the audience.
Silence, silence everyone. Good afternoon. So it's my privilege to welcome our eminent speaker, Dr. Bharat Kumar Mohandas, a highly accomplished cardiovascular and thoracic surgeon and an expert in minimally invasive and robotic cardiac surgery. Welcome, sir. With his vast experience and exceptional skills in performing advanced and complex cardiac procedures, Dr. Bharat Kumar Mohandas has been pioneer in bringing precision, innovation, and compassionate care to the field of cardiac surgery. His dedication to advancing minimally invasive and robotic techniques has not only improved surgical outcomes but also has set a new benchmark in the patient care. He has finished his MBBS in 2010 from Mahatma Gandhi Medical College and Research Institute, Pondicherry, and DRNB in Cardiovascular and Thoracic Surgery in the National Board of Examinations, New Delhi. We welcome you, sir. Currently, he is working as Associate Consultant in Cardiac Surgery, Apollo Hospital, Bannerghatta Road, Bangalore. His main skills are perform robotic and minimally invasive coronary artery bypass grafting, mitral valve repair or replacement, aortic valve replacement, ASD closure, PA-PVC repair, myxoma excision, aortic aneurysm repairs, etc. We are indeed honored to have such a renowned surgeon with us today to share his expertise on transforming cardiac surgery from sternotomy to robotic and minimally invasive approaches. On behalf of organizing committee, I extend a warm welcome to you, sir. Thank you very much.
Good afternoon, everyone. Thanks for the extensive and warm welcome. Thank you, sir. So, cardiac surgery dates back to 1897, and first median sternotomy was performed by Milton for draining mediastinal abscess. It's the gold standard approach for all surgeries till date. So, you can see the picture of sternum being opened and the heart being exposed. So then why should we go for minimal invasive and robotic approaches? So you can see both patients having sternotomy, post-sternotomy having mediastinitis and infection. So first cause will be infection, second will be hardware complications, osseous complications, and mediastinitis, which is dreaded complication, which creates panic in all cardiac surgeons. It mounts to mortality of 7 to 80% with prevalence of 0.5 to 5% post-sternotomy. So what are the minimal invasive cardiac surgery approaches? It's a modern approach that uses smaller incisions to perform surgery. You can see the scar on the left side of the screen. It causes reduced pain and it's more cosmetic. There is faster recovery. Most of our patients go back to work within a week after cardiac surgery. There is lower risk of complications because soon after sternotomy, we will lose obviously 200 to 300 ml of blood. Here, we don't cut any bone, so there is no blood loss. And less time on the ventilator. Most of our patients are extubated within 2 or 3 hours post-surgery. So what are the approaches? Left anterior thoracotomy. Through this left anterior thoracotomy, you can do a CABG, apical septal myectomy, ventricular septal rupture repair. So in this, you can see the thoracotomy, and I have done a proximal. So first I'll make the marking and then stick an IO band. And just start off with the surgery. So this is the setup after opening the thorax. So you can see an arch and then a retractor pulling the shoulder up and then the rib retractor. And this is how you see inside. So this is how I perform a distal anastomosis. Here I am performing left internal mammary artery to left anterior descending artery anastomosis. I am performing a minimal invasive CABG. You can see the heart beating and I am just performing the bypass surgery. So all the perfusion students here might be exposed to this. So I have an assistant who helps me with Mr. Blower. So in our institute, after all anastomosis, we just do a epicardial ultrasound as well as transit flowmetry. We document this and give it to all our patients, showing how much flow is there after each anastomosis. After doing the bypass, we hand it over to all our patients. So after that anastomosis, this patient had 32 ml flow and there was least resistance. So this is a handheld Doppler probe. I hook it up after the anastomosis is done. And next approach will be upper hemisternotomy. Through this, we can approach the aortic valve, ascending aorta, SVC, innominate vein, pulmonary valve, and main pulmonary artery. So on the left, image A shows the entire sternum being opened, and image B shows upper hemisternotomy. So right anterior thoracotomy. So image A shows where we make the incision, and image B shows the post-op scar. So in this surgery, we do aortic valve replacement and SVC surgeries. So only drawback in right anterior thoracotomy is you will have to sacrifice the right internal mammary artery. Transaxillary approach. So image A shows me performing sinus ASD closure, and image B is the post-operative scar. You can see a 5 centimeter incision. Through this transaxillary approach, you can do aortic valve surgeries, mitral valve surgeries, ASD closure, partial anomalous pulmonary venous connection closure, double valve replacement, tricuspid valve can be approached, myxoma can be excised, hypertrophic obstructive cardiomyopathy surgeries can also be done through this. And posterior thoracotomy. This is quite rare actually. It is mostly used for doing video assisted thoracoscopic surgeries for any lung surgeries. And in this image, I am showing descending thoracic aorta surgery. So image A shows coarctation of aorta in a 23-year-old male. And the same patient I met after a week after surgery. So you can see the scar posteriorly. And this is a small image, video of coarctation of aorta repair. I have put a jump graft because there was so much mismatch between the proximal aorta and distal descending aorta. So I had to use a jump graft using a Gore-Tex. So earlier, even this thoracotomy will be like 12 or 13 centimeters. Patient will have massive pain post-operatively. This boy went back to his college like within a week after surgery. And what are the complications of these minimally invasive approaches? There is limited surgical field. It causes a block in all cardiac surgeons. And it is technically very challenging. You take a lot of time to learn this technique. Because if any complication happens, the surgeon will be very much dreaded and they will try to convert it to a sternotomy. and instrumentation limitations. All the instruments we use are special instrument, long instrument, single shafted instrument for this approach, and they are very costly. Many managements don't support the surgeons with the instruments, and increased operative time. So normally, and conventional sternotomy and bypass surgery will take like 2.5 hours to 3 hours. When you do as a beginner, you will take like 5 or 6 hours to complete the surgery. So that's when most of the surgeons give up trying all these minimal invasive approaches. And then there is always this one. If any complication happens, they convert it to open surgery, and patient and their party will be very much dissatisfied with the surgeon. And always, even though the scar is small, we make a small incision, there is a minimal chance of this wound getting infected. So next, one step ahead of minimal invasive cardiac surgery will be robotic cardiac surgery. I am very proud to announce that we are like very few surgeons in India, we perform this robotic surgery. Hardly like 5 or 10 surgeons in the country will be performing this. So it is minimally invasive. The recovery is much faster compared to minimally invasive approaches. Very minimal pain and scar. Cosmetically the best. And there is enhanced precision. The camera which we use shows 10 times magnification. So which the precision with which we operate with our naked eye is nullified. The camera is so awesome, so good that any surgeon who visits our center will sometime in the future want to become a robotic surgeon. And the least risk of infection. Hardly I've seen any patient coming back to me telling that they have surgical site infection after robotic cardiac surgery. So that is me sitting on the console operating the robo. The best part of this is, see, we have connected it to the monitor. Everyone in the operative room knows what I am doing. If I do any small mistake, they're ready to point it out. So, and even the junior surgeons can learn the surgery. When your minimal invasive approach is, the vision is so small that only the anesthetist, only the assistant knows what I am doing. Now, if I perform on a robo, everyone in the room, even the technician, nurses, everyone knows what I'm doing inside. And this is a robotic CABG setup. So you can see the middle one is the camera, left one is the robotic left arm, and the right one is the robotic right arm. And you can see the scar post-operatively. So this is how we harvest the internal mammary artery, which is used as a conduit for coronary artery bypass grafting. See the image quality. Even small vasovasorum, small blood vessels are being magnified here. So very less chance of doing any mishap or any complications. So this is a robotic mitral valve repair. So again, you can see the setup on the left side. See how beautifully the mitral valve is seen, which we can't appreciate in sternotomy cases or any minimal invasive approach. So that is how we perform the surgery. On the left side, you can see a mitral valve repair ring is there, and see how small the scars are. And post surgery, you can see on the right side, the valve is being repaired. And robotic AVR. So heart is stopped, aorta is being opened. So you can see the aortic valve. The aortic valve was so calcified in this patient, we are just cutting and excising it. See the precision and image quality. And Apollo Bannerghatta was the first center to perform robotic aortic valve replacement in India. The drawback is not much of public is aware of these surgeries. So decalcifying, removing the calcified leaflets. So the calcified aortic valve is removed in toto. So now I am sizing which valve to be used. And taking sutures on the aortic annulus. Now we are pushing in the Inspirus valve. This is a bioprosthetic valve. So this is something called core knot. You need not tie those knots. Just this device will cinch the sutures. So this is how it will look after replacing the aortic valve. Now we'll close the aorta. Entire aorta has been sutured. And the image on the left shows the immediate post-operative picture. You can see below the right nipple, there is the camera port, and one to the left to that will be the left arm. The drain site will be the right arm, and the assistant port will be just below the camera port. And this patient came to our OPD, and this photo was taken like 4 months after surgery. It looks like you have just put an intercostal drainage tube. No one will believe that patient had underwent aortic valve replacement. And this is robotic ASD closure, opening the pericardium. Aorta is about to be cross-clamped. Now we are stopping the heart, giving cardioplegia. Right atrium is being opened. Right heart surgeries, a major role is being played by our perfusionist. So we use the utmost suction device. Most of the centers, they just go around the SVC and IVC. But in our center, we don't. See, there is a fenestrated large ASD. You can see, appreciate the ASD there. See the hole there on the left side? Yeah, that is the ASD. This case was a failed device closure, ASD device closure. So we did a direct closure of the ASD. This is something called Lila loop. We need not tie the suture, just pass the needle through this suture. The other end holds stiffly. So last suture being done. Next, we will ask the anesthetist to de-air the left chamber. See how beautifully the ASD is closed. So left chamber is de-aired. So now right atrial closure. So right atrium is completely closed. See the precision. There is no chance that nothing will go wrong in this surgery. Assistant ties the suture. So what are the complications of this robotic surgery? There is a very long learning curve, prolonged operating time. So the practicing surgeon should not give up. And risk of bleeding is minimal, but if there is any bleeding, again, you will have to go back through the tiny incision and set it up. So again, there is very low threshold for most of the surgeons. They try to convert it to sternotomy. And there is a risk of stroke because we manipulate the aorta, and chance of aortic dissection and arrhythmia. And a little bit on the epicardial ultrasound. After each anastomosis, we put the high sensitive epicardial probe on the heart to see how patent our grafts are after any CABG anastomosis. So you can see this is a left internal mammary artery to left anterior descending graft being done. So it looks like a delta. The top one is the conduit, and the left and right will be the proximal and distal to the artery, and transit time flow metric. And in our center, we always use the cell salvage system. So we always give back whatever blood we have lost while operating. So the blood usage is like 5 to 10% in our unit. 90% of the times we never give any transfuse our patients. Thank you. So patience and perseverance with consistent passion will fetch everything you want in life. And I'm grateful to my wife and daughter and my parents, because I go home very late, I start very early, and I thank my teachers, and that is our big team. I'm grateful to everyone. Thank you.
Thank you, sir. Any questions?
Hello, Dr. Bharat. You are told in a nice way. No doubt. You have covered up everything. But I want to know the role of anesthetist here.
Anesthesia plays a major role here, sir, because all our patients will have to use a bronchial blocker. And transesophageal echo plays a very much vital role, pivotal role. So before the surgery, after the surgery, 24/7, we'll have the transesophageal echo probe being placed in our patients. And yeah, they help us by doing a fast tracking also. They extubate the patients immediately. And we need multiple lines, arterial line, pulmonary pressures to be monitored. And most of our patients, they even put the NIRS to measure the cerebral perfusion also. So anesthesia plays a very much vital role in minimal invasive and robotic cardiac surgery.
Doing minimal invasive, you are told, with a difficult task, which is a difficult procedure you come across.
Almost all surgery is difficult, sir.
But still,
But
anterior, posterior, because we have got circulation in a different way. So you have to put the probe in a different way, or sutures in a different way.
Yeah. So needle angles, you can't be playing defensively like Dravid. You'll have to be a Dhoni on field. So whatever comes you, how much ever you want to, you'll have to change your needle angles. So you should not be conventional surgeon. You should be daring.
Last question to you. Compared to conventionals,
yes, sir.
What earlier CBG, Devi Shetty, so-called, is true, and you are coming with the robotic now. So what is the contrast you want to say? What is the failure rate you want to say?
Failure rate, as I said, the surgeon should persevere. The team should be supportive. Anesthetists, nurses, assistants, everyone should be play a vital role in their part, because initial days the surgery might take much longer time, and everyone will be tired. And another drawback is these procedures are quite costly. Not everyone can afford. maybe over the period of time, the procedure rates might come down. So otherwise, yeah, initial few days you might find it difficult, but now we have a protocol for all surgeries we perform. Everyone is trained now. So our unit has been doing the surgery since 2019. So now everyone play their part, and this ASD got over in just 1 hour's time. AVR took just 2.5 hours. So MSAC ABGs we are doing just for 3.5 hours off late. So our the plateau, the time has come down significantly.
Nice to hear this one. NIRS, you're using Somanetics or Somanetics?
Yes, sir.
NIRS?
Yes,
Somanetics.
yes, sir.
And Cellsaver is Medtronic or?
This one is
Cells-
Medtronic, sir.
Medtronic.
And we need the industry support as well. Yes, sir. Thank you.
Thank you, sir. Now I request our chairperson, Dr. Sharat Kumar Shah, sir, and Dr. Amit sir and Dr. Ravi Shankar sir to felicitate Dr. Bharat Kumar sir. I request our principal and vice principal sirs also to join. Now I request Dr. Yashaswini, consultant Karthik Netralaya, Bangalore, to come on to the dais and join the felicitation. Thank you, dignitaries. Now I request Krishna sir to hand over the token of gratitude to our chairpersons. Sharat Kumar sir, please come on to the dais, sir. Sir Amit sir, Dr. Amit sir and Dr. Ravi Shankar sir, token of gratitude. I request Dr. Chandrapa sir also to hand over the token of gratitude to our chairpersons. Thank you, dignitaries. Now our next session, I request Mr. Santil Kumaran Dhanakote sir to come on to the dais. Sir is a chief perfusionist and senior manager, Apollo Hospital, Bengaluru. To chair this session, I request Dr. Bharat Kumar Mohandas sir and Dr. Krishna MC sir to chair the session. To introduce the speaker, I request Dr. Krishna sir to introduce our speaker to the audience.
I'm very happy to introduce Mr. Senthil Kumar Dhanashkoti. He is a chief perfusionist and Senior Manager at Apollo Hospital, Bangalore. At present, he is working at Apollo Hospital, Bangalore. With extensive experience in the field of cardiac perfusion technology, he has played a crucial role in the success of numerous open heart and complex cardiac surgeries. As a leader in the perfusion team, he had an excellence in extracorporeal circulation, patient safety, and the adoption of advanced perfusion techniques. He has totally 26 years of experience in this field and a renowned perfusionist and good friend of mine. He has presented numerous papers at both national and international conferences. He has won first paper presentation at Hyderabad. Give them a big hand. We are very proud and privileged to have Mr. Senthil Kumar Danakoti sir to address on the topic redefining the beat, innovations and insights in modern cardiac surgery. Over to Danakoti sir.
Thank you so much for the great introduction. I'm very happy to be here, part of this CME, National CME. And first of all, I would like to thank the Sri Devi Institute of Allied Sciences management, as well as the principal and assistant principal, and all the teachers who are working here, and all other faculties here. Thank you so much for me to give a great opportunity to talk in front of the southern Indian student. I mean, all the paramedical students have come across southern India, and I'm very happy to be here. And start with my talk. As a very nicely arrangement was done as a talk. When you say that cardiologist, cardiac surgeon, and perfusionist. See, the way cardiac surgeon will follow the cardiologist, because they have to do the angiogram, angioplasty, whatever thing they will say send to the patient to the cardiac surgeon. And as a perfusionist, we always work with the cardiac surgeon. We don't have any room for working in other facility except cardiac surgeon. We always follow the cardiac surgeon. As Dr. Bharat has come here, I'm just following not only in this forum, as well as in the theater as well. And here the redefining the beat. So what the very good topic they gave me is what is already defined. The surgery has been it is, if you take it history, without talking about history, we cannot talk any even though we are reaching in a different league, but we have to respect the people who are given us so much the path. We cannot go. So traditionally we have been doing it many traditional cardiac surgery. Now we redefining. What does it mean? Redefining the beat. Actually, the redefining the surgery, like minimal invasive, robotic surgery. We are not regular orthodox surgery like stenotomy. We redefining, which is very relevant topic to me. And thank you so much for that. This is what I'm telling. As a perfusionist, the cardiac surgeon's perspective, Dr. Bharat spoke all of that. But I was thinking he will tell about the perfusion also. Then I will not have a role to talk here. But luckily he didn't touch the perfusion side. But even that our chairperson was asking what is the role in anesthesiologist. But you forgot to ask what is the role in perfusionist. That is very important. As a paramedicals are there, a lot of perfusionist are there. Perfusionist gives we can say that when you say arrogantly, yeah, of course we are giving a best platform to surgeon to operate. When you say very polite way, yeah, of course we are a part of the team. Both way we can take it, but definitely we are very vital role during the cardiac surgery, especially minimal invasive cardiac surgery. And when you see perfusion perspective, when you look at this, see where we are. And this is a difference which we have to, as a student, as a upcoming perfusionist or upcoming cardiac care, we must know that what we were doing it. So this is the heart-lung machine which we are using in the earlier, where Dodville GMR heart-lung machine, which innovated long back. And these are the big machines in the theater. Keeping the one machine only, it is required one theater. And when you see this is a Gibbon IBM heart-lung machine, and there's other cross. You all seen this when you would have read it in a book. This cross circulation technique, Dr. Walton Lilly, and this is when you look into Sigma motor pump, and these all things which we have come across, and this become a museum in our level now. This is the machine, which is a myogibbon heart-lung machine, is a huge machine which we were conducting a cardiopulmonary bypass with this big machine. That was a small introduction of our Perfusion side of the history. Now we have come to the topic, which is what is open heart surgery and robotic heart surgery. Where you see these others, the left side, if you see the open heart surgery, where the sternum is opened and retracted, and when you see that it is 6 to 8 inches is open, huge open, and this is a regular and a standard care of doing across globe. This is a standard people are doing. But the other side, the robotic heart surgery, and which is we say that totally endoscopic coronary artery bypass, which not many, if you say that we figure out it with only maximum, if you say that 20 cardiac surgeons are doing across the globe. I'm telling you, in that we are our center is one of the centers we are proud, as Dr. Bharat said. See here, other side, if you see, look at this 1 to 3 days, one maximum 3 days, the patient gets discharged and go home and start resuming work from 2 to 4 weeks, patient start working. And this is an interesting strategy which I see hospitals say. You see that hospitals say blood transfusion, the blood transfusion where we as a perfusion is very, very important role in this. As we use as a self-salvage system, and the inside or pre-operative or post-operative and intraoperative, all the way we use a self-salvage system. So in order to blood, we will not ready to, we'll avoid the totally transfusion. And pain score, you see that pain score also very low, and return to the work is very, drastically very low. Infection rate is definitely low. These are the strategies which is traditional surgery and modern surgery. And what is the introduction which I'm going to talk is what is robotic, and what is MICS and robotic. Perfusion is perfecting, and robotic setup and preparation and peripheral cannulation. Without peripheral cannulation, perfusion is minimally invasive is not possible. And perfusion management in robotic cardiac surgery. And robotic cardiac surgery at Apollo, what we do, our statistics, I'm going to discuss it, and conclusion and Q&A answer. And see that now there's important things. The minimally invasive surgery is a surgical procedure which is operation and performed through small incision using special designed surgical instrument or endoscopy. The term called robot, when you say the robotic, many of you before seeing it, when there's some robot or some arms are operating it, whether it is operating its own or somebody is manipulating it, that doubt many of you have. But I'm telling you, the often robot means robot will go and do it. No, it is not like that. Robot does not do own. Robot performs the surgery. Instead of surgeon perform surgery, robot by using instrument that he or she guide via console. The surgeon will be sitting in the console and you will be manipulating joystick. You will be using a joystick. Accordingly, that arm will be moving inside the thoracic cavity. Robotic cardiac surgery was first described nearly 2 decades ago. Only recently that happened. The first reported case, which is Alan Carpenter, 1998. Robotic surgery, nothing but is the advanced minimally invasive cardiac surgery. See, we see that if you see the concept of minimally invasive cardiac surgery, the access route to the heart, reaching to the heart changes. It is either is a left anterior, right anterior, or upper sternotomy, his route only changes, but the surgical procedure on the heart unchanged. Whatever is supposed to do it in the heart, we never change anything. Whatever you're supposed to do, whether AVR or mitral valve, or it is in a multi-vessel coronary artery regrafting, definitely will be done through small hole. And when you look at the spectrum of the minimally invasive cardiac surgery, and the mini sternotomy and thoracotomy, and minimally invasive thoracotomy, thoracoscopic surgery, and robotic assisted cardiac surgery. These are the spectrum of minimally invasive cardiac surgery. This is a setup which the other side, the console, the surgeon is operated. There's a bedside surgeon who's assisting the surgeon to, giving a suture and taking back the suture, everything. This is where this is a system. This is the way the OT will be set up. And the Da Vinci is one of the recognized and FDA approved system which is used in across the globe. And the proud to say that the India has one more robot which is called Mantra, that also been told. And it is, it is indigenous robotic system which is also the last 2-3 years is started operating. That also will be in future. It will be in leading into India, all across India. A robotic system given the surgeon advanced set of instrument using performing robotic assisted minimally invasive surgery. And system also to deliver the eye magnification. As Dr. Bharat said, it just gives you, see, when you see the 2D, how clear it is there. You have seen all the videos now. This is only 2D. When you look at the 3D, you feel like sitting in the heart and operating it. That is a feel you get it. And that way, you will very precise surgery we can do it. As a surgeon, we'll feel and happy to do exactly what you're supposed to do. When you suppose the mitral valve repair, it is exactly what you're supposed to do. We can do it. Not like even the minimal invasive thoracic things, it will be difficult to do it. When your robotic is very, very precise surgery. The instrument size makes possible to surgeon to operate through one, few or small incision. And make surgery better, provide the surgeon to better production and effective and safety perform the minimal invasive surgery. The new digital architecture provides the best surgical image ever. And what is a perfusion? As a perfusion, I just wanted to know for understanding how many perfusionist student or internship students are here. Just lift there. Perfusionist, all perfusionist. I'm not asking about perfusion student only. Okay, good number of perfusion students are here. And see definitely this will help for them. Definitely, the current social development simulate the introduction of fast expand the minimal invasive. Everybody wanted minimal invasive. Today, see, not only the Apollo, if they go to Narayana Delhi, they go to Jayadeva, they ask for it. Minimal invasive do robotic surgeries because they don't have machine. They don't. But now the social awareness is so much, people think that cardiac surgery, all the surgery can be done through the robotic or minimal invasive. So that much awareness people across the people it has created, but not many people are doing it. But they wanted to get to the minimal invasive only. And the minimizing surgical trauma involves changes in access the heart or requires definitely when you are as a perfusionist, what we wanted to do it. It is not a sternotomy. Sternotomy means we can put a SVC cannula, IVC cannula, and the aortic cannula. Everything done there only. But when you do the minimal invasive, that's totally is covered. Only 2 instruments are going inside. That's it. Then how do you conduct the cardiopulmonary bypass? That means you need specialized instrument, then equipment to control the cardiopulmonary bypass. That is important. And they often lead to increasing of during cardiopulmonary bypass. As Dr. Bharat said, of course, when we are really trained, it is very easy and quickly we can do it. But when you start up any minimal invasive or robotic, it takes its own time to learn. And therefore, as a perfusionist, will be running a pump 3, 4, 5 hours continuously. That makes cardiopulmonary bypass circulation and the less physiological benefit to the procedure. In this situation, what perfusionist we have to take care? What our advancement we to involve in the perfusion as an advanced cardiac surgery they are doing, what we want to do advanced perfusion things. And the perfusion must be ready to adopt this new cardiopulmonary bypass called that is according to alternate the patient condition as well as changes in operating field in order to balance safe perfusion and provide the optimal condition for the surgeon to operate. Now you have seen the ASD closer, you've seen the AVR, you've seen the mitral valve, all of them, there is a person who's sitting and manipulating the heart lung machine where the blood does not flooding out and who's also at the same time also we making it giving all the organs adequate perfusion of blood. That is perfusionist which is doing it. So the surgeons operates and behind that the perfusion will deal this all things. And he should be very much trained to do just that. What made progression into the MICs? There is some to give the records and which is and it is extracorporeal circulation which is developed to improve the extracorporeal. We need to make it different circuit. It's not that we can give as orthodox perfusion, big circulation, big circuit, big oxygenator, a cannula. That no, we need to reduce it, the smaller size of cannula as smaller as possible, and is going to be a femoral artery and femoral vein, so that therefore we need to reduce the size of cannula. Therefore, that extracorporeal circulation is very vital role in progression of MI surgery. And benefit of MI surgery, and which I all know, the technology. Technology is there where our anesthesiologists comes there. The role is very, very important, where they need to have give their input to the cannulation and post-operative, pre-operative, and all the things. They have to be very much. It is all the teamwork. Without the team, there is nothing is possible. The surgeon is, of course, there's a captain of the ship, and anesthesiologists, perfusion nurses are paramount achieve the best clinical outcome. And this is the preparation for the robotic. What do you do? What Dr. Bharat said, all surgical thing is it. As a technologist, as a technician, we are working, surgeon comes in the correct time, operates and get out. And we start from beginning and end to till shifting. We have to be, as a allied science person, we need to be in the theater all the time. So what we should know all the steps from the patient comes in and goes, whether you are going to involve or not, but definitely you need to be there, present. Anytime, any situation, anything is a cardiac surgery, will always be, we should be very much vigilant to be the procedure. The intubation with double lumen endocritical tube, because when you want to do right or left, when you want to do a right thoracotomy and you need to, right lungs has to be collapsed. Only left lungs will be doing it, oxygenating and all. So that way we need to put a double lumen tube for when you're doing anesthesiologist doing the job. And the patient should be supine position and slightly right or left, chest slightly raised, depends on the procedure. Whatever the procedure you want to do, right or left, depends on that. And then external defibrillator is very, very important. Why? Because we don't put internal. As anybody would have gone into work in OT, we know patient gets fibrillated. So we put internal fibrillator and defibrillate the heart. Now we don't have any space to put big puddles inside. Therefore, we use on the external defibrillate on the backside of the sternum, so that in case any defibrillating in the ECG gets any changes, we have to do that, apply that soon. And the pleural space was insufflated with the CO2. Why the CO2 is important and vital role in the minimal invasive or robotic surgery? Because when you insufflated with CO2 with 6 liter or 7 liter, depends on the thing, and there's all the organ gets pushed the other side. The diaphragm pushed down, lungs pushed down, so that therefore the heart is seen and we can operate heart properly. And selected ECG, we need to select the circuit which is minimizing the surgical trauma, also require the minimally extracorporeal circulation. And the cannulation for the robotic, and where the augmented venous drainage is important in future, important. And the two method of augmented venous drainage exist, using 3 type of extracorporeal circular setup. And what is augmented? Augmented means, see, we are as a perfusionist, we are not doing it as a central cannulation. We are taking a blood from the, what is actually most of the people will not know what is cardiopulmonary bypass. When the surgeons operate in the heart and lung, as a perfusionist, we take the blood and give back. We work as a heart, we work as a lung, give back to the patient. So this purpose, when your heart is getting repaired, and then we take the blood in our machine and give back. So that way we need to make it circuit as small as possible. That makes difference to the surgery. So blood will not come from the femoral artery just like that, and it can't decompress it, because unless until you take whole blood from the body, then the heart at least, so then surgeon cannot operate. So that way we use a 3 technique, which is vacuum assisted, because we apply our artificial oxygenator, the reservoir, we apply the vacuum assist. We use the vacuum, so that therefore the blood gets sucked from the venous system and get into the venous reservoir. So that from venous reservoir we can pump into the patient. What is the KAVD? The kinetic assist venous. Instead of vacuum assist, we use a centrifugal pump, which we connect in the venous system, and centrifugal pump will be rotating with more than 1500 rotation, so that the blood will be sucked in the system and get into the venous reservoir. That can be used open circuit and closed circuit, which is very deep in knowledge. And miniaturized extracorporeal circulation is, we use it very like ECMO. We would have seen a lot of people in the COVID time. There are a lot of patients put in ECMO. ECMO is also one of the extension to the cardiopulmonary bypass. So that is the closely they use it. But where cardiac in the theater, we use open system. That's it. So this is the picture says where you take the blood from there and give one side. And if you see, the mouse is okay. So there's a venous where the arrow mark is shown that comes to the venous reservoir, which is a arch cell venous reservoir, and then with the roller pump, it pushes into the oxygenator. There is a below down oxygenator, then it goes to arterial filter where small particle gets filtered and goes to the aorta or femoral artery. The both way you can do it. But in case of any, in this, there is a gravity only. When you use a central cannulation, you can use it gravity. But when you use a femoral venous cannula, we cannot use a gravity alone will not provide the adequate perfusion. So therefore, we use a Atmos suction where you apply into the guard cell. So we regulate it. The blood will be sucked to the reservoir. That is what it says. And then the cavity. In this, instead of the suction, this area is centrifugal pump is kept. That centrifugal pump pull the blood to the reservoir and get into the venous, then it goes back to the patient, oxygenated, and get not only oxygenation, it's also remove the CO2. And that is what the slide says. And what is a miniaturized extracorporeal circulant with KVAD, kinetic assisted venous drainage? Introduced in 1999. It is introduced, and it has been. I'm proud to say that I got a gold medal with this paper only, and in 2015. First time I introduced to the MEC circuit, I have the one who got a paper and statistics things and presented. So far, and nobody able to use it because also there is support from the company. It's very expensive because because all the tubes are coated tubes and the oxygenator all comes together like ECMO. One ECMO set is almost 2.5 lakh. When you use for cardiopulmonary is 1.5. Again, is a cost constraint. It is we can't use it for regular cardiopulmonary bypass, but definitely it is when you use like robotic cardiac surgery. Definitely you can use it, and it gives you so much important. This comes like this whole thing oxygenator, no reservoir comes. So there was a centrifugal pump which inside, that is the rotaflow, maquet, and pre-connected tubing, venous line, filter, everything is there in that. So this is called the MEC circuit, and not in India now they stopped using it, and it's like just same like ECMO only. And when you assemble, it will look like this. And that box, which is sterile pot, will be passed to the surgical site. And the other thing, you can just maintain it. Is a priming volume. When you do a cardiopulmonary bypass for the stenotomy, it will need a 2 liter priming volume. 2 liter of saline push into the patient, which is hemodilution is happened. But here only 500 ml plus 100 ml of minotal, very minimal priming. And when that also will be taken out with the retrograde priming with a little bit advanced training. You can take it out. Only 200 ml of blood only, saline only gets diluted. And this is the heparin circuits are available. And if when you go for cardiac surgery, we need patient weight into 4 mg. You have to give for the heparin. But when you use this circuit, but why you give a heparin? Because we are putting into cardiopulmonary bypass, so that should not be getting clot. But when you use this kind of system, you need not to heparinase too much. Just if you mh, per kg, you can just give 1.5 ml or 2 ml per kg is more than adequate. This heparin comes international unit to see 150 international unit per kg is more than enough to conduct a cardiopulmonary bypass with the MEC circuit. And the flow mainly depends on the prepare. When you comes, it's all very technical things. The patients have more volume, it gives you more. If patient does not have volume, it will not give more. So the preload depend on the so that you need to have much well-trained training for doing this, conducting cardiopulmonary bypass, especially this kind of pump. And if you look at the negative pressure from the venous end will be more than 400 will be. To achieve it will be around 62 minus 60 to 40 millimeter of mercury is enough to. This is what I'm telling is venous side to pull the blood to the reservoir. This is in case of any blood comes, whatever the blood comes out, no, that will be get into the reservoir. That also will get into the circuit. This is a circuit the way they looks. And when I come to the footstep of robotic cardiac surgery, innovation, and advancement, the T is very important. T, the anesthesiologist role is very, very important during robotic cardiac surgery as well as the perfusionist also for the robotic surgery. This kind of variety of surgery, see, minimal invasive, multiple vessel, multiple, you can do multiple vein, arteries, rema, all graft can be done with all kind of, maximum 5 graft you have done it in the small hole. Very, very, very interesting things. This is called anterior lateral mini thoracotomy. We will do it, and mitral valve replacement, and atrial septal defect, and LA myxoma, and DVR. Even DVR we have done many DVRs, mitral valve and aortic valve together will be replaced in the robotically. And AVR to right intercostal space, which Dr. Bharat explained very well. And what Apollo, we do 80% or 85% of cardiac surgery through the minimal invasive. Only 15% we do it with the open system, where the patient is not afford to do it. So we go, our patient is very, very sick, we cannot go for minimal invasive. That condition only we go for the open case, otherwise minimal invasive 80% of cases. And we do it all multi, as I said, with the 2 inches only we do all kind of cases. AVR, and what are the things? And more than 5,000 minimal invasive procedures, which is including robotic, we have done. We are the referral center across India. The lot of surgeon across India comes to our hospital and to getting training for the minimal invasive or robotic surgery. And perfusionist also comes for the 2-3 days workshop and learn things and goes. This is a team where Dr. Bharat you can recognize, and our Dr. Satyaki Nambala is our chief cardiac surgeon who does all things studied in America, and our anesthesiologist Dr. Dharmesh and Dr. Gautam is also assistant surgeon who does independently open surgeries as well as robotic surgery. Where there's Ashwini is a physician assistant. All together we do a wonderful job in Apollo Hospital. And what is the peripheral cannulation? As I told, the peripheral cannulation is very, very important. One of the most cornerstone of the minimally invasive surgery. Any compromise in peripheral cannulation. Suppose before going for robotic surgery or minimal invasive surgery in on pump. Suppose you want to do a on pump cases, we always cannulate femoral artery. If have any cannula problem, any compromise, if any problem, so we will just abandon the procedure. We have to go for the sternotomy. There only, because the patient life is very, very important. We will not take any chances. Every surgeon would experience a limitation. They should have a limitation and technical difficulty of steps during their career. In MICS, obstacles could put whole surgery. If you want to do it, see, as a Dr. Bharat said, you have to play as a Dhoni. I accept it. But a Dhoni also will have you have focus mind. You have to do as a focus mind, you have to do it. And what is with the bat, is a Dhoni. With a glove, I am a Dhoni. That's it. There's only two difference. And every surgeon would be experiencing the limitation and technical difficulty to step during their career. And this is the way the OT setup, where the cannulation is take place. Our anesthesia is very, very, very prompt and very clearly looking at the monitor where the guide wire, where the cannula going, because it's very important. Anything happens in the, suppose if the cannula is not going in the artery or is not going in the venous, it gives you, patient, you can't revive. Patient will get, you can't revive the patient. That's it. That's when the robotic, that's called tile pro condition, where you can see all of them. Even echo you can see, monitor you can see, and patient robotic screen you can see. And this is the way the anesthesiology with the 3D, or this is a 2D, but we have a 3D mission where the cannula, where the going, see that where we take a venous blood from the IVC, femoral vein, the cannula has to go crossing the IVC and sit in the SVC. So that when this echocardiography says the cannula is reached perfectly without deviating any vein, like a hepatic vein is there, renal vein is there, so it should not go anywhere. It goes to heart. So therefore, we can pull the blood from the heart and then give back to the aorta. And this is setup which, if you see the 3D picture, the echocardiography, you see that cannula position. Now you see the robotically, there is a mark, which is a blue mark, I did it. There's a cannula tip you can see. The round cannula tip you can see. That also gives us, see, this is the advantage of robot. Our cannula is placed, so the drainage will be all right. we can make out. And this is setup which I was running a pump for the robotic, where inside what Dr. Bharat said, this is outside what the OT setup look like. And when you give cardioplegia, he said just cardioplegia. But what happens in the cardioplegia? Just you see that when you see that ECG, the heart is getting beating now. When I give a cardioplegia, which is delnato cardioplegia, and there's a storm which you see that what's happening, the cardioplegia getting into the aorta, you can see that. And if you see that ECG getting AC stole, their heart is getting stopped. See, the heart is totally stopped. Therefore, the cardioplegia is working well. This is where that means we as a perfusion also can see in the monitor, oh, our cardioplegia is working well and it's going in a proper places. Okay, and this is a totally endoscopic coronary artery bypass. This harvesting the lima. See that Dr. Bharat has shown the video where there he's sitting and harvesting the lima rima both, and you see that the one side, the other side. After taking it, it has to be anastomosis where the post block. Suppose that block is there in the coronary artery, block is there. It has to be anastomosis post block. Therefore, you are retaining the blood circulation. So there, that whatever the harvested will be connected with the robotically. We do it. This nobody in India has done it. We are doing it. That is very, 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 very proud moment. And we also not. And we are also not able to do multi-vessel with the robotic. Of course, we have small incision, we will be able to do it direct version. But the robotic will need to do that learning curves happening, and octopuses are very important. That once comes, that will be done. That also will be done. And another 2-3 years, I will come here again, present a different league, lived in level. This is coronary anatomy. Anastomosis happens. After anastomosis, as he rightly said, we have to check it. But what he says, we check it. But who check it? Our perfusion check. The perfusion role is here. We record it. And we give the report where, of course, he is the one who done the surgery, and we have to, as a perfusion, what is our job? To record these whole things and take the printout and hand over to the patient, where patient you explain the patient that your surgery went very well. This is a graft, you have done it. And this is a graph where we are done. This is a blood flow across the graph. The pulsatile index is below 3 is excellent. Then in the patient having only 1.2, which is very good. The whatever we have grafted is flowing very well. It shows that. And when you see that robotic ASD closer, this small video, when you can see that interesting, and actually Dr. Bharat has shown this. This is the earlier one. See, and we see that measure that what size. But what Dr. Bharat shown, that is a direct closer. The hole was very small, so that we did a direct closer. But here we need to have a bovine pericardial patch, which we have taken a bovine sterile package. Patch which we stitch across the defect, the ATL defect. There's a shunt between the right atrium and left atrium. There's a blood mixing. As a cardiac technologist, you will know what is ASD. I need not explain, but that has to be closed with the patch. Because a big ASD, we need to close with the patch. And the RA is, you see that a lot of, if you see in a regular case only, so much blood will be flooding over there. But now we are doing a minimal invasive robotic surgery. You see that not much blood flooding out, which is very important for the perfusionist to manage. That is very important. And when you see the other side, the mitral valve replacement surgery, where the mitral valve gets replaced by in the position, and that is a robotic mitral valve replacement. The other side, if you see that tricuspid valve repair, tricuspid valve also can be replaced, but most of the time repair is more than adequate. He is getting a repair. So this is a versatile surgery. We do it every day. And this is a setup which you look in when you look at in the other side. And this is a patient where the Dr. Bharat said differences. And this is a trend of cardiac robotic surgery increase. When you see started in 2019, where we hardly 19 cases we did it, and then COVID came, and this is still in the COVID we have done 34 cases, and then 43, 54, 101. Now last year we have done 128. Is exclude of AVR. When you add AVR, another 15 AVR can be added. So around 150 cases we have done last year of robotic surgery. And conclusion, the robotic surgeries cases number in India are growing because seeing in the training is getting better, because otherwise the people has to go South Korea or China or America to get a robotic cardiac surgery training. But in India we are giving training, and we are able to give accommodate every month three surgeon, and now it's really getting growing, and it's growing fast, including large spectrum procedures. Different procedures are started going. And conversion rate, what is the conversion rate? Even if you're in the during surgery it's not possible, you have to open the sternotomy, no, that is also become low, and clinical outcome is very very favorable. Indication safe conduct of this high-tech minimally invasive surgeries, and requires fast analysis of all available information, timely reaction. The timely reaction in order to balance the safe perfusion and provide the optimal condition to the surgeon to operate. That is our perfusion role. And the surgeon is the captain of ship. Of course, we all know that, but it's no longer tenable because all the health workers who are even including the housekeeping to and the head of cardiac surgery also, everybody's equal responsibility and accountability should have. Then only we can perform the good surgery. The perfusion performed robotic assisted cardiac surgery must master in different type of extracorporeal circulation and cannulation strategy, as well as different technique to assure the proper cardiac arrest and myocardial protection. That is also very very important as a perfusion during cardiac bypass. And it is important to the knowledge the success outcome requires a significant investment. As Dr. Bharat said, the investment training is important. The experience as well as the increasing the cost also very 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 high. So we need to have, not all the hospital can afford. So that like Apollo, like Fortis, the big hospital can afford, but that even the small hospital slowly coming up to robotic systems. The dedication team is, of course, the dedication team is also important. The coordinated effort of surgeons, anesthesiology, perfusion, and nurses is paramount to achieve the best clinical outcome. And what is take home as a perfusion? The minimally invasive and robotic assisted intervention redefine the cardiac surgery to less invasive, more efficient, and safer approaches. The perfusion advancement complement the surgical innovation, optimal patient outcome. The future point to ever the great synergy between the advanced surgical tools like robot and all and perfusion technology. This is what happens as a perfusionist. You can take away home this message. And this is a video, one small video which I wanted to play. Just one interesting video, last one, which includes everything like anesthesiologists. Play. No, it doesn't open. From beginning. I made it with a nice sound, but unfortunately sound is not coming. This is a pre-operative echo. See the 3D echo. There are a lot of MR in the patient. This is a Da Vinci we use. This is a roller pump. This is the Essence Leonova pump. And this is a marking for the cardioplegia position. Clamp is done. Cardioplegia given. Heart is stopped. Mitral valve is getting resected. Where is a damaged valve is got resected. Resection is done. That whatever the prolapsing happening, that is MR, so too much MR, where there's a LV is dilated. Now with the for LV is dilated, for that reason that reconstructing the LV, that annulus reconstruction has happened with a ring, and surgeons operate from the console. Whatever is happening inside the thoracic cavity, he is only the one who is operating there. And in the bedside, surgeon will help you to put all things. These are like a smiley position. You see the metal valve, and echo you've seen the perfusion part, whatever happening there. This the other side, I little bit as a perfusion, I wanted to, I didn't make it much speed in this condition because perfusionist role is important. And anesthesia also always very vigilant to know what is happening in the procedure. Our Sridevi students also watching behind the student. They are coming for the internship here. And there's no leak after that. This is a procedure done. This is our team. Thank you so much, and great opportunity. Last slide. Last slide. Thank you. This one. Anybody have a question, please ask me, or you can contact, feel free to contact. My contact details are here. Any perfusion required, any help, any kind of to know anything, you can always contact me, or you can send me the mail. I'll definitely revert you back. Any questions? Okay. Thank you so much. Thank you so much, chairperson.
Thank you, sir. If there are no questions from your side, there is a question from my side, not to the topic. The youngsters which are sitting like this, 25 years back, you were student like this.
Of course, sir.
So the audience, majority are BSc Cardiac Care Technology and BSc Perfusion Technology. What is their future? What is their job responsibility? What is job opportunities in future? Because they want that. Because robotic surgery now it is increasing, it was not there. So what is your advice to the young budding undergraduates?
Very nice. This is a good platform to ask this question. See that, sir. One thing I'll tell you, the perfusionists are who are studying, if they focus on more learning and hands-on training, they will not get failure, sir. And they will, if they are, I have seen many perfusionists who does not speak good English. When I was in Narayana for 15 years, I know from Kerala many students have come to the as a student. They don't not speak good English, but now all of them working in other different country. That is only because the dedication they gave towards the work, and it made them to become perfusionist. And that is the only thing. Wherever you study doesn't matter, but your focus is whether you want to become perfusionist or just for the time pass you're coming. That is the two things you should be very clear. When you wanted to be a perfusionist, and you need to definitely put so many. And I find it your Sridevi college student who comes, and I found the students are very keen, and like the thirsty crowd, like that they're grabbing very much. Whatever they have, time is very less. They're grabbing so much, and I really happy for that kind of grabbing capacity. And the people who are interested, they will definitely become a good perfusionist. And now the scope of learning is more, sir. There are a lot of centers. Even we plan to start cardiac surgery here. Soon we'll be starting that. There are many peripheral centers starting. There's no problem with the job opportunity, but unless until you are a very good perfusion, even able to handle independently, you will be able to do it. If you are not, you want to be an assistant only perfusion, you will not have a position to do anything. And that is the only thing. Of course, they will have to have a training center. This is a training center you don't have. Many centers, but that has to be facilitated by the principal of college, which we are doing it. And that way you can have MOA with the big cardiac center, and they can send them for the pediatrically, and they can get trained. And during their 3 years course only, they can have to be ready with the all the set of things. They only learn running a pump only takes post BSc or post degree or diploma. So it definitely, when support from you, anyway you're supporting the student side, if they have interest, they can become good professional.
1 minute.
See, even doctors need USMLE to go to US or practice in Canada, and few more exams to practice in the Gulf. But paramedical courses, you don't need any USMLE. You can directly go there if you're good in your career.
Very true.
Thank you for the question, sir, actually. So, see, perfusion technology is one of the most advanced courses of all the paramedical courses. Needs extensive knowledge of cardiovascular physiology, extreme skill. They have to manage very well. In fact, they are almost, so I'll tell you something. We are, since the question was asked, So we are tied up with one UK hospital, Gosh, Great Ormond Street Hospital, and that's a top hospital for pediatric cardiac surgery or pediatric surgery all over the Europe. So the first perfusionist who came, Kiri Wheeler, she was a perfusionist. Now she has completed her MBBS. She's a doctor. Okay. So this is one course where you can complete your medical profession directly because they have a quicker access. Moreover, in the US and in the UK, there's something called advanced APNs, advanced practice nurses. So where people are certified, they can do some procedures independently. For example, coronary angiogram. They can do coronary angiogram independently. So there are certain lists. US has already started. UK is starting now. I frequently visit Newcastle actually. So perfusion technology. I don't know why this question came up, since most of the time it is off pump procedures are going, and so that means the perfusion job. No, most of my center, for example, I'm even in my cath lab there are 3 perfusionists for me, because sometimes I take ECMO based cases, and all our ECMO will be done only under fluoroscopy. Unlike TE,
Yes, I
even
know.
inside the theater, I'll move the CM, I will be cannulating it. So I'll take a CM guidance because perforation can get into a hell of a time. So it's always under fluoroscopy. And ICU, I feel perfusionists are more better equipped to handle than intensivists.
Very true.
So
very
this
true,
is
sir.
the actual situation. So there's no dearth of opportunities or something like that. So it's how you perform. You correctly pointed out. It's your intention. It's your thing. It's not the institute or the course you study, how interested you are in, how you should be serious. Unless and otherwise you are serious, try to understand it and work, and you are sincere. Opportunity is plenty, sir.
There are many roles are there. As you said, the ECMO management is also membrane.
ECS is a highly growing field with high demand. So it's a wrong idea that it is the job opportunities are lesser.
The question why I asked is, majority of the faculty have come from various colleges across the country. In my view, the courses they will start. They will tell the theory part. The practical exposure as skill and dedication has to be exposed on and training in a respective college, the hospitals where the surgeries are going on. So I request all my faculty colleagues from different colleges across the country who are here, train your students. They are the young kids going for a future. As there is no a problem for the job opportunities as such, and also they can thrive better compared to the other technologists. So you will be called as a technologist and assisting the surgeons, and you will have a bright future. Once again, I request all my faculty to take home message is, have the skillful, dedicated technologist and make continued medical education like this in your setups.
Yes,
Thank
very
you.
truly, sir. Very true. That is very true. Okay. Thank you so much, sir.
Thank you, sir. Now I request our chairpersons, Dr. Bharat Kumar sir and Dr. Krishna sir, to present the token of gratitude to Mr. Senthil Kumar Danakote sir. Thank you, sir. Now I request our Vice Principal, Dr. Chandrappa sir, to present the token of gratitude to Bharat sir and Krishna sir. I request the audience to please upload. I request Dr. Krishna sir to hand over token of gratitude to Dr. Chandrapa sir. Thank you, sir. Now I hand over the stage to Mrs. Nishad. Sorry.
Thank you, ma'am.
So there will be a poster presentation now. After that, we'll have a group photo session. So I request all the colleges and faculty students to stay back.
Individual college group photos will be there. Please stay back.
Good afternoon, one and all. I'm back with the session where I pause the button for the poster presentations, which is an important event in our scientific committee. And also it's an important event because all the students who have come from so far to present their talents. So let's begin our poster presentation again. So we stopped at Dhanush M from Nehru Institute of Allied Health Sciences, Coimbatore, to present on the topic Interventional Techniques for Coronary Artery Disease, Current Advances and Future Perspectives. To judge him, we have our two judges. It's my honor to welcome Dr. Ravi Shankar sir and Mr. Sendil Kumar Danakoti sir on dais. Welcome, sir. Again, I repeat, the time limit and the duration for the presentation is 5 minutes. By 4 minutes, you will get a first bell. By 4.5 minutes, you will get a second bell where you have to wind up your session. Okay. Let's begin. I hand over to Dhanush M. Welcome, Dhanush M. You can start.
Good afternoon to everyone. I am Dhanush from Nehru Institute of Health Sciences, studying BSc Physician Assistant. Today, we are going to discuss about the interventional techniques for coronary artery diseases. First, coronary artery diseases is a narrowing or blockage of coronary arteries due to atherosclerosis, which means fat deposition in the arteries. Coronary artery disease remains a major cause for morbidity and mortality with advances in medical technology and procedural technologies. Interventional cardiology has recast the management of CAD, offering the minimal invasive solutions to improve the patient outcomes and quality of life. Introduction. Today we are going to discuss about the angioplasty. Percutaneous coronary intervention, PSC, is also known as a angioplasty. It is a minimally invasive procedure to treat a narrowed or blocked coronary arteries, improving the blood flow to the heart. Some of the procedure we need to do. First, assess and preparation. First, assess. Incision is made in the femoral artery or radial artery. Why we choose radial artery and femoral artery means it is the largest artery in our body. Next, catheter is placed in the inserted place. By the use of catheter, we need to give the guidance by give the guide wire, and we need to give the contrast injection. A contrast injection is a special dye to visualize the blockage in the arteries, and we need to inflate the balloon. The balloon inflation in the blocked area is main role in the angioplasty and placing the stent. When we are doing a PCI, it has some risk factors including bleeding, blood clots, heart attack, and stroke. The PCI can result in the symptoms of coronary artery diseases and reduce the risk of heart attack. It is the diagrammatic representation. First picture represents the plaque formation in the arteries, placing the guide wire and catheter. Second picture represents the balloon inflation. Third picture represents the stent placing with improving the blood flow to the heart. Thank you. Thanks for giving the best opportunity.
So, which is the most important step in angioplasty you think it is? Just make a guess.
Balloon inflation.
Just stop. Can you just show above? Procedure? Just show above. So balloon inflation and stent placement, so angioplasty.
Yes.
The single most important step is getting the wire across the lesion and maintaining the wire till the end of the procedure. That is the single most important thing. Many calamities happen because of loss of wire position. Same thing with ECMO. ECMO wire, you put the cannula, venous cannula is 27 or something, you put it inside, you lose it and you puncture, what will happen? So maintaining the wire position, getting the wire across and maintaining the wire till the end is the most important one.
Okay.
Thank you, Dhanush. Thank you so much. We would like to felicitate you. Please. Next presenter. Next, I would like to call Divya Darshini M from Sri Balaji Vidyapita on the topic stem cell therapy for cardiac regeneration, past, present, and future. Divya Darshini, the dais is yours and the time limit is 5 minutes. You can start.
A very pleasant evening to you all. I am Divya Darshini from Sri Balaji Vidyapit. So today I am going to share the information about the stem cell therapy for cardiac regeneration, how we had the techniques in our past and how we are using it in our present, and how we are going to what are all the options there are in the future. Now let's see about it. So firstly, as we know, cardiovascular disease is the most leading disease in the mortality rate, to increase the mortality rate. So what is the problem here is that once the tissue is injured, it is irreversible to make it as it was as original. So now we are going, the solution for this is that to regenerate the cardiac tissues, what is the usual procedure for usual procedure is we will be just curing the diseases what has happened in the vessels. But here I am going to explain that how we can regenerate the tissues and how we can repair it as it was like normal. So first, the objectives are to compare the stem cells. There are different types of stem cells: embryonic stem cell, mesenterial stem cells, and pluripotent stem cells. These are the major stem cells available in our body. So firstly, how this procedure is continuing is that we will take stem cells from our bone marrow, and it can be from the donor or from the own body, and we will be the stem cells are the cells that can generate and that can functions in many ways. It has many different functions. So if we related to the cardiac tissues, we have to specify the stem cells according to that heart. So after retrieving of the stem cells from our body, we have to specialize the cells and make it more specific to the cardiac cells. And after that, we have to induce the cells in the myocardium, that is the cardiomyocytes. So this is how the procedure is being done. So first, in the past, we had a very traditional procedure like drugs, surgery, and transplants. So now we are exploring the embryonic stem cells, induced pluripotent stem cells, and mesenchymal stem cells. So here we will just induce the stem cells, the fresh stem cells what we are taken out. So this lead to various problems like autoimmune disorders and various diseases. So to avoid these things, in future, what we can do is that we can instead taking the whole cell, we can take only the organelles and exosomes and extravascular vesicles. So by taking that and fixing those organelles alone, we can make it happen so that we can reduce the many hurdle things. So the clinical evidence and trials is that many have shown improved left ventricular ejection fraction and reverse remodeling in acute MI, and also It has tested safety of MSCs in STEMI patients. So in conclusion, I would like to say that repairing the heart is a medicine, but regeneration, it is an innovation. Thank you, sir. Thank you, everyone.
Thank you, Divadarshini. Please be on center. We would like to felicitate you. This poster is very nice. The font size, the background you have matched very well. Nice. The poster presentation is not about just a poster or just a sheet of paper where you cut, copy, put the photos. It's about how you present your talent, how you represent your research paper, and how you put your thoughts into one single sheet. So it's all about creativity and talent along with your knowledge. So the same scientific committee still continues to Pavitra R from Enepoya School of Allied Health Sciences, Bangalore, for the topic prevalence and severity of left ventricular diastolic dysfunction in type 2 diabetes mellitus. Please come. Welcome her with a big round of applause because they have already selected from total 63 posters. So it's a big achievement. Already they are the winners. So you should welcome them with a big round of applause. Once again. Thank you so much.
Good evening to everyone. Myself, Pavitra R from Enepoya University, Bangalore, MSc Echocardiography student, and my co-guide is Munir Ahmad sir, and my guide is Dr. Kumar sir. And my research study is prevalence and severity of left ventricular diastolic dysfunction in type 2 diabetes mellitus. It is a completely echocardiographic study with correlation to HbA1c level. This study is totally based on finer criteria, which is F is feasibility, I is interest, N is novelty of the study, E is ethical of the study, and R is relevant of the study. And coming to aim of the study is to assess the prevalence and severity of left ventricular diastolic dysfunction in type 2 diabetes mellitus patients with correlation to HbA1c level. The primary objective to evaluate the relationship between HbA1c level and severity of left ventricular diastolic dysfunction in patients with type 2 diabetes mellitus using echocardiography. The secondary is to compare the duration of diabetes in relation to LV diastolic dysfunction. And coming to methodology, the study design which I made is a cross-sectional observational study, and the study site is Jaideva Institute of Cardiovascular Science and Research, and my sample size is 93. The procedure is transthoracic echocardiography was performed using phased array transducer to assess left ventricular diastolic function. The HbA1c level and duration of diabetes as taken from the patient files. I have included inpatients and outpatients aged 30 to 60 years who are all diagnosed with type 2 diabetes mellitus, and I have excluded type 1 diabetes mellitus or other specific types of diabetes, and all cardiac abnormalities and hypertension and suboptimal echo windows. Coming to statistical analysis, the sample size is calculated by using the formula, and my sample size is 93. And the data analysis has been performed using SPSS software version 27. Coming to the result of my study, I have, based on the severity of left ventricular diastolic dysfunction with HbA1c level, I have given two variants. The one is HbA1c less than 0.8%, which is controllable group, and the HbA1c level more than 0.8, which is uncontrolled group. Coming to HbA1c control group, grade 1 has 76% and grade 2 has 15% and grade 3 is 7%. Coming to HbA1c more than 0.8%, which is uncontrolled group, grade 1 has 21%, grade 2 has 27% and grade 3 has 11%. Based on the duration of diabetes, I have given three variants. One is less than 5 years, 5 to 10 years, and more than 5 years. Less than 5 years, LVDD has 38% and there is no LVDD, which is 61%. Coming to 5 to 10 years, LVDD has 67% and no LVDD has 32%. More than 10 years has LVDD 77% and no LVDD has 22%. In the end, I have concluded that diastolic dysfunction is highly prevalent in patients with type 2 diabetes mellitus and seems to be positively correlated with the HbA1c level and the duration of diabetes. Grade 1 LVDD, grade 2 and grade 3, which is the pseudo-normal and a restrictive pattern, has significant in HbA1c more than 0.8%, and the longer duration of diabetes was significantly associated with the presence of LV diastolic dysfunction. Reference, these are the reference which has been taken in Vancouver style. Thank you.
So give her a big round of applause because that's an original study. This is the first original study among the posters that was done. Only thing is that, what is that 0.8%? 0.8%. 0.8 or 8.0?
0.8%.
8.0. There's no HbA1c value of less than 0.8%.
Sir, actually, I have sent it other paper for at last night.
No, the controlled diabetes is less than 8.0%. Uncontrolled is HbA1c more than 8.0%. There's no 0.8% calculations. You understand? It doesn't make any sense at all. Both are actually, so what is the meaning of it? So that is the only thing. Otherwise, this is okay. First of all, appreciate you for the original study, but you have to correct this. Okay, so this is a major this one.
Thank you, Divya Darshini, and please felicitate her.
What's your name?
Now I would like to call upon stage Lavanya S from SNS College of Allied Health Sciences, Coimbatore, on the topic miniaturization and handheld devices. Welcome, Lavanya. The dais is yours.
Good afternoon, everyone. I am Lavanya from the Department of Cardiac Technology. So my poster presentation is based on miniaturization and handheld devices in echocardiography. So miniaturization means making technologies smaller in size but more powerful. So today's poster presentation, I'm going to explain that in next generation, how echocardiographic machines are more portable and allowing bedside imaging and rapid patient assessment. So in this, usually we know echocardiography plays a better imaging and diagnostic cardiovascular assessment imaging, and these echo machines are usually very big and we can't carry. So these machines can be connected to laptops and tablets. So where we can, where accuracy of the diagnosing imaging can be used. And there are few limitations, like where in emergency we can use, and less portable, limited transducer options, operator dependency, it depends upon the operator, and less Doppler capabilities. And this can be used in critical situations like acute MI, cardiac tamponade, and this is scanning time is less than 5 minutes. So this can improve the technology in future generations, and AI integration may further enhance the accuracy of this device. So at last, I would like to conclude, if diagnosis could be made in 3 minutes instead of 15, how many lives could we save? Thank you for giving me this opportunity.
Please felicitate her.
As a, okay, keep doing it. As a cardiac care technologist,
Sir.
are you well versed using this?
No, sir. I'm just read an article. In 24, there are many 7 to 8 devices has been implemented, but it has not come under study, I think, sir. So in future, it will improve the accuracy of imaging, sir.
Okay, okay. It's not just you read it and make it a presentation.
Aye, sir.
Okay. Actually, this more, when you use it and then get it any presentation in future, I'm telling, okay, now, okay, in any kind of e-presentation, what you observe in your setup, you make as a representation that it will be relevant to explain your experience to among the audience, or as well as you also take the message from others. So
Okay.
this is what I expect. But now as it is, you cannot now as it is okay, but next year future you do that. Okay.
Nice, sir. Thank you, sir.
There has to be original data collection. That's what he's trying to point out. So you understand what I say. So you get involved in. So in the way you are able to follow up some patients in your internship or something, get a data collection and do analyze it.
Next, I would like to call Raji M from Sri Venkateshwara College of Allied Health Sciences. 2D and 3D echocardiography is her topic. We welcome you, Raji. You can start.
First of all, I'd like to thank you for this great opportunity. Myself, Raji, from Sri Venkateshwara College of Allied Health Science. I'm here to present about the basic 2D and 3D echocardiography. First of all, echocardiography. It is a non-invasive procedure that is used to observe the functions of the heart and its structure. It has two-dimensional, three-dimensional views. Two-dimensional echocardiography. It produces the view in 2D, but it has some abstractions like geometric assumptions and analyzing volumetric examinations. But 3D overcomes all these abstractions by providing the accurate images of the heart. Introduction. Two-dimensional echocardiography. It creates images in 2D using the ultrasound by swept across the area of interest. Ultrasound is transmitted along several scan lines over a wide arc and many times per second. But 3D is not created like that. In earlier days, 3D is created using the multiple 2D images to form the 3D view. But nowadays, the technology is developed and the machine automatically creates the 3D view. The methods used. For creating a 2D view, we can use the standard transthoracic echocardiographic linear probe using to view the heart structure, functions, and its valve size and valve pathologies. But 3D is used. 3D uses matrix array probe for the clearer view of the heart. It overcomes all the abstractions that the 2D cannot provide, like calculating the accurate ejection fracture and ventricular dimensions. As a result, 2D provides real-time cross-sectional images of the heart, but it has its inherent limitation. 3D overcomes all these limitations by providing the volumetrically accurate images. So in now modern days, 3D is essential for the evaluation of the heart function and structures, because nowadays many childs are born with many congenital defects, and some are not easily detected using 2D echocardiography. So advancement in the 2D echography is essential in our medical care, and it is widely used in nowadays for the cardiac care. Thank you.
Thank you so much, Raji. Any questions to the panel? Raji Yam. Illa, sir, Palamika is not present. That next one. Raji Yam. The next presentation is from Nehru Institute of Allied Health Sciences, Coimbatore, Mahashri M. I welcome Mahashri M on the topic of advance in echocardiography. You can start.
Good evening, everyone. My name is Mahasri, studying BSc Cardiac Technology second year from Nehru Institute of Health and Science. Today I am going to explain the e-poster about advanced in echocardiography LV segmentation by using this application CNN. First, we discuss about what is echocardiography. As we all know, echocardiography is a most important diagnosis for detecting As we all know, echocardiography is a most important diagnosis for detecting structural and functional abnormalities of the heart. It's a cost efficiency to evaluate the heart functions. In heart, there are 17 segments that we are using by this method CNN. CNN means convolutional neural network. Convolutional neural network is a type of artificial neural network used primarily for image recognition and processing due to its ability to recognize patterns in images. Uses of CNN. First, cardiac structure identification and segmentation can be trained on echo images to identify and define different cardiac structure like ventricles, atria, and valves. Second, cardiac function assessment can analyze echo images to measure the function like ejection fraction value, stroke volume, and cardiac output. Third, phenotype prediction. A unique application of CNN is in echo images is ability to predict systemic phenotype like age, weight, and height from echo images. Fourth, disease diagnosis can be trained to classify echo to find it is normal and abnormal. What is disease occurred like LVH, stenosis, and regurgitation. Advantages of CNN. Automatic features extraction, high accuracy, efficiency, potential for real-time analysis. Disadvantages. It requires large amounts of training data and computational power to train. Thank you.
From where did you get this?
Sir, in article, sir.
Which article?
Sir,
What is CNN first of all?
convolutional neural network.
So what have they done?
They have done 17 segments, sir. It can automatically deduct from that, sir.
Okay.
Thank you so much. Thank you. Now I would like to call Harshavardhini JB from Sri Venkateshwara College of Allied Health Sciences on the topic of hypothermia in perfusion. Welcome.
Thank God, ಅದು one perfusion come out. I was waiting for one perfusion to come on.
Thank you. Good evening, honorable present here. I am Harshavardhini pursuing Perfusion Technology from Sri Venkateshwara College of Allied Health Science. I am here to present the role of hypothermia in perfusion. First of all, hypothermia is not a machine, it's a state. Hemotherm is the machine which we are used to attain this state. It's when the body's core temperature lowers below 35 degrees Celsius, leading to impaired physiological functions. When hypothermia and perfusion refers to the deliberate lowering of the body's temperature during cardiopulmonary bypass to reduce metabolic demand and protect vital organs. Hypothermia is perfusion is no longer just about cooling. It's about precision and data-driven strategies. In perfusion, it is widely used to reduce metabolism and protect organs. Modern use spans cardiac surgeries, post-cardiac arrest care, and organ transplantations. Its goal is to balance organ protection with risks of cooling and rewarming. Recent trials shows that hypothermia is evolving from a protective blanket to a targeted tool guided by real-time evidences. Based on Newton principle, metabolic rate drops below 50% for every 10-degree decrease. Its main focus is to protect brain and heart during ischemia. From 2023 to 2025, we have seen three shifts. Moderate cooling in surgeries, fever prevention after cardiac arrest, and Oxygenated machine perfusion during organ transplantation. Its temperature ranges from mild, moderate, profound, and deep. Mild ranges from 32 to 35. Moderate ranges from 28 to 32. Deep ranges from 14 to 20. It reduces cerebral metabolic rate by 6 to 7% per degree Celsius. It also decreases oxygen consumption and extends ischemic tolerance. In cardiac arrest, fever prevention matters more than strict hypothermia. The risks are coagulopathy, arrhythmias. The risks are coagulopathy, arrhythmias, longer bypass times. Here, we are moving from a colder versus warmer debate to a target to a data-driven hypothermia. Perfusion is not just about physiology, but also logistics. The portable devices shifts risky night surgeries to safe daytime operations. Here, the some are organ prevention, neuro prevention, safety margins during arrest or some benefits, but there are some issues too. Viscosity changes, coagulation issues, and rewarming complications or some issues. At last, we have clearly seen that hypothermia is a key protective tool to perfusion. It must be clearly managed, especially during rewarming phase. Individual approach can give best outcomes. Here are the references from recent scientific journal articles and clinical guidelines that published the recent finding about hypothermia in perfusion. Thank you.
One question from me. Hypothermia, of course, this is very important during cardiopulmonary bypass, especially where we need a very patient where we do aneurysm or this pediatric case like all congenital heart disease, very complicated congenital heart disease, where we go for deep hypothermia and all. Everything you covered. But what I want to do as a perfusionist, when you do a hypothermia, what is more in a blood gas, what stat you maintain, whether a PK stat or alpha stat, which that has to be also mentioned, very important. That is very important during hypothermia, what state you maintain, PH or alpha stat? That is my question.
Alpha state.
Why? What is alpha stat? A, B. Why? Okay. It is nothing to you are, otherwise you have presented well. For the audience purpose, I just want to tell you, when as she said very rightly, she pointed out, and it's a two organ is very important during hypothermia. One is heart and another one is brain. The brain, when you take care of the brain, when you are as a viscosity, when you are hypothermia patient, the viscosity is increased. As you said, very rightly said, viscosity is increased, and all the thrombus complication increase, all other complications. Okay, I understand. But when you are cooling the patient, you are reducing patient. As you said, 50% of metabolic requirement goes with 10 degree of Celsius cooling. Okay, when you cool it, we are reducing the flow 50% down. Okay, that time all organs will be okay, but brain will not be okay. Okay, therefore we need to make it as good. The CO2 has to be maintained. When you are running a pump or when you are doing anything, CO2 is a main culprit in a vasodilator. Vasodilator, the CO2 is a vasodilator, cerebral vasodilator. When you maintain CO2 has to be maintained. So therefore you will protect the brain. Otherwise it will be difficult. That is what I want to tell you. The CO2, if you would have mentioned one point, it would have been 100% success. Okay, thank you.
Thank you so much.
Thank you, Arshavardhini. And my dear students, I am back here to talk to you for 2 minutes. The poster presentations or this abstract presentation is not for the panelists or not for the judges. These are for you to learn so that you can develop your research knowledge and interest from BSc. Once you go to MSc, it's all about paper presentation. From MSc, you will do your PhD and you can go into any research sector. It is very important that you pay attention here and learn all those small skills, like what is the poster size and what are the fonts they have used and what technique they have used, what graphics they have added. All this you have to see and pay attention. I hope you understood. Now I would like to call Komal Rathore from Saptagiri Institute of Medical Sciences and Research Center, Bangalore, to present a very interesting topic, AI-driven left atrial strain for early prediction of atrial fibrillation. Welcome, Rathore.
Thank you for introducing me. Good evening, everyone. I am Komal Rathore, a cardiac care technology intern at Saptagiri Institute of Medical Sciences and Research Center. My topic for today is AI-driven LA strain for prediction of new onset atrial fibrillation. As we all know, atrial fibrillation is the most common and sustained arrhythmia associated with high morbidity and mortality rate. Not just mortality rate, it can also lead to complications through these complications such as stroke, systemic embolism, and heart failure. Therefore, it becomes very critical to detect the atrial fibrillation in the earlier stages. Okay, as we move on, atrial fibrillation will develop slowly due to progressive atrial cardiomyopathy, and traditional methods such as atrial size and diastolic dysfunction or left atrial volume index usually indicates about late remodeling. What about the early remodeling that is occurring? So, left atrial strain measures atrial deformation, thereby providing insight into stiffness, compliance, and the fibrosis of atrium. AI enhances left atrial strain assessment, transforming a complex tool into a routine, reproducible, and clinical parameter. How do we do it? For methodology, we use automated recognition of apical 4-chamber and apical 2-chamber view at the end systole. AI-based endocardial border is traced, carefully excluding the pulmonary veins and LA appendage. Using speckle tracking, strain curves are generated for the left atrium. The strain curve usually has 3 phases: the reservoir phase, the conduit phase, and the booster pump phase. But for our atrial fibrillation, we only need the reservoir phase, which is seen as the peak positive deflection of the LA strain curve. As you can see in this image, the peak of the wave predicts the reservoir strain. What does it represent? It represents LA compliance, that is the ability of the left atrium to stretch, LA fibrosis and stiffness, that is if there is reduced strain, that indicates that there is more fibrosis. And there is also early remodeling of atrial myocardium. So we'll go on to the discussion part. Normal LA reservoir strain is greater than 34% and borderline is between 25 to 34% and abnormal is lesser than 25%. The result shows that LAS, that is left atrial strain, detects atrial dysfunction earlier than the conventional indices, that is the traditional methods that we are currently using, which can be replaced by artificial intelligence driven LA strain measurement, which not only takes lesser time but also minimizes inter-observer variability. Early detection of at-risk patient using AI-driven LA strain can enable preventive interventions such as lifestyle changes, closer monitoring, or timely therapy. Thank you.
Thank you, Komal Rathore. Sir, any questions?
atrial fibrillation, suppose this is our presentation. What is treatment? Suppose your early detection, what, okay, you can prevent the surgical intervention, but what is if it is, you find it, we need to have a surgical intervention, what are the, any idea about it?
Yeah. So first of all, we can go with rhythm control. We can give antiarrhythmic drugs, anticoagulation for avoiding stasis of blood, which can later on lead to stroke. So we can prevent it by giving anticoagulation drugs and antiarrhythmic drugs. But if it advances, then catheter ablation is the go-to for atrial fibrillation.
Have you seen that how they do it? I mean, you will not do, as a student they wouldn't have allowed you to.
Yes.
Have you seen it in the cath lab how they do it?
Sir, I have seen electrophysiology study, but catheter ablation I'm not.
Even as a surgical, surgically also we do it.
Yes,
ablation, mitral valve replacement or repair with ablation we do it in surgically, and interventional the cardiac care or the cath lab doctor cardiologist may also do it.
Yes.
Okay, 1 minute.
So as such, the treatment part of atrial fibrillation is very difficult to treat actually. The success percentage with all your ablations is around 50 to 60%. Surgically, Cox-Maze procedures around the same. Leave that part. So what is it? So as far as AA is concerned, it's, I told something before. What's in the vessel will come in the spoon. What's not in the vessel will not come in your spoon. The acquisition part is the most important. It's not the AA. It's not, we do something. See, my professor, when I joined MBBS, he used to tell, the surgeon he was, don't think that you will throw stone at the mango tree, the mango will fall. This is something he used to tell. So you cannot imagine that you put the probe and switch on the AA or 3D, you will get everything sorted out. No, it's not that. So how the acquisition part is the most important part of the sonographer or the echocardiographer. Unless and otherwise that is done, and the the incremental values of the strain imaging as such is questionable, highly questionable. So leave alone the AA part of it. Even the strain imaging, the incremental value, diagnostic value. So these are all more of promotional gimmicks. Then I'm not very confident that these things will stand the test of time. You understand what I say?
But the thing is, myocardial remodeling can be checked earlier on. Like usually for atrial fibrillation, what do we do now? We usually go by LAVI, that is left atrial volume index. So we can just trace the atrial remodeling even before there is a dysfunction in the left ventricle.
Yes, but
Yeah,
so what kind of interventions we have for that at that stage? We do not have. See, somebody presented the diabetes and left ventricular diastolic dysfunction.
Yes,
I presented that in MD 25 years back. 25 years, what improvement has happened? Nothing has happened. So that's what. So what, unless and otherwise we have a specific therapy directing at it, showing your convincing, treatment differences, these things will not really affect much. But okay, as a student, it's fine. Good topic. Yes.
Thank you, sir.
Thank you, Komal Rathod. Now it's time to talk to you again for 2 minutes. It's about the tea break now. A high tea has been arranged, but a small announcement is after we have remaining 5 more postures. After this, you have excitement prizes. For you also have cash prizes. You also have hidden gifts. Everything from the e-poster committee. So you all go to the tea break and come back immediately so that you can grab your prizes. You can go for the tea. Thank you so much.
सर चार्जर कनेक्ट ಮಾಡಬೇಕು ಎಲ್ಲಿ ಸಾಂಗ್ ಐತಿ ಇಲ್ಲ ಬ್ಯಾಂಡ್ ಮೇಲೆ ಬಾ ಹೊರಗೆ ಪೆನ್ ಡ್ರೈವ್ ಏನದು
कहने को जश्न बहारा है इश्क ये देख के हैरा है कहने को जश्न बहारा है इश्क ये देख के हैरा है फूल से खुशबू खफा खफा है गुलशन में छुपा है कोई रंज फिजा की चिलमन में सारे सहन नजारे हैं सोए सोए वक्त के धारे हैं और दिल में कोई कोई सी बातें हैं ओ कहने को जश्न बहारा है इश्क ये देख के हैरा है फूल से खुशबू खफा खफा है गुलशन में छुपा है कोई रंज फिजा की चिलमन में सोचते हैं अब ये हम कोई कैसे कहे वो है या नहीं हमारे करते तो हैं साथ सफर फासले हैं फिर भी मगर जैसे मिलते नहीं किसी दरिया के दो किनारे। पास है फिर भी पास नहीं, हमको ये गम रास नहीं। शीशे की एक दीवार है जैसे दरमियां, सारे सहमे नजारे हैं, सोए सोए वक्त के धारे हैं, और दिल में खोई खोई सी बातें हैं। हो कहने को जश्न बहारा है, इश्क ये देख के हैरा है। फूल से खुशबू खफा खफा है गुलशन में, छुपा है कोई रंज फिजा के चिलमन में। हमने जो था नगमा सुना, दिल ने था उसको चुना। ये दास्तान हमें वक्त ने कैसी सुनाई। हम जो अगर हैं गमगी, वो भी उधर खुश तो नहीं। मुलाकातों में है जैसे घुल सी गई तन्हाई। मिलके भी हम मिलते नहीं, खिल के भी गुल खिलते नहीं। आंखों में है बहारे, दिल में खिजा, सारे सहमे नजारे हैं, सोए सोए वक्त के धारे हैं, और दिल में खोई खोई सी बातें हैं। ओ कहने को जश्न बहारा है, इश्क ये देख के हैरा है। फूल से खुशबू खफा खफा है गुलशन में, छुपा है कोई रंज फिजा की चिलमन में।
నీ కళని పట్టుకు వదల నన్నవి చూడే నా కళ్ళు, ఆ చూపులనల్లా తొక్కుకు వెళ్ళకు దయలేదా అసలు. నీ కళ్ళని పట్టుకు వదల నన్నవి చూడే నా కళ్ళు, ఆ చూపులనల్లా తొక్కుకు వెళ్ళకు దయలేదా అసలు. నీ కళ్ళకి కవలి కాస్తాయే కటుకల నా కలలు, నువ్వు నులుముతుంటే ఎర్రగ కంది చిందే నేసెగలు. నా ఊపిరి గాలికి ఉయ్యాలలుగుతూ ఉంటే ముంగురులు, నువ్వు నెట్టేస్తే ఎలా నిట్టుచబట్టే నిష్ఠురపు విలవిలలు. చూసి ఆగగలనా మనసు
మీద వయసుకున్న అదుపు చెప్పతన్నా సామజవర గమన నిన్ను చూసి ఆగగలనా మనసు మీద వయసుకున్న అదుపు చెప్పతన్నా ఈ కడని పట్టుకు వదలనన్నది చూడే నా కళ్ళు ఆ చూపులనల్లా తప్పుకు వెళ్ళకు దయలేరా అసలు
Stop. A small announcement, as two of the colleges have to leave to Bangalore, but we have a small privilege that they can take a group photo with all the students and with our dignitaries. So you can please come on the dais. The leaving people can come. The remaining poster and cultural presentation students have to stay back. Till that, please be seated on the dais. Please be seated on the seats. We will call you. Please be seated. Don't be crowded. Please take your seats. We have to felicitate each college with a memento, a gift and token of love. So till that, please be seated.
నీ కళని పట్టుకు వదలనన్నవి చూడే నా కళ్ళు ఆ చూపులనల్లా తొక్కుకు వెళ్ళకు దయలేదా అసలు నీ కళని పట్టుకు వదలనన్నవి చూడే నా కళ్ళు ఆ చూపులనల్లా తొక్కుకు వెళ్ళకు దయలేదా అసలు నీ కళ్ళకి కవలి కాస్తాయే కటుకల నా కలలు నువ్వు నులుముతుంటే ఎర్రగ కంది చిందే నేసెగలు నా ఊపిరి గాలికి ఉయ్యాలలుగుతూ ఉంటే ముంగురులు నువ్వు నెట్టేస్తే ఎలా నిట్టుచబట్టే నిష్ఠురపు విలవిలలు
Come back from the tea break. As we are going to start our session, please come back from the tea break. Please occupy your seats fast. We are starting our session. Come back everyone. We are starting our session. Please come back. Occupy your seats. All the students are requested to come back and occupy your seats.
అసలు
A small request to all the coordinators and to all the students. As we have come to the end of the session anyway, it's just a matter of 15 to 20 minutes where you can learn again some more posters. The remaining are only 5. So kindly you can be the audience for them and cheer them with your big round of applause so that we can continue this session and finish it off. Now I would like to call Balambika G from SNS College of Allied Health Sciences, Coimbatore, on the topic goal-directed perfusion using AI precision care. Welcome, Balambika. Please settle down fast. Judges are requested to come back to their panels. Start. Time starts now.
Good evening to one and all. I am Balambika from Department of BSc Cardiopulmonary Perfusion Care Technology from SNS College of Allied Health Science. Here I am going to explain about goal-directed perfusion using AI precision care. Prologue. Goal-directed perfusion is a strategy. Goal-directed perfusion is an individual approach to cardiopulmonary bypass. Aim. It optimizes the oxygen delivery and blood flow and pressures like central venous pressures and mean arterial pressures, and it minimizes the organ injury. There are two goals are present in that. It reduces the complications and enhances surgical outcomes. The complication that would be avoided by
One minute. Let the student sit. Please give her silence so that she can explain well. Thank you.
Complication that would be avoided by AI in goal-direct perfusion is acute kidney injury. It oxygen delivery. It monitor oxygen delivery and predict the low flow and low HT level. Neurological dysfunction. It monitors the cerebral pulse oximeters like near-infrared spectroscopy. Hemodynamic instability. It continuously monitors the flow, pressure, and temperature of the patient and vital signs of the patient. Coagulation and bleeding issues. It continuously monitor and test the ACT every 20 to 30 minutes, and any complication occurs, it will actively react. Inflammatory complication and tissue hypoxia and lactic acidosis. Advantages for the perfusionist. It continuously monitor multiple parameters throughout the surgery. It will predict early and give time for perfusionist to act the time. And it decreases the workload of the patient, and it decreases the and support the perfusionist to focus on patient care and safety. It predict and give the time for perfusionist to act. It will support for the perfusionist and guide the perfusionist to do correct. Consistency and accurate performance without getting any tired, and enhanced better outcomes. Futuristic uses. It is a closed loop. We don't want to adjust it. It will automatically adjust it, the flow, temperature, and oxygenator without manual intervention. That means the perfusionist will not have any work. That means that not. It will automatically correct the flow, oxygen, and temperature. Digital twins. It stimulates the virtual model before the surgery and give the details for the perfusionist and the surgeon. Predict dashboard. It already predict the data sheet of the perfusion record, and it will continuously monitor and will market the data. Teleperfusion monitoring. AI guided system will continually monitoring, remote monitoring and control of perfusion system. Learning outcome. From thousands of perfusion cases, it will continuously learning about the perfusion. The two cons are there. Data quality issues and technical failure. For that, we can test the AI weekly once. We want to test the AI by giving some problems to AI while it is solving or not. AI is not integrated in India. It is using in foreign countries. AI integrated in console, machine console, heart lung machine console. It is integrated in heart lung machine console. Thank you for this opportunity.
It is nice imagination, I should say that. There is a nice imagination about this perfusion using AI. Definitely, no country is using AI. It is absolutely wrong information which you got it. And AI, nobody, the last time when we in a national conference, there was a debate whether the AI going to replace the perfusionist or not. Absolutely no. The perfusionist job, first of all, see how the AI should work. The AI will work depends on feeding our data. See, it is nothing that is not God, somebody is coming out and working. Whichever we feed the data, are basic on this analyzation, and then it works. Like now, there's all the robotic people who taking input. Now the cardiac surgery, where the research, these things are happening. Now only the cardiac surgeon and how they does, how the hands are going for a mitral valve, how the hand moves are going on, and mitral valve or aortic valve or any, because all the Da Vinci machines are internet connected to the America. Whatever the sold in India, they're connected to the India. They keep observing what we do in a robotic. These data are knowingly or unknowingly, it is passed it on to that main sector where the Da Vinci's office are there. So there, based on that, they will analyze, and future there may be a possibility the AI can do the cardiac surgery. But perfusion job, I don't think any AI can come, because there is no data-driven system in our system. Nobody now across global, nobody in a foreign country they may doing digital data saving only digitally they save it, and that because of the lot of there's legal issues, because of that reason they'll save it. But India, I don't think anybody are doing digital saving or digitally we are doing a data collection or not. And then we are all doing it in the paper record only. So based on this, when you do all the records, we don't have any data to feed in the system to analyze to make AI to work. So I don't think for another 20 years or another 40 years, perfusionist cannot be replaced by the AI, but possibility is a surgeon. Surgeon can be replaced by AI, other purpose, but perfusion, I don't think so.
No,
Thank
sir.
you.
A is the mind, sir.
Hmm.
Heart lung machine is the body, sir.
Okay.
But perfusion is the heartbeat, sir.
Oh, that may be a silent way.
Wonderful.
Right? Without perfusionist, the cardiac surgery will not happen, sir. A is a tool that support and guide the perfusionist to alert, sir, and reduce the stress for the perfusionist, sir.
So this is true reasonably for anything. Say AI will be of use to the doctors and the medical field. So first field, that is everybody is feeling insecure about AI and whether there will be, or there's the debate goes everywhere. The thing is, so it's very unlikely to happen, because the human brain cannot be so easily replaced. The human brain is clearly superior. It cannot be so easily replaced. So that's what I told you before. What is in the vessel will come in the spoon. What you feed will be taken by AI. See, yesterday somebody asked me whether you can sing a song. So I was searching. I know only 2 words. It's Vishnuvardhan movie. I don't know Kannada. So there's one Sanketa word. I have been searching for 6 hours. I got to see all the songs except the song I was looking for. That's the power of AI.
Sir, you can sing, sir. You can sing a song, please, for us, for the audience. You're welcome, sir.
Finally, madam only picked up the. Finally, I called up. Ended up calling up anatomy HOD of BMC. She was my senior. I felt a little bit difficult in the night to call her. She would have thought Friday night, what the hell happened for this man? Why he is calling at this time? Then I messaged her. Then she sent me, this is the song you're looking for. So I'm just giving you an example. If you want, you can see my WhatsApp.
Yes, sir. Thank you so much. Thank you so much, Balambiga. And I would also like to add a point here. When the topic comes to AI, always remember one point. AI is also created by human mind. So human mind cannot be ruled by AI. The next poster is by Asra A from Sridevi Institute of Allied Health Sciences, Tumkur, on the topic of intravascular lithotripsy. Welcome, Asra. Time starts now.
Good evening, everyone. My name is Asra Azmat, third year BSc CCT student, Sridevi Institute of Allied Health Sciences. What if I told you the technology used to break the kidney stones can also be used in blood vessels? That's intravascular lithotripsy, a novel approach treating heavily calcified lesions. Calcification is a major risk in coronary as well as peripheral interventions. It increases the risk of complications such as rupture, dissection, and under expansion of a stent. The traditional methods such as atherectomy and high pressure balloons can increase the complications like vessel rupture, dissection, and also peripheral embolization, distal embolization, sorry. So let's understand the procedure. In intravascular lithotripsy, there is a IVL balloon with emitters which generates acoustic shock waves which fractures the calcium, so makes it easier to expand a stent. Let's understand the procedure in steps. So first we'll cross the lesion with a guide wire, then a balloon is inflated with a small pressure of 4 atmospheres so that the balloon is in contact with the lesion, and after that the shock waves are delivered. Around 20 to 80 rounds of shock waves are delivered based on the severity of the calcifications. Next, we'll re-inflate the balloon so that it widens up the lumen of the artery to place a stent. The stent placement is confirmed by IVUS and OCT. So the clinical trials performed by Disrupt CAD from 2019 to 23 shows 90% of success rate with low MACE rates. MACE rates means major adverse cardiovascular events like sudden death and stroke that occurs in 30 days of duration. The advantages is we can opt this procedure in a heavily calcified lesions where we cannot perform a PCI, like using a high pressure balloon, and it reduces the risk like vessel perforation, dissection, embolization, and it increases the success rate. The limitations are this procedure is a bit costly, which costs around 4 lakh, and it's not available in all cath labs. And if the lesion is very tortuous and tight, we have to opt for a new technique that is rotatripsy, where we combine two methods, rotablation plus intravascular lithotripsy. In conclusion, I would say that intravascular lithotripsy is a transformational technology which is simple, effective, and which is useful in complex interventions. Thank you.
No, well said. Now IVL has now replaced. Now people don't understand that your rotablation or everything, atherectomy, all the atherectomy devices. Somebody was presenting orbital atherectomy as well. All these things came much earlier than stent. These things were development in the 80s actually, including the present orbital atherectomy. They were 80s, but they had more complications, perforation, everything. After that stent came, then they were added on to it. Now IVL is almost the after stronger balloons. This is going to be the simple. It's the usage is very simple and it's safe. But here there is one big irony. The biggest irony is the first man. So somebody told William Fossman who put catheter. So you know the history of cardiac catheterization. Most of you would have studied. He was a German actually, German cardiologist. What he did was he put a Foley's catheter in his own body to show that cardiac catheterization is safe. Nobody believed. What he did was he inserted a Foley's catheters in his own forearm inside the heart. He walked one floor down, took an X-ray and showed that the catheter can be placed in the heart. You know what was done? He was dismissed. He was dismissed and transferred to, you want to put catheter, so he was transferred to urology actually. He worked in urology for the rest of his life. His son developed lithotripsy. Now lithotripsy is coming to coronary again. You see the world is one big round. The world is one big round. You understand what I say? Fossman developed cardiac catheterization by risking himself, putting the catheter inside his own heart and taking an X-ray. He was dismissed, taken out for on ethical grounds, sent to urology during World War. Rest of his life he was a urologist. Of course, eventually he won a Nobel Prize after his death only. He was given a Nobel Prize after his death posthumously. His son he's the one who developed the kidney stone breaking technology called lithotripsy. Now the lithotripsy is again coming into the coronary. So it's a big circle life.
Thank you, Asra. Thank you so much. Now, I would like to welcome Elipe Manasa from Sridevi Institute of Allied Health Sciences, Tumkur, on the topic veno-arterial extracorporeal membrane oxygenation. Welcome, Elipe Manasa. Your time starts now.
Good evening, everyone. Myself, Felipe Manasa from BSc Third Year Perfusion Technology of Sridevi. Everything has end in this world, but not the technology, not the science, mainly certainly not to this medicine. So amongst the great advancements, VA ECMO is one of those. So when you look after this abstract, I have chosen this extracorporeal circulation because as a perfusionist, not only the role in CPP, but we can also have a role in extracorporeal membrane oxygenation. So ECC, which mainly defines that which we are doing outside the body. So when to save and bring back the heart, when the heart and lungs are no longer to take the burden, VA ECMO is one of those which brings the bridge, which be a bridge to the recovery. So when coming to the introduction, the concept of the ECMO is simple, but the procedure will be complex. The first ECMO was done in the year of 1972 in an adult with traumatic aortic rupture. We know arterial ECMO, which provides the hemodynamic stability and also the pulmonary rest, which is mainly done in cardiogenic shock, cardiac arrest, and a bridge to recovery and transplant. So when we look after this methodology, when you look after these methods, how it is performed. The technique involves the drainage of the deoxygenated blood through a large bone venous cannula, and it goes through membrane oxygenator. After oxygenation and also the CO2 removal, it will be sending the oxygenated blood back to this patient. This mainly involves the patient selection, cannulation, circuit, initiation, monitoring, and weaning. Patient selection, which mainly depends upon the indications and contraindications. Indications which mainly we can see for the cardiogenic shock, cardiac arrest, graft failure, or if the patient is unable to come off from the bypass, or ejection fraction if it is less than 30%, or severe LV dysfunction, or biventricular failure. So even we bring back the therapies, but still we lack in drawbacks. So the contraindications that the patients who are not able to be on a VA ECMO is the peripheral vascular disease, aortic regurgitation, aortic dissection, encephalopathy, or encephalopathy, and the organ failure. When coming to the cannulation techniques, so we'll have three types of cannulation techniques: peripheral cannulation, central cannulation, and the hybrid cannulation. Peripheral cannulation, which is most common when go for the femoral artery and femoral vein. We also have the limb perfusion cannula, and central cannulation, which mainly will go for right atrium and ascending aorta, and hybrid techniques, which mainly includes axillary artery cannulation, subclavian, carotid, or IJV. When coming to the circuit, which mainly consisting of the pump, console, oxygenator, gas lines, hemotherm, and initiation, we have to prime the circuit, we have to de-air the circuit, connect the gas lines, and next monitoring, mainly monitoring of heart rate, mean arterial pressure, central venous pressure, flows, temperature, ABG values, which indicates the lactate, pH, and the partial pressure of oxygen, carbon dioxide. And mostly we have to go for the echo findings of the LA, LV function. And we have to go for chest X-ray, PT, APTT, and NIRS and urine output. When weaning, next coming to the weaning, we have to reduce the flows. If the consideration of weaning trial is the phenotype of the patient, it is compatible to this recovery, then we can go for weaning trial. That is, we can reduce the flows to 0.5 liters per minute. If he is tolerating, we can go to 2 liters per minute. After checking 8 to 24 hours, we can go for, and next comes perfusion role. Perfusion is the one who assembles, who initiates, and he brings up the safety in the patient. And in results, what we have in axillary cannulation, we can have the ablation, that is less stay in ICU, and mortality will be good. And conclusion, that is VA ECMO increases number of clinical sites, and we have to be profound in hemodynamic stability. Thank you.
Thank you, Manasa.
That was well presented, actually. So what do you mean by bridge to life?
Bridge, sir, actually heart is the main organ. So heart can go to the very extent, it can bring up to many more resistance to save. But what if the heart is unable to take the burden? So that the patient might lose the hope. But we are bringing the another therapy, that
No,
is
actually,
VA.
ECMO is not a treatment.
It is
ECMO is a support.
Support.
ECMO is a support system. It can bridge the patient to recovery, or it can bridge to transplant, or only these two options are practically available. I am talking about VA ECMO. Either the patient goes to a transplant or recovers. Those things, for example, say myocarditis, a child with a myocarditis. So there is a chance that the heart will recover on its own. So there you support the heart till the heart recovers. That's called bridge to
life.
recovery. Another kind is dilated cardiomyopathy or something, burnt out heart. Those people won't survive. So you put them, then you have to wait till transplant is available. For example, we put a patient on VV ECMO. The patient was our staff's husband, very poor family. We maintained him for 47 days. 47 days we maintained him on VV ECMO. We could not find a matching, lung transplant is not that successful as a heart transplant. The match won't be really very great. Eventually we had to decannulate him electively, allow him to die. So that's an open end on the other side. You understand what I say? It was painful because on ECMO he was very nice. You understand what I say?
Yes.
The lung is completely destroyed, totally destroyed. Old TB completely destroyed. So electively we had to decannulate and allow him to die because we could not find the lung anymore. Because if you are prolonging that, there will be complications of ECMO, bleeding in the brain. The famous singer SPB died of ICH in ECMO, intracerebral hemorrhage. He was pretty fine. He recovered. But what happened was, because of anticoagulation management, he developed intracerebral bleed. He died eventually. So you have to be careful.
And the indication you have said, nowadays the ECMOs are used for the snake bite. They're more in the yeah. That is also would have nowadays many people are using for the snake bite, where the poison snake within certain time that will insert the ECMO and we could able to save the patients. And I recently, not recently, I come across many ECMOs, which is my remembrance that one patient who's fallen on oil, the Goa, there is oil, Indian oil, he has fallen on oil chamber and he swallowed a lot of oil, he could not able to breathe. Though they airlifted to Apollo Hospital, and then we put a AV arterial vein bypass only, VA ECMO only, and we have maintained only during removing oil, and then we have supported for 1 day, and we could able to save his life actually. And this is a very interesting thing which we when I come across during this ECMO.
So these are the novel indications of ECMO. One bursting indication of ECMO is what is called eCPR. Heard of something called eCPR?
Yes.
So eCPR is ECMO CPR, where you do CPR. So that is one indication where it will be decentralized. So that is one area where perfusionists will be extremely not limited to cardiac theater, but to the emergency department, where recoverable cardiac arrest, you put them on ECMO till they recover and they come out well. For example, the kind of novel indications he is saying, one is sulfas poisoning. Sulfas poisoning, ECMO is highly used. Snake bite, we have used on sulfas poisoning. We have not used on snake bite, but snake bite it is being used. Most commonly thing we use is perioperative peri-PCI coverage. Peri-PCI coverage. So for left main stenting, from left main to LAD, it's a high risk procedure. Those are generally bypass surgery cases, but an acute MI where the LAD is totally cut off, we have to take a risk and put it. I preemptively place them on ECMO and then do the procedure. So these are the indications for it. And this lasts only for 6 hours or 8 hours, then we decannulate and come out.
No, there is one more condition where we use it is nowadays. As a cardiologist, I just wanted to think there is a cath lab also for the transcatheter aortic valve replacement, where you do the transcatheter, remove the valve in all, and the aortic valve will be there, and the valve we put a new valve in valve. That condition of situation where we insert the ECMO and support the patient in ECMO, then they do very, without any problem, they can do the procedure, and then they can remove the ECMO for 24 hours of support. These are a lot of the ECMO has become especially in the COVID time, the ECMO only given a lot of people life, sir. And as we are as a perfusionist, we were on the hospital shifting from Jayanagar Apollo to Banarghatta Apollo. We've been putting ECMO so much, and with the scary situation of COVID time. Interesting, the nostalgic feeling when I talk about the ECMO. Really, it is interesting things. Thank you. Thank you for nice presentation.
Thank you, Manasa. I'm coming here again for 1 minute talk. It's about we have only remained with 2 posters. So here you have to pay more attention because this is ending of your gaining knowledge session. So here you pay attention for the fonts, size, everything. And also one request for all the poster presentation and abstract submitted students, there are 63 presentations. So I would like to tell you one line that kindly publish your posters if they are genuine so that your knowledge is not wasted. You can publish in any of the international journals or Indian publication papers or articles so that your paper and journal just don't go to dustbin. So kindly try to publish your papers, check plagiarism, all these procedures you have to do so that the next future scope can develop from those papers. This is my humble request. Now I would like to call Sania from Sridevi Institute of Allied Health Sciences, Tumkur, for the topic xeno transplantation and pig heart transplant. Please start.
Good evening,
Time starts.
Good evening, everyone. Myself, Sania, from the Department of Perfusion Technology, Sridevi Institute of Allied Health Science, Tumkur. Today, I am presenting on the topic xenotransplantation and pig heart transplantation. Xenotransplantation is the process of transplanting living cells, tissues, or organ from one species to another. Aim is to provide sustainable and alternative sources of organs, tissues, or cells from the animals, especially pigs, for transplanting into humans. So a donor pig is selected from which the genetical modification genetical modification will be done. That is the pig genes which attack immune humans are human immune system is removed, and then the human genes are inserted. That is the genetical modification. Then the transplantation occurs into the recipient. So why pigs are used? Because they are anatomically and physiological similarities to humans and easier breeding and availability, ethical acceptance compared to primates. So advantages are that it addresses organ shortage, potentially unlimited supply, lower cost compared to long-term mechanical support. Challenges: immune rejection, risk of zoonotic infection, long-term graft survival under study. That is the first genetically modified pig heart transplantation was done in 2022, and the patient survived for 2 months. Then later the second transplant was done in 2023, and the patient survived for only 6 weeks. So the study is still undergoing. Conclusion: xenotransplantation, especially the pig heart transplantation, offers the revolutionary solution for the organ shortage crisis. It may soon become standard life-saving therapy for the patients with the organ failure. Thank you.
Xenotransplant, I'm not really very sure, but you're saying 2 case reports, quite interesting. Because first thing that was done, that were done for xenografts only. First transplants that were conducted in human body was xenotransplants, but they failed because of severe immune reactions.
Rejection.
But let's see, you are saying 2 case reports, 2 months survival, is it?
Yes.
There was a case
due to some immune rejection, that the cytomegalovirus infection,
see,
he only survived for 2 months.
No, I have to look it up.
Who's the surgeon,
Sir?
Who's the surgeon?
Dr. Griffith. Dr. Griffith from the University of Maryland.
No, what about in India?
In India.
India? India also that tried once. I remember he is put in jail. He's a cardiac surgeon. He was put in jail. I remember that it was become a big. It was a big issue. 20 years back. I remember that, and it was when Indira Gandhi those days. I think Indira Gandhi time. I'm not sorry. 20 years back. Before that Indira Gandhi time. That is what I read. And one perfusionist was telling me this. And that is what I don't think is possible. It is a very difficult. But whatever.
She's quoting something.
I know. I understand. I completely understand. But definitely, this our innovation comes with this kind of discussion and debates. Definitely, there is nothing no do. No, what I want to do when peak art related to the human art, of course, very much related to the human art. Why I am telling is when you do the robotic training, we do it with the peak art. And it helps us to learn the resemblance. That's why I mean we know very well that. Thank you.
The valves are also from the pig,
Yes.
the porcine processes or the bovine and the porcine processes are highly compatible. But this is new to me. I'll cross check and then.
But the interesting thing I should
that
not.
was quite interesting actually.
I should not say that this what I mean to say when as a perfusionist working in a cardiac theater, there are a lot of patients we get it from Saudi Gulf countries and all. They don't prefer for the valve pig valve, which is some kind of pig valve, because the Muslims, I mean, the religious things that they don't accept pig valves to get into their body. So they use it porcine valve where the cow from the cow. So there's different manufacturer tissue valves are there. But being that, and I think it is proud that she has researched so much and getting into this one. Thank you so much.
Thank you. Now I would like to welcome our last poster presenter, Alia Anjum from Sridevi Institute of Allied Health Science at Tumkur on the topic Perfusion Techniques to Reduce Post-Operative Complications. Welcome, Alia. Time starts now.
Good evening, everyone. Myself, Alia, from second year BSc PFT, Sridevi Institute of Allied Health Sciences. Today, I am going to discuss about perfusion techniques to reduce post-operative complications in cardiac surgeries. As you know, post-operative complications are common after surgeries. That's why we use perfusion strategies to reduce the risk. Goal-directed perfusion, monitor and feedback system. It plays a major role in reducing post-operative complications by enhancing the oxygen delivery, blood flow, temperature, and pressure. Next, optimal perfusion pressure to maintain the adequate blood flow. Normal optimal perfusion pressure range is 50 to 80 mmHg. Next is tailored perfusion to patient's needs. It maintaining the adequate O2 delivery and perfusion pressure according to the patient body surface area, metabolic needs, and surgical requirements. Additional supportive techniques are normothermia. Maintain the patient's body temperature. It used in certain situations instead of hypothermia and hyperthermia because temperature management directly affects the tissue metabolism. Next, hemoadsorption to remove the toxins and inflammatory mediators from the blood. It can act as blood purifier. Coagulation management. It is used to prevent the excessive bleeding and to prevent the thrombosis. The aim to use these techniques is to improve hemodynamic stability and to optimize organ protection, to optimize O2 delivery and metabolic balance. The clinical benefits to use these techniques are reduce complications and organ injury, shorter ICU stay and faster recovery, decrease the risk of neurological events like stroke, maintain blood pressure and body function. In conclusion, I would to say perfusion techniques are essential to reduce post-operative complications and improve patient outcomes. Thank you.
Thank you, Alia.
So what is SIRS? SIRS? Heard of that word? So your BSc or MSc or
BSc.
BSc. So systemic inflammatory response syndrome. So it's an extra, that's common for any extracorporeal circuit. The blood is not flowing inside the body when it taken outside. So that's why we were talking about the CPB time. When they were talking about robotic surgery, they were talking about something called bypass time or CPB time. Longer the CPB time, higher the chances of systemic inflammatory response. All the complications will be increased in a prolonged cardiac surgery. So that's a one.
For that reason, we use a cytosab, but actually, there are a lot of innovation happen during reducing our systemic inflammatory response. Since we use a cardiopulmonary bypass, we use a cytosab. Cytosab is a very expensive one, but which can be reduce all the complementary things absorbed in that filter, and then it goes to the patient. So that time, that even whichever the patient we use it, the post-operative complex very much reduces, and the patient recovery is really much better. And we incorporate with the cardiopulmonary bypass, but it little bit expensive, so we cannot use it for all the patients. Thank you.
Thank you so much, Alia. This was our last presentation. And after this, I would like to tell that until the judges give their final scoring, and I insist all the judges to go back to their respective places. And now we have a photo session, but before that, I would like to hand over the mic to Rajkumar sir. And before that, a small announcement that culturals will be held. So whoever have dance presentations and everything, you can just coordinate with Ruksar ma'am, so that you can check whether your songs, everything in the meanwhile till we decide the prize and the photo session. Cultural team can come back separately. Thank you so much for the scientific e-posters session, and thank you for your attention. I think you have gained little bit of knowledge about e-posters and abstracts presentation. Thank you so much. I would like to give mic to Rajkumar sir.
So as we come to the end of the session, first of all, I would like to thanks our principal sir, Dr. Krishna MC sir, and Dr. Chandrapa sir, vice principal, Sridevi Institute of Allied Health Sciences, from behind me, successing. Actually, we planned for small CME, right, sir? So your cooperation with nothing possible, you can make big, this program. Thanks one and all coming over here from various parts of India. So, and without your faculties cannot possible. I would like to thanks from all the college faculties. Put your hand together. Then last but not least, I would like thanks to our college faculties and all the committee members and finally volunteers who supported me can make this success very big. Thank you, one and all. Then here, I want to say something. I can proudly say here, I started my career in Apex Heart Hospital, working under Dr. Ravi Shankar sir. Sir is here. I am your student, sir. Thank you so much, sir. I'm standing here because of you, sir. Definitely. Thank you so much, sir, your guidance. So we are going to give some best supporter from some colleges, because faculties who had worked hard, who are bringing more students over here for the CME program, for actively participate in the CME program. Like first colleges, I would like to invest SNS College of Allied Health Sciences, Coimbatore, 51 students and 3 members of faculties. Please come to the dais for photo session. SNS colleges and faculty members, please come to the dais for photo session. Chandrapa sir and Krishna sir, please come to the dais, sir. Please come to the dais, Dr. Ravishankar sir, Mr. Senthil sir, Palya sir. Next, I would like to invite Negru Group of Institutions Coimbatore. Come to the dais, all faculty members and all students. So Negru College who bringing 39 students over here and 4 faculty members. Please come to the stage first. Dr. Satish sir, please come to stage, sir. Dr. Satish sir.
Kindly listen here. Kindly pay attention. Students, please listen. For the culturals, the sequence is solo Saraswati from Sridevi College, solo dance by SNS, Tejaswini and group Sridevi, solo dance by Joshna, group dance by SNS, Devika and team by Sridevi. Other than this, we are not taking anyone, so kindly be in this order.
Nehru College faculty members, please come to stage.
Nehru College, Coimbatore, they conducts annually intercollegiate cultural as well as sports. So other colleges, please join with Nehru College in the next year program.
Next, I would like to invite Siddhartha Medical College, Tumkur. Please come to stage. Siddhartha Medical College and along with faculty members. Kind attention, all the faculty members. Once ensure the certificate whether it is correct or not and check count also. Next, I would like to invite Wales University from Chennai. 41 students coming over here along with 3 faculty members. Please come to the dais. Please put a hand on together. Please put hand together. Next, I would like to invite Steve Venkateshwara, Institute of Allied Health Sciences, E-Road, all faculty members. Around 42 students coming over here along with 5 faculty members. Please come to the dais.
After the photo session, please don't go. We have culturals and prize distribution event. Kindly go back to your seats and occupy it.
Next, I request MVM College of Allied Health Sciences, Bangalore. 27 students coming here along with 2 faculties. Come to the dais. So I repeat, MVM College of Allied Health Sciences, come to the stage. Next, I would like to invite Yenipoya University from Bangalore. Please come to the dais. Next, I would like to invite Mahatma Gandhi Medical College from Pondicherry. Please come to the dais. Next, finally, I would like to invite Senthil sir team, Apollo team from Bengaluru. Come to the dais. Apollo Banargata Road, Bengaluru. Apollo Hospital, Banargata Road, Bengaluru.